72 hours during the stressor response, it makes sense to give a short dose of insulin. For daycare surgery, we start when they resume oral feeds. Keep the blood sugar less than 180. If it's high, you may temporarily use insulin. Minor procedures who are already on insulin, I think keep them as the first in the list. Early morning procedure. You can skip the insulin till the procedure is done and the patient is resuming his late breakfast or an early lunch. For procedures which are planned in the latter half of the day, I think you can give one half of the basal insulin cover and thereafter check the blood sugars post-operatively and treat it with rapid-acting insulin. For all elective major surgeries, I think it makes prudence to stop oral agents, shift to basal bolus insulin therapy. On the night prior to the surgery, ensure that you give basal insulin and do not skip basal insulin on the night before, and see that the fasting is no greater than 6 hours. This is an important slide here, is that generally most surgical teams are habituated to using only ringalactate and normal saline and fasting the patient. What is important is that in a hypercatabolic state that ensues a surgery, they need a minimum, every subject needs a minimum of 150 to 200 grams of glucose per day. Your 500 ml of DNS solution has 5 grams for every 100 ml. That's only 25 grams. And 5 bottles in one day gives you only 125. That's no more than 500 calories. So don't starve the patient. You'll be pushing him into ketosis. The best way to give insulin is to do the variable insulin infusion rate using a syringe infusion. I've purposely not spoken about the GIK protocol because it's not done anywhere. So use the syringe infusion pump in 50 ml of normal saline. You can add 50 units of rapid-acting or short-acting insulin, never premixed, never basal insulins. Add the rapid-acting analogs or short-acting insulin, and every ml will give you 1 unit. You want to give 2 units per hour, give 100 units, and then, as the case may be, IV insulin does not have an action greater than 5 minutes. So the moment there is a risk of hypoglycemia, stop the infusion and you don't have hypo. Commonly what we prefer to do is the dual back paradigm. On the one IV line we give the syringe infusion pump with insulin, and the other, once the blood sugar falls below 200, we shift to a dextrose containing solution. Before that it's normal saline. Monitor the blood sugar every 2 hours, keep it around 180. Urine sugar has no role to play, but urine ketones, yes. This is 2 scenarios here for you. You have a blood sugar of 100 and the ketones positive. It's probably euglycemic ketoacidosis because of not stopping the SGLT2, but more commonly it's because there is insufficient dextrose. It's a case of starvation. Give more glucose, give more insulin, and adequate hydration. The second scenario, there is hyperglycemia. So it's hyperglycemic ketosis. Here you need to step up the dosage of insulin and bring the blood glucose to around 180. Where you need more insulin, whenever there is an infection, where you're using corticosteroids, which is very common in a neurosurgical post-op ward. During CABG, the dead space that is created by the bypass machine can sequester a lot of glucose. Hypothermia that follows can also cause insulin resistance, and if infected foot ulcer or a caries tooth. And when the insulin requirements will fall is once you let out the pus, remove the decayed tooth, or a woman who's pregnant, the moment the placenta is delivered, the placenta is a diabetogenic endocrine organ. So the moment the placenta is removed, the blood sugars will begin to fall. You will have to reduce the dosage of insulin by more than half. As I said, the fluid that we like to use is normal saline till the blood sugars come down to below about 200, then shift to IV dextrose. But we've been classically been taught to use isolate M, which is known as plasma-lightly, the balanced crystalloids, because of the fact that they're a good source of potassium. Please do not use ringer lactate because people think that ringer lactate is safe. When you use more than 1 or 2 units of ringer lactate, simply the lactate is going to go into the Cori cycle and then being converted into glucose. IV insulin always transports the glucose and the potassium into the cell. So hypokalemia is the rule. Monitor the potassium every 4th hourly, and if you don't have the luxury of monitoring electrolytes, simple, instead of using DNS, use Isolate-M, which already has enough potassium. Even then, I think it's prudent to monitor the potassium at least 2 times a day. When do you shift back to oral agents? Well, when the patient is able to hold back oral feeds and there is no emesis. I don't think there is a place for CGMS because there is a time lag between the interstitial glucose and the capillary glucose. So I think CGMS is more for chronic care rather than during the perioperative periods. So now we have an emergency-like situation, a road traffic accident. There is a fracture of the femur. You cannot keep the patient for long, and the patient has come to you with ketoacidosis. Simple. Get him out of shock. Give him adequate fluids. Give him adequate pressors. Get him out of shock. Give him intravenous insulin. See that the general condition stabilizes. He's out of shock. That is very important. When there is more hemodynamic stability, I think you don't have to wait for the blood sugars to come down. You can send the patient into the theater and manage post-operatively. So I think I'll stop short here, saying that it's very simple. You need a thorough pre-op assessment. Intra-op, I think IV insulin has changed the way we look at perioperative management, and post-operatively, I think it's easy to get back. Once the emesis stops, it's easy to get back the patient onto his feet and get back to the old oral anti-diabetic agents or insulin, as the case may be. Thank you so much for a very patient hearing.
Thank you. Thank you, Dr. Deepak, for finishing before time. Anyone, any questions? We can have a couple of questions for him. It's a very important topic, very well covered. Because there's always a confusion and a misunderstanding between surgeons.
I think while selecting the IV fluids post-operatively, or intraoperatively as well, I think lactate solution is better avoided. That's a very important aspect.
I said that. Ringalactate, the Cori cycle, I put that slide.
So no questions. Yep. No, he wants to leave actually, so. We are checking if you have any questions on WhatsApp for him. Yeah, thank you.
Thank
Big
you,
round of
thank you
applause
so
for
much.
Dr. Deepak. Thank you. Yeah. There is one question which has come up. Is there any type of insulin to be avoided in diabetic patients during surgeries?
See, the best thing is to go in for basal bolus insulin therapy. These pre-mixed, basically, I'm not in favor of them. Each one has their own way of managing patients, but at least in the perioperative period, better to use 3 doses of rapid-acting insulin or short-acting insulin and basal insulin cover. That's the safest, that is physiological mimicry. So I'm comfortable doing that. I think if you adopt that method, you'll find it very easy. The only insulin which you should not use, as I already mentioned, in the syringe infusion pump, there is no place for pre-mixed insulins, there's no place for basal insulins. It's only short-acting insulin or rapid-acting analogs.
Thank you, sir.
Dr.
Now
Deepak,
I
can you please
request
come? Yeah,
Dr. Rajesh Keshwan to felicitate Dr. MC Deepak.
Yep.
Thank you, sir.
Thank you.
We'll now continue with the session.
Yep. It's my pleasure to invite Dr. G. Vijay Kumar. He's going to talk on breaking through insulin initiation barriers with premixes.
Good morning to everybody. My special thanks to Dr. R.K. for giving this opportunity, and also my good friend Vinay Dandania. Now, to what Dr. Deepak has spoken, I think a continuation to that. He was very particularly talking about initiating insulin therapy in a wound care or in a hospitalized patients. So I'm just going through some practical things like how to breaking through the insulin initiation and some of the clinical pearls that we can do. This talk has been sponsored by CIPLA. If you look into that, I think to a certain extent, Dr. Deepak has already spoken about this, why acute illness can cause hyperglycemia and hyperglycemia can cause acute illness. It's a vicious cycle, if you could see that. If you look into that, in any acute illness, there will be increased hormone levels, especially the cortisols and epinephrine levels will be higher. And also, there is a decreased level of physical activity. So these are the few things that can increase the hyperglycemia in a diabetic patient. And there are many situations there where the newly detected diabetic can happen during admission for sepsis as well. And once you have a hyperglycemia, whether newly detected or earlier known diabetic or pre-diabetic, that can hyperglycemia can decrease the immune function, decreased wound healing, that's the most important thing, increased oxidative stress, and endothelial dysfunction and pro-inflammatory action that will be there. So endothelial dysfunction is a very, very important thing because endothelial dysfunction will reduce the nitric oxide levels, and then also this inflammation will be there, and the oxidative stress also will increase, which will impair again the wound healing again when you are doing it. Now, the usual targets, Dr. Deepak has already shown that suppose somebody is admitted in the wards, what you need to keep is keep the blood sugar fasting less than 120 approximately, and in any time it should not cross 180. Whereas in critically ill patient, you keep it around 140 to 180 so that you avoid hypoglycemia. Infusion is the best thing, as Dr. Deepak has already said. Now, why insulin, especially for wound healing? You can always say that my blood sugar is under good control, and then you have oral drugs that are already there, and why should I start insulin? So the insulin has got a wound healing effect. So it's a potential therapeutic agent for improving wound healing, especially in diabetic conditions. So what the way it promotes wound healing is there several mechanisms, at least 4 can be identified here. And enhancing macrophage activity, there's a better pathogen clearance and increased oxidative stress killing. And regulating gene expression, which improves the repair-related genes and as well as immune genes. See, this is very important actually, we don't realize it actually. And also activating the pathways such as endocytosis, it improves cellular uptake and wound closure. And immune-related pathways regulates inflammation as well. So once you have inflammation is reduced, wound healing also is going to be faster. So, and also it creates a very good microenvironment in the wound. It supports bone tissue healing and balances inflammation and repair. But mind you that there is no role for local insulin in the wound. There is no role in it. It's only systematic. Now we have spoken so much about that, how it works and all. And then if you look into the evidence that you have, how insulin can improve, this is one study which is done about 185 patients with 107 diabetic foot ulcers. And then if you can see that those people who have been on insulin, the healing rate was 30.3% healed. And in a non-insulin group, it is only 9.8%. It's almost 3 times better healing capacity when you use insulin for whenever somebody is got a wound infection. Now, if you look into this number of insulins, remember Dr. Deepak has told that only insulin is the only thing that has been there, especially wound infections are very, very bad infections that have been there. Not for, I'm talking about this for trophic ulcers or anything like that. Anybody who's got infected wound and cellulitis is there, and especially when they're admitted, you have various insulins. Now, there is one question related to what insulin to be used. Now, before that, what insulin to be used, you should know what are the insulins that are available. If you see that, there are insulin, short-acting insulin logs and long-acting insulin logs. These are the ones which we usually use, where you can see the short-acting insulin logs are aspart, lispro, and glulysin, which starts acting the moment you give injection. It will start acting in 15 minutes and goes for 3 to 4 hours. And then it goes down within 4 to 5 hours, the action is over. So it very well suits the postprandial blood glucose that can happen. Whereas if you look into that glargine and degludec, which we call it as basal insulin analogs, these are the most used one actually in the hospital as well. where it works for 24 hours. The moment you give injection, starts working in 2 hours and continues till 24 hours. So this is called basal insulin. And this is bolus insulin. So these are the two varieties. And to just more to look into that, how it acts, you can see that the one in blue, you can see that the regular insulin, what we use like Actrapid, human insulin and all, they have a different, what do you say that, what we have a profile of thing that because it works late and also go to the peak a bit late, it doesn't match the postprandial blood glucose. So that what you have is that you have a high postprandial blood glucose and in between meal hyperglycemia can be there. So going for insulin which is physiologically acting is the best thing that to do. We can do that. So whenever we talk about basal bolus therapy, whenever somebody is admitted, please indicate only basal bolus therapy, nothing else. Basal bolus therapy, as I said, that basal insulin which works for 24 hours, it reduces hepatic glucose output. It also ensures that prandial also the glucose will come down, and then we can have bolus insulin with the food. So that is called as prandial insulin, which is we talk about the analogs, short-acting analogs. Sometimes you need to give one more injection as a correction therapy. That's one thing. Now, how do you calculate it? You just take about 0.4 units per kg body weight. It's about 0.3 to 0.4, depending on the blood glucose, depending on the amount of infection that you have. You can go up to 0.4 units per kg body weight and calculate the amount of the body weight, and then you divide into half. Half should be given as a basal insulin, and the rest of the 50% of the insulin divide into 3 with you along with the feeds. So this is how, it's a very simple way of looking into how to calculate a basal insulin therapy. Okay? So this is very, very simple. 0.3, suppose blood sugars are normal, you can go for 0.2 to 0.3 also. Suppose the blood sugars are high and infection is very high, cellulite is very bad, then you can go for 0.4 units per kg body weight. And this is how it looks. This is more physiological. When you give a basal bolus therapy, you can see that this is what happens. In a normal physiologically, even in a non-diabetic, there will be basal insulin which covers the hepatic glucose output, and with every food that you take, there will be one spike of insulin that is released. And basal bolus therapy is the best because it mimics the normal physiological insulin. That's the reason. Now, a lot of people go for a, the sliding scale. Please don't do that. It is not a good option, not an option. You should have proactive. That's why basal bolus therapy. You should know what is happening in the previous blood sugar, how much of insulin is given, how much it is coming down, and all these things you should be kept in mind. And as nurse calls on the phone, we have to tell accordingly. You should find out what is the level that happened even earlier. Even NABH says that the only phone instruction that is accepted without writing is insulin dose on the phone by the nurse, nothing else. This is how we can see that this is Ompires. You can see that rabbit trial. You can see that compared to going for a sliding scale on the top, you can see that when you have a proactive, not using a sliding scale, you have better glycemic control. And then as far as the drugs are concerned, depends on what is the situation and what is the situation that you can see that. And then you can see that metformin, if there is no contraindication, can be continued. But only thing is that when you are giving IV contrast or anything else, better avoid it. But DPP-4 inhibitors are the ones which are very safe and can be given without effect. But otherwise, TZD, sulfonylurea, alpha-glucose inhibitor, GLP-1 receptor analogs have got no role in during therapy for when they are admitted. Now, this is about the in-hospital management happening actually. And then as far as that, suppose the patient has come out of the hospital and then we need to start giving insulin. But in general, to avoid wound infections and improve the wound infection, those who are not admitted, the problem what you are facing is that in India, when the time when you start insulin, it is about 9.4. Until fasting blood glucose is almost close to 200, we don't start insulin, which is very, very late. And it is also said that in the surveys in India said that there is a 7-year delay in starting insulin, which can cause prolonged hyperglycemia, can increase the blindness and renal failure and also amputation. So let us start insulin as soon as possible, and also it can cause micro and macrovascular complications as well. Now, why it is happening? Why is it happening is that the misconceptions. The patient from the sense it's a stigma for them. They think they have personally failure. They don't understand that it is not their failure, but it is a failure of the beta cells that require to make them take insulin. So this is very, very important thing. And then cultural beliefs, religious beliefs are also make them not to take insulin at all. And from the physician point of time, there is an insulin. We have insulin resistance. We have also resisting insulin for a patient. This is also happens because basically it's not that they don't want to, but probably they are not trained well, number one. Number 10, they're worried about the weight gain and hypoglycemia that can happen, but appropriate usage can reduce these problems. And then also the time consumption to educate is a problem. So that educator, they don't have an educator or a nurse who is trained in telling them how to take insulin. And now what happens is that we have a specific problem, is a postprandial hyperglycemia. It is generally said that when HbA1c is very high, only fasting blood glucose will be there higher and then postprandial will not be there. But as the HbA1c comes down, it is more. But this is in the Caucasian population. For Indian population, even at higher HbA1c, there is a role, there is an increase both postprandial and fasting blood glucose, and it comes, as it comes down to less than 8 HbA1c, postprandial will take over the fasting blood glucose. This is because the problem that we are having, the way we take the diet, high carb diet all over India, anything, you can see that. So that is the reason we have more postprandial hyperglycemia. So we can have in a patient have premixed insulin, which is a combination of short-acting analog with intermediate-acting insulin, which works both as a bolus insulin combined with a basal insulin. That's what we can do that. And with a single pen, we can use this, and then easy to do that. And we can start it once a day. If necessary, we can make it 2 times a day and even 3 times a day. Whereas basal bolus therapy in practice, after the admission is over, it is very difficult unless you are too motivated. 4 injections is not enough. And then other ends of the prescription happens only when you make it simple insulin regimen, and the effort that has to be taken by the patient should be minimized, so that if we can make it 1 or 2 doses, the other ends of the prescription will be better. And that's where, especially in Indian conditions, you can have postprandial blood glucose is the most important thing. And then, as I said, that it combines rapid and intermediate acting insulins effectively, so it controls both fasting and postprandial. You can give either once, depending on the blood glucose, or twice you can give it. And there are several mixes. We can have 25% of the short-acting, 70% intermediate-acting, or 50% short-acting and 50% intermediate-acting. This is where we can see that according to the postprandial blood glucose, you can have a mix, because the short-acting component addresses the postprandial better. So depending on your blood glucose postprandial compared to fasting, you can decide about 25% or 50% of the short-acting analog. So we can see that premixed insulin is a very good, viable and more practical choice, where you can see that start with 1 and go in 2, and if most often 2 injections are more than sufficient. Similarly, we can see that guidelines, usually in a Caucasian population, like what we have seen in ADA, you could see that they start with a basal insulin. Only for intensification, they go for premixed insulin. 2 more slides. And then whereas if you see that IDF insulin, this works only for the whole world. You can see that the choice is premixed insulin along with the basal insulin is there. And similarly, if you can see that RSSI guideline recommendation, we have either, depending on the blood glucose levels, you have to either go for basal insulin or for premixed insulin. So I think in India, we have India-specific insulin regimens which are required, and where premixed insulins are going to be very good actually. So in the last slide, friends, let me conclude to say that it should be simple to understand for the patient, and fewer injections, and then less frequent monitoring is needed. And then it is also physician friendly to address the teaching to the patient also by having one simple. Thank you for patient hearing.
Thank you. Can I request everyone to please share their questions and suggestions in WhatsApp? Please write your name and mention your queries so that we can take all the questions in the end. Thank you. So can I invite Dr. A. Shanmugam for presenting his talk on continuous glucose monitoring. It's again a very, very important topic and very, very useful in day-to-day practice.
morning, everyone. I'd like to thank Dr. RK and the entire team of RK for giving me this opportunity. I thank the chairperson also. I'm going to talk on another 15 minutes. I'm going to discuss about continuous glucose monitoring. It's a new tool we do use in our day-to-day diabetic practice. We know that Holter's monitors, which monitors ECG. We know that ambulatory blood pressure monitor, which monitors 24 hours blood pressure. This is a tool which will monitor the sugar 24/7 for almost 7 days to 14 days depending upon the model we are using. This is continuous glucose monitoring. It measures sugar in the interstitial fluid and it works for 24/7. Many agents will work for 2 weeks. There is a sensor inside. The sensor became the small microtubule is there. Because of small microtubule, the sugar, the interstitial fluid will be absorbed. It will assess the sugar levels, and every 3 to 4 minutes, depending upon the model, the sugar will be assessed. And this is the data we are going to get. This is almost for every day, 24/7. What was the sugar levels for each day? There is each different colors has been given. So putting all together, it is very difficult to understand. If you see multiple colors in multiple variations, it is very difficult to understand which time blood sugar is going up, which time blood sugar is coming down. And each and every day also we can able to see it independently. But this is altogether 2 weeks blood sugar levels. You can putting all together, which we call it as ambulatory glucose profile. This is what the same patients, this is all the ambulatory blood glucose profile starts with midnight 12 o'clock, and every 2 hours there will be stand will be there. 2 hours, 4 hours, this is 6 hours, 8 hours, this is afternoon 12 hours, this is evening 6 hours, this is midnight again. So if you see here, these patients, any value in between 70 to 180 shown as the green. This is the target range we want. So any value more than 180 to 250 shown as orange, more than 250 shown as red. This is most dangerous area. So values less than 70 shown as hypoglycemia, less than 54 is very severe hypoglycemia. So by seeing single curve, we can able to see that whether this patient had any episode of hypoglycemia over a period of 2 weeks. This patient doesn't had any episode of hyperglycemia, but only a part of time he had a good glycemic control. Only in the fasting time he had good glycemic control. If you do the fasting, almost roughly 120 to 130. Average fasting for this patient will be 120 to 130. If you do post breakfast, it is 230, post lunch will be 200, post dinner will be 250, all these things is happening. So with the single ambulatory blood glucose profile, with the reading will be, there will be one column called median. So the average value for the last 2 weeks. Another value called as percentile curve. This is the first value curve, 25th to 75th percentile curves. This is the second deviation. This is 10 to 90th percentile curves. So if you see, go with only the median, you can be able to understand what was the blood sugar for this patient for the last 2 weeks, whether the patient had hypoglycemia, whether the patient had hyperglycemia. By seeing this curve alone, I can able to say that the patient not having good glycemic control, he has having post-breakfast sugar is going up, post-lunch is also going up, but significant rise in the post-breakfast, there is no hypoglycemia at all. This is what I can able to see with this patient's data with ambulatory blood glucose profile. Why we are not bothered about HbA1c alone? We all know that HbA1c is a gold standard for good glycemic control. We ask the patient to go achieve a good HbA1c of less than 7. If you see here, for the same for 2 different patients, the same HbA1c 7.7. Here also the 7.7. But if you see here ambulatory blood glucose profile, so much difference is happening. So this is why we are worried about ambulatory blood glucose profile. We are concentrating much of CGM rather than focusing only on HbA1c. So the new tools for new glycemic targets will be not only HbA1c, fasting, postprandial we are targeting about, we are focusing on glycemic variability and another terminology called time in range. What is a period? The period the patient isn't well in control. The time in range, the target value will be 70 to 180. Already we discussed that. What is glycemic variability? For the same HbA1c of 8, both the patient had exertion down and ups in the glycemic profile. But what was the highest, what was the lowest? he had much variability here. This patient have very low variability. So overall sugar is, average blood sugar is reasonably maintaining here, but this patient have so much ups and down. This patient have more glycemic variability compared to the bottom line patient. So why this is most important? Glycemic variability has been associated with all type 2 diabetic complications. So if a glycemic variability is less than 36 or less than 25, the patient is doing good. Any value more than 36 glycemic variability, it means that patient's blood sugar is not well adequately controlled, even though the HbA1c is maintaining less than 7. And this is what we have discussed about time in target. So what is the period the patient is able to maintain a good glycemic control in between 70 to 180? This we call it as time in range, TIR. So above the value we call it as time above the range, below this value we call it as time below the range. In other words, time in range, good glycemic control, time below the range is hypoglycemia, time above the range is hyperglycemic period. So this is internationally accepted that the aim we want to have time in range will be almost all type 2 diabetic patients. We want a time in range of more than 70% of any day. So time below range will be less than 5. Time above range will be less than 25. If you are able to maintain a time in range for more than 70% for your patients, you are doing good for your type 2 diabetic patients. Why this is important? Why this 70% has been taken? If it is time in range is less 70%, corresponding HbA1c will be 6.7. If it is time in range is 80%, corresponding HbA1c will be 5.9. So whenever we are increasing time in range, definitely the HbA1c will come down, but at the same time we should not induce hypoglycemia. At the same time we should not induce time below the range to achieve time in range more than 70 to 80%. This is the international recommendation. What is needed target value for is a type 1 or type 2, time in range will be 70%, older or geriatric populations more than 50%, pregnancy more than 70%, but the value here is time in range will be 63 to 140, not 180 here during pregnancy. And this is a gestational diabetes. In type 2 diabetes, the time in range will be more than 90% expected. So this is, every CGM tell us a glycemic story of each and every patient. So this is a patient's glycemic, these are all real patients' data. So this is one patient's glycemic profile. If you see here, how much beautifully is well controlled. This is a diabetic patients with medications. And if you see here, time in range for these patients, time in range is 99.4%. It is like a non-diabetic patients. If you see another patient, this is another patient's glycemic profile, which is good one. You can able to see by simple seeing a curve, even without looking at the HbA1c, fasting, postprandial, you can able to see that this patient's time in range is 14.9, time above the range is 85.1%. Definitely these patients need more addressing the lifestyle modification, medication change, all these things will be needed. So having said that, what is CGM? There are 4 generations of CGM is available. We all know that how glucometer works. It works by glucose oxidation. So by glucose oxidation, there is one oxygen particle will be produced, which will be reduced by FAD. By transmitting FAD to further reduction, we are generating one electron. By generating one electron, the glucometer sends the value, assess the sugar value. The same methodology here also be using here. There are 4 technology available. All this technology will be glucose oxidase will be used here. The same FAD also used here. We are having this is a technology 1, first generation technology, second generation, third generation, and fourth generation. Whatever CGM we do have only up to first generation and second generation. Third and fourth still in the research. If it is fourth has come, the period can be delayed more than 2 years or 3 years. We can have extended CGM can be possible with fourth generation CGM methodology. And there is something called real-time CGM or intermittent CGM or implantable CGM or professional CGM. Whatever CGM we do use will be real-time or intermittent. All the 14 days CGM will be intermittent CGM, which work for every 5 minutes or 10 minutes. Real-time continuously monitor the sugar, which will be more useful for if you go with closed-loop technology. It means that the CGM will connect with the insulin pump. It tells the insulin pump that you stop insulin or increase the dose of insulin or reduce the dose of insulin. It is interconnected with CGM and insulin pump. That we use real-time CGM is called as closed-loop technology. So these are the CGM methods available, models available, Dexcom, Freestyle, Medtronic, ever since 365, which is not available in India. It is available in US. Usual duration will be Dexcom 10 days, Freestyle 14, Medtronic 7 days, ever since will be 360 days. But what we have to look into the CGM, the only parameter we have to look into the CGM, whether it's a good CGM or not, which is called as MARD. What is MARD? MARD will be mean absolute relative difference. How much difference for the accurate blood sugar? What is the CGM value shows? If a MARD values is less than 10% or less than 15%, this is really good. If it is less than 10%, very good. If it is less than 8, it is excellent. So if you see here, all the CGM availables, Dexcom have 8.2, Freestyle have, this is the lowest, 7.9, Medtronic have 8.8, Eversense is 8.5. Any value less than 10 is good. So all these CGM will be clinically reliable. You can go with the CGM with the treatment modality. Why this is not useful in hypoglycemia? If this is only for hyperglycemia, in case of hypoglycemia, the MARD for hypoglycemia will be 7.6 to 53.3%. That is why always don't rely on hypoglycemia with CGM. If you have a CGM shows hypoglycemia, always cross-check with glucometer, then only you have to treat. Many times if you're pressing over the, CGM usually applied over the arm, if a patient slides down over the pressure point, because of pressure point, the CGM shows hypoglycemia. Because during pressure, interstitial fluid will not be get absorbed, so interstitial fluid is not going up, sugar showing that it is going down. So this is what commonly happen with the CGM with nocturnal hypoglycemia. So always carefully monitor, particularly if a patient have persistent hypoglycemia during the night without any symptomatology of hypoglycemia, always cross-check with CGM. And what is the benefit of CGM? Always we know that it reduces HbA1c without adjusting the dose, but the major benefit is reduction of hypoglycemia. 72% reduction in hypoglycemia can be avoided with CGM, and hospitalization also be avoided with CGM. And CGS dramatically reduces hypoglycemia, as I said before. The reduction of severe hypoglycemia is 59%, and severe hypoglycemia post-CGM will be 7.8% rather than 14.6% for the other patients. So, what is the international recommendation? Where to use, which patient has to be, go with CGM. This is about so many recommendations we do have. American Diabetic Association, and this is EASD, European Association of Study of Diabetes. This is ISPAD, which focused on type 1 diabetic children, our NICE guideline, UK guidelines. This is American Association of Clinical Endocrinology. This is our Indian guidelines. Where I have shown that green is all the guidelines do recommend that type 1 diabetes with insulin, whether with insulin pump or multi-dose insulin, basal bolus therapy, all type 1 diabetics should be exposed to CGM. And type 2 patients with basal bolus therapy, or 3 injections or 4 injections per day, these group of patients also be exposed to CGM. And patients with basal insulin alone, maybe there are grade A or grade B recommendations. And patient not on insulin, not necessarily always go with CGM. Whenever you suspect there is some hypo, whenever there is much more brittleness, whenever the blood sugar is non-concordant with the HbA1c, blood sugar will be fasting will be 90, postprandial 130. If HbA1c is 11, that time you can go for CGM in type 2 with the non-insulin. And type 1 with pregnancy, all the bodies do recommend that. And something called professional CGM, where we have a discordance with the blood sugar and HbA1c. When the doctor feels that definitely this patient feels better with CGM, this is also be recommended here. And inpatient setting, whether it is useful for inpatient setting, there is so much trial is happening. As of now, during COVID, it has been promoted. Because we cannot go with the patient, you can see the patient, post-COVID has been withdrawn, and because of hypoglycemia. We know that, we have discussed that MARD for hypoglycemia with the CGM will be 53%, maximum value. So we don't rely upon hypoglycemia. That is why if you have a hypoglycemia, MARD being reduced less than 15, definitely CGM can be used in inpatient setup as well. And apart from that, this is the most important way to understand that dietary pattern recognition. Most of our patients say that, doctor, na onnume saapalla, but my sugar is going up. I am not eating at all, my sugar is going up. Put a CGM to the patient, patient can be able to understand that what food elevate his blood sugar. Even one banana, patient most of the time, sir, one banana தான் சாப்பிட்றேன். But with one banana, blood sugar goes to 350.
Sir, time.
2 minutes, sorry, extra 2 minutes. So with the one banana, blood sugar goes up to 250. So patient will understand which diet suits well for the patients and associated with education patterns. So if you, whatever diet you tell them, whatever exercise you tell them, patient will not understand. If you put one CGM and patients understand that by eating this, by doing this, my sugars are coming down, patients stick on to their lifestyle modification. This is the best tool for education, not only for HbA1c control, not only for avoiding hypoglycemia. This is the best tool for educating our type 2 diabetic or type 1 diabetic patients about his individual glycemic profile so that he can able to achieve a good glycemic control. And what about diabetic foot diseases? We all know that chronic hyperglycemia, whenever time above the range is high, definitely induces peripheral neuropathy, peripheral artery diseases. So this is, if you want to have a wound healing, if you're a stable patient, definitely CGM will be better. Good glycemic control definitely improves wound healing. But we have to be careful about remove CGM whenever we are before going for MRI, and remove CGM whenever before using diathermy or cautery for the patient. And adverse effects, skin local reactions can happen. Some allergic reactions will be quite common that. And psychological issues. Patient have some anxiety, blood sugar, my sugar is going up, my sugar is going down. Many a time, some patients are putting CGM will not sleep better. Every minute they see the sugar. So some anxiety will be there. And access, cost is quite high still. Not many of our type 2 diabetic patients still afford. Many of CGM available here will be starting from 4,000 to a maximum of 10,000 rupees available cost. So not all our type 2 diabetic patients are affordable to go for this CGM.
So can you please conclude, sir?
Yeah, I will conclude that. Last slide, sir. This is about, it reduces HbA1c, it reduces hypoglycemia, increases TIR, reduces hospitalization, increases quality of life. This is 1 or 2 patients. If you see here, by seeing this CGM ambulatory blood glucose profile, what you see that the patient developing hypoglycemia here, hyperglycemia here, and acute rise post-dinner value. You can adjust the dose accordingly, you can manage that. If you see here, this is the first value, this is the second value. Hypoglycemia has been increased, post-prandial uptake has been reduced, this surge has been reduced. So by adjusting CGM with adjusting medications, you can have a flat curve. This is individual day, and over a period of time, we can 24 hours, TR will be 80, 90, 90, 90, 87. Previously, the same patients, TR will be 38, 60, 50. By understanding the profile, we can go with the CGM will be better way of managing type 2 diabetes. So HbA1c alone is not sufficient to manage type 2 diabetic patients. And CGM have robust evidence and consistent glycemic control has been well achieved, and hypoglycemic reduction will be dramatic but not useful in inpatient setup, and recommendations are clear for type 1 or type 2 with the insulin, pregnant patients better to go with CGM, and limitations will be real and must be counseled before going to the patient because of the cost and so many factors. Thank you. These are the Instagram photos with the patients with the type 1 with CGM. Thank you.
Thank you. Thank you very much.
We have 2 questions to Dr. Vijay Kumar. One, again, Isolatium, is it banned or not? So that is one question that Dr. Shankar has asked here.
No, Isolatium is not banned. Actually, the same. Maybe the trade name is gone. But potassium containing, Isolatium basically is a potassium containing fluid which also mimics the intracellular fluid, actually, so that it is available, not that it is not available. I am using it regularly. Maybe it comes with a different trade name, that's all. And similarly, if you can see that you have DNS or something like that, it has got more sodium, which mimics the extracellular fluid. It's available.
And if insulin improves wound healing through other mechanisms, do you want to change patients who are not on insulin but on OHA but with good control? Do you want them to switch to insulin?
No, never do that. Provided it is only type 2 diabetic we need to continue the oral drugs. Whatever the slide I have shown is only for the inpatient practice, but whatever the patients have got no contraindications, if somebody is or already on oral drugs, they're well tolerated, effective, you have to continue them, only then we have to start insulin. There are two situations here actually. There is that natural course of the disease of type 2 diabetes. Over the time, the beta cell numbers comes down and insulin comes down. It is said in UK PDS trial, it is said that at the end of 7 years, 60% of the people did require insulin. But that is a different era. Now we have got more oral drugs that we can continue. And then, but nevertheless, most of the people may require insulin at around, this is insulin requiring diabetic, not insulin dependent diabetic, insulin requiring. And also why we have to start insulin, because the endogenous insulin levels are coming down. So for insulin to work better, whether you give it endogenous or exogenous, you need to continue the oral drugs. So you should not stop it. And suppose in acute phase you start insulin and the healing is better, you can always withdraw insulin and continue the oral drugs.
Dr. Shanmugam, one question from the audience.
Yes, sir.
Is can CGM be started in the hospital? Is it advised in hospital?
No, that is what I have told you. CGM is not advocated in hospital. During COVID only we have used it. So because of hypoglycemia range, it won't pick up hypoglycemia as good as glucometers. So that is why CGM is not, as of now, it is not recommended with the current available CGMs. As I said, MARD, this is the most important parameters of CGM. For hypoglycemia is more than 55. If it is reduced less than 15, definitely CGM can be used in in-hospital settings as well.
The one thing is that closing the loop, what we call. Somebody is on insulin pump. CGM is a very, very essential. We can have a closing the loop. Actually, it becomes as an artificial pancreas, but it is not fully validated, but to certain extent it's validated.
Thanks.
I have couple of type 1 patients who are using CGM regularly. Once they get admitted, in fact, I've seen they keep using that CGM in hospital as well. But for type 2 diabetes, it doesn't make sense to start a CGM being in the hospital.
Thank you, Doctor. Now I request Dr. Rajesh Keshwan sir to felicitate Dr. Vijay Kumar. Dr. Shanmugam. Thank you, Doctor. Now we'll continue with the session.
Done, thank you. Thank you. Now, can I invite Dr. Bala for presenting a very interesting topic, holistic approach for diabetes management, a very important topic. Just don't see the number of blood sugar reports, but see the patient as a whole. Over to Dr. Bala. Yep.
Thank you, sir, for introduction. First of all, I'd like to thank Dr. Rajesh for giving me this opportunity. And it's a great opportunity to be in front of all of you. And I would like to learn a lot from how diabetes and complications are treated so that we can ensure that the patients benefit. So you must be wondering how a professor from IIT is interested in Ayurveda. So I had a health issue for 6 years after I came back from US, and I tried all conventional therapy, chronic gastritis, but 7-8 courses of antibiotics and a lot of proton pump inhibitors only made my health worse. So that's when, being a skeptic, I was very adamant to meet an Ayurveda doctor, but my mother-in-law kind of pushed me. I mean, I'm sure you know that it's hard to say no to mother-in-laws, so I had to go and meet an Ayurveda doctor. And that changed my perspective. Right? It gave me a lot of insights into how holistic medicine is practiced. And I strongly believe that when these two systems come together, patients benefit. Right? So we're very happy to associate with Dr. Rajesh. He is one of the very open-minded doctors we have seen. but ensuring that, science is not compromised. That's why we are doing a clinical study with Sir and Dr. Sheila and the Dr. RK's hospital to understand and validate the integrative approach and the outcomes. So there are a lot of opportunity areas. You can see diabetes management, complication prevention, pre-diabetes reversal with the lifestyle changes, obesity and metabolism. I just want to go back a little bit, right, and understand the context, right? So diabetes, as we know, we think that it's a very new disease, but it's been present for the last 2,500 years. If you look at the etymology, the names that are described for diabetes and prameha is actually diabetes in Ayurveda. The etymology is exactly same, right? And same with diabetes mellitus, right? Madhumeha is what is described. This is described 2,500 years ago. So understanding how Ayurveda perceives, right, diabetes and diabetes complications, there are 20 subtypes of diabetes, urinary disorders that's described, and part of it is also diabetes mellitus. So there is a lot of literature that is available. So if you look at the diabetes treatment using conventional approach, right, so we all know, the effectiveness of the oral hypoglycemics, right, and also the insulin medication. People take it, they definitely get better, but then the bad habits, bad lifestyle, right, bad eating habits, and the disease pathogenesis takes them, right, to increase medication, insulin, complications. Right? So we all know that there are certain limitations to the conventional therapy, and that's why more than 70% of the people don't get their sugar levels under control. So the reason for that is we are only, mainly focused in a conventional approach. We mainly focused on sugar control. Right? It is very, very important. But there are also, it's equally important to address the root cause. The root cause is insulin resistance, right? As Dr. Kumar talked about, inflammation in the body, stress. So both of this have to be addressed for the patient, right, to have long-term sustainable outcomes. So that's why if you see, the integrative approach is also becoming mainstream, right? Apollo has acquired a company called Apollo Ayurveda, and currently they have scaled, right, the integrative approach in 14 plus centers, and a lot of AIIMS, New Delhi, a lot of AIIMS are adopting the integrative approach. So one of the important things I want to emphasize is diabetes, as we all know, it's not a single disease. There are multiple subtypes for diabetes. There is a nice paper in Lancet which talks about how there are 5, right, different types of diabetes. Even type 2 diabetes, there are 4 subtypes. And giving a monolithic treatment will not give sustainable outcomes to the patients. Same thing in Ayurveda. There are 3 main forms of diabetes described, and depending on the stage of the diabetes, it's assigned to a particular phenotype, kapha, pitta, vata. These terms you might have heard about it. So what is the point I want to emphasize is we need a very personalized treatment to have sustainable outcomes. So this is the goal that we are working, an integrative architecture based on 5 pillars. Not increasing HbA1cs after 5 years, 10 years, etc., but to show a sustainable control of the diabetes patients through an integrative approach. Right? So first, of course, targeted pharmacotherapy. Already Dr. Mohan's, right, published so many results which show that how different type 2 subtypes has to be given a very targeted regimen. Same thing with personalized Ayurveda. There are a lot of dietary modifications. So Ayurveda is not just about medicines, right? It's about dietary modifications. It's about lifestyle, yoga, meditation, because these do help in terms of improving the insulin resistance and also decreasing the stress levels in the body, which is what causes trigger of liver glucose. Right? So functional diet, I think, all of us are familiar, right? Indian culture is rich in functional diets, whether we add, turmeric, right, in our dishes, right? Whether we take fenugreek. A lot of diabetic people, we know they actually soak fenugreek seeds overnight and drink the water. So these are all part of our culture. I think it is very important that we integrate, right, the practices into this. And Dr. Shanmugam also talked about continuous glucose monitor. In all our patients that we are doing, CGM plays a very, very important role, and I'll show the outcomes, right, that we have done 3 sites, including Dr. RK's hospital, lifestyle practices, and one of the important things is behavioral modifications. If you have a weekly oversight to the patients, they get more confidence, and then we are seeing very good results. So we want to change from, precision diagnostic to personalized care. As I mentioned, right, there are a lot of tools that we use, not just, right, medicines. We use blood markers. We have actually an app which recognizes the food that you're eating, and if there are a lot of carbohydrates in the food, it actually gives a warning. Right? So this is a partnership that we have done with my advisor from Stanford company. It's called January AI, which does the smart food recognition, and then we give targeted interventions. Okay. So we always say being an AI engineer, in God we trust. Everybody else must bring data. So you can see, the data that we have been getting, right? This is the data of 100 plus patients we have put in the monitor. This is the data of one subject who has followed very good, right, strict regimen. 1 week, we just ask the user to just, record the diet, no interventions, and then see how the sugar spikes are seen. And with just, right, dietary modifications, right, functional food, supplements, etc., we are able to bring down the sugar levels 30% spikes within a week. Right? And this is the power of CGM, right? This is the power of the modern interventions that gives sustainable outcomes. So in addition to that, right, when we track the people for 2 months, modern medicines are very good, right, for controlling sugar level. But in addition, right, if you supplement, right, with an integrative approach, you can see that it's not just the sugar that's controlled, it's also the fasting insulin, right, 20% reduction in 2 months. And more importantly, the CRP, right, the inflammatory pathway that gets triggered in a lot of the diabetic patients because it's a chronic disease, that gets reduced by 30% within 2 months. So a couple of case studies I wanted to show, right, we had a patient, right, 10 years diabetic, didn't want to take any medication. So somehow we convinced him, right, just get into our program for 2 months, right? You try lifestyle interventions, Ayurveda, interventions. So you can see that HbA1c decreased, right, from 12 to 11.1 within just 2 months. And fasting glucose, more importantly, because he was doing exercise, diet, right, and the supplements that we are giving reduced by 30%. Right? So we had, another subject, right, who said, I will just control my diabetes with just Ayurvedic and lifestyle interventions. Though we recommended, right, most of the patients, we recommend them to get onto, oral hypoglycemics by talking to a modern doctor, but some are adamant, right? So you can see that there is a lot of improvements in the blood sugars. The case 3, right, that's the power of the integrative approach, right? When the patient is willing to try both the approaches in consultation with both the doctors, you can see that, right, within, within 90 days, they're able to bring down the HbA1c 40%, fasting glucose, right? Same with improvements in the CRP. So we have a free program, right? If any of your family or relatives are interested, it's completely free, so they can, register here. We also have a booth outside, you can come and register. So last point I want to emphasize the gut microbiome. Actually, in all the patients, in half of the patients, when we look at their gut microbiome, there is severe dysbiosis. Right? So when we look at the root cause for that, if you compare all diseases, right, diabetes has one of the highest LPS-driven inflammation, and that's what causes insulin resistance. And if we correct it, right, through dietary patterns, we can, get good patient outcomes. Same thing with diabetic foot ulcer, right? There is a huge benefit for having an integrative approach because, as the previous speaker said, if you have inflammation in the body, wounds don't heal. And if we can correct the inflammation and insulin resistance, wounds will heal. Right? So this is the approach that we are taking. Right? We have a kiosk outside which does the subtyping. Please visit us. And post-consult, there is a constant in touch with the patient. So this is my last slide. I'm very excited to announce partnership with Dr. Rajesh and Dr. RK Hospital. I'm sure this will be first of its kind, right, integrative approach for especially diabetic and diabetic foot ulcer patients so that we can work together and create sustainable outcomes. Thanks, Dr. Rajesh and your team. Thank you so much.
Thank you, Dr. Bala, for an excellent presentation. It's really going to be a blockbuster in the days to come for diabetic patients with the epidemic of diabetes, especially in youngsters, which we are seeing today in our community. Now, can I request Dr. Natarajan to present his topic, Holistic Type 2 Diabetes Management with Innovator Semaglutide, Evidence and Experiences.
At the outset, I thank Dr. Rajesh for giving me an opportunity. The topic for today's discussion from me is Holistic Type 2 Diabetic Management, and it is with the innovator Semaglutide. It's a sponsored program from Novo Nordisk, and the flow of talk is going to be with this burden of diabetes and the need for holistic management, and why Semaglutide is an ideal fit for the management of diabetes, and Ozempic metabolic management for sugar and scales, and Ozempic for organ outcome, and we'll see CVOT and renal outcome. And we know the diabetes is not a isolated disease. It's basically a vascular disease involving every organ which has got vascularity, and it is aggravated by inflammation, weight gain, hypertension, adiposity, and insulin resistance. They all lead to end organ damage right from your brain, eye, heart, kidney, liver, and peripheral vascular system. So it's all been well established, and this slide shows the burden of diabetes in India. We have a huge burden, 101 million, and majority of them, 77% of the people are not under control with A1C more than 7, and 85% of the people die with cardiovascular disease, and 44% they have chronic kidney disease, and 90% of type 2 diabetic have weight issues. This slide is a very well-known slide from Wikipedia's where we see early intervention in the treatment of diabetes aimed at a tight glucose control reduces future micro and macrovascular disease, which is called metabolic memory or legacy effect, which we know. And this in this slide we see after the trial period, when the treatment is off, we see the A1C from both the intensive and the conventional arm becomes erratic, but we see in spite of that, the people who are on the tight control, they have lesser incidence of micro and macrovascular disease. This is in addition to, we know the weight loss, it improves the glycemic control, it impacts on cardiovascular risk, and it disrupts the underlying pathology. And that is the reason why we need to have a little holistic, and semaglutide comes handy. And we know semaglutide is a GLP receptor agonist with a multimodal benefit. It takes care of 7 out of 8 pathological pathway of omnious activities. We know right from the beta cell insulin secretory defect, alpha cell glucagon secretion, incretin effect, and so on. Everywhere the GLP receptor agonist play an important role, and we know semaglutide is a human GLP which has got 94% homology, and it is the original non-Nordisk reverse RNA semaglutide has extensively studied in many RCTs and real world, which we'll be seeing in the future slide. And semaglutide injection has got a longer half-life, so it allows us to use once a week, convenience to the patient. The oral semaglutide is co-formulated. The snack should be used every day in the morning in empty stomach. So SEMA is endorsed today by multiple professional guidelines bodies, which include ADA, ESD, NICE, and Canada, and so on. And how the original inventor, Ozempic semaglutide is manufactured, we know that it is all the biologicals, medicines, they are made in the living organism, in the genetically recognized DNA, and that is placed in the cell growth plate that called a bioreactor, and the cells multiply, and which has been moved to the larger bioreactors to have a better yield at the end, and the cell lines are harvested at once when the maturity is there, and it has been segregated, and it is purified at multiple level to give you the molecule which is formulated, the protein is formulated into suitable therapeutic product, is suitable filled into the pen device, and it has been supplied to us. More importantly is now the transport of the cold chain is very important for biological, for its action to be expressed in the clinical practice. When we come into the clinical practice and the clinical development program, the original semaglutide has been extensively studied for efficacy and safety, and it has been extensively studied for cardiovascular outcome and renal outcome, the SUSTAIN trial and the FLOW trial, about which we'll be seeing in the future slide. Now coming to the metabolic management, we see this is the snapshot of many of the SUSTAIN program. We see the SUSTAIN program is done with semaglutide 0.5, which is marked in the blue, and 1 milligram is marked in the dark blue. they are compared with, as monotherapy with placebo, we see the A1C level reduction is huge, and when compared to other oral hyperglycemic agent in SUSTAIN 2 with sitagliptin with metformin thiazolidine combinations, we see the semaglutide scores over. With canagliflozin also it scores over. The other GLP receptor agonists, the previous one, exenatide, dulaglutide, and liraglutide, we see the semaglutide scores over in reducing the A1C. Both the dulaglutide, this is 0.75 and this is 1.5. Both as it's inferior to semaglutide, and liraglutide as well is inferior to semaglutide 1 milligram in terms of reducing A1C. As far as insulin is also compared, the glargine also has been compared with, and we see the A1C reduction is better with sema. And so we see there is a greater A1C reduction achieved when compared to all the other comparators or placebo in SUSTAIN program, and we see up to 2.8% of the people with the A1C has come down 2.8% in people with high A1C level. We see 4 out of 5 people, that is 80% of the people with diabetes reach the guideline recommended value of less than 7. When it comes to the weight reduction in the same SUSTAIN program, we see similar benefit of greater weight reduction with semaglutide with all the comparators, and we see up to 8 kg weight loss we see in people with diabetic with high baseline value, that is up to 66% of the patients with diabetes reached a clinically meaningful weight loss of at least 5%, and there is also proportionate waist circumference reduction. What type of weight loss we see? It is mainly fat loss instead of lean mass reduction. We see it is also beneficial when we use semaglutide. One caution, whenever we are using the GLP-RA, we need to take little care about the nutrition aspect as well the exercise. We need to give little high protein up to 1.5 gram per day and per kg per day to maintain the muscle health, and we need to increase the fiber and hydration to avoid constipation. And the patient should spend adequate time for resistant exercise to not to lose the muscle strength. If at all, if you are looking for a higher weight reduction for an individual, we can go with the same semaglutide 2.4 milligram, which yields around up to 18% of the weight loss, and this is sustained over a period of time for 4 years. As we see here, when we use semaglutide up to 4 years, the A1C reduction is maintained, as well the body weight loss is also maintained over a period of 4 years. It endorses the durability. So this, when we combine SGLT2 inhibitor along with the oral semaglutide, it gives additional benefit in reducing the ischemic stroke, myocardial infarction, greater A1C reduction, and also 3-point MACE reduction as well, 5-point MACE reduction, and there is a greater weight loss. Why this happened? This is a complementary mechanism. As we know, the GLP-RA handles 7 out of 8 amylase oxidase, and SGLT2 tackles with excretion, the kidney aspect, excreting glucose through kidney. So this turns out in the clinical merit, we see there is a greater body weight reduction when we combine, and there is also lesser incidence of ischemic CV events. So using SGLT2 and GLP-RA together, we get complementary benefit, and also there is a positive linear association which is identified with the weight loss, resulting in the reduction in the insulin resistance. Thereby, in clinical practice, that we can reduce the insulin dose when we use GLP-RA. And now coming to the cardiovascular and renal protection, we know every 1 year of poor glycemic control in type 2 diabetic lead to higher incidence of myocardial infarction, heart failure, and stroke. And this SUSTAIN trial for semaglutide, which is a cardiovascular outcome trial, which compares semaglutide 1 milligram in one arm and 0.5 milligram comparing with placebo, and we see there is a 26% lower 3-point MACE, which happens as early as about 6 to 10 weeks of time, and we also see this is independent of weight loss. This benefit is, CV benefit is in addition to the weight loss, not directly depend on the weight loss. We see when compared to the other GLP receptor agonist, say dulaglutide in REWIND trial, which is much lesser in terms of CV benefit, and we see the surpass with tirzepatide when compared to SUSTAIN 6, we have a greater reduction of cardiovascular endpoint. And this is because there is a reduction in the free fatty acid, there is a reduction in the triglyceride and VLDL cholesterol and LDL cholesterol, which we see. Now we go on to the kidney benefit of the semaglutide, and this flow trial is for to know the kidney benefit of the semaglutide, where it is compared with the 2.5 milligram of subtitrate to 1 milligram to 1 milligram of semaglutide in type 2 diabetic with chronic kidney disease with adult type 2 diabetic patients, and we see the benefit. There is a 24% reduction in the composite kidney outcome. There is also 32% improvement in the urine albumin creatinine ratio, and there is a slower of EGFR decline with semaglutide, as we see in the next slide. This is the arm with placebo, this is the arm with semaglutide. We see additional of 5% for 5 years without end-stage kidney disease in the people who are using semaglutide. To understand the mechanism, how this happens with kidney, this is the remodel trial where this trial is to understand the mechanism. We see that we already seen the flow trial. This is investigated for the renal benefit. This remodel is to investigate how Ozempic protects the kidney. We see it protects the kidney by reducing the excess fat within and around the kidney, improving the kidney hemodynamics, stabilizing the cortical kidney fibrosis, and down regulation of the gene expression associated with metabolic stress and fibroinflammation in the glomerular endothelial cell. All these result with the improvement in the kidney function. So based on this, the semaglutide is recommended by almost all the global bodies for type ADA recommends for type 2 diabetic, and EASD recommends for type 2 diabetic with atherosclerotic cardiovascular disease, and ESC recommends for atherosclerotic cardiovascular disease with type 2 diabetic, and we see the recommendation is also extended for stroke prevention as well diabetic kidney disease benefit. So how to initiate semaglutide? Start with 0.25 milligram once a week for 4 weeks. Each pen will come for 4 dosing, so use it for 4 weeks, and then when the patient is able to tolerate, we can up titrate to 0.5 milligram once a week for next 4 weeks, and then we can also up titrate to next 4 weeks onwards.
Can you please conclude? Yeah.
I will do that, sir. I still have 1 minute. I'll do that, sir. So we can up titrate. So this is my last time summary of the holistic management. It is not only the glycemic control, the weight reduction is seen, there is a cardiovascular risk reduction is seen, as well the CKD risk reduction is also seen. So the holistic management comes with semaglutide. This is for chronic care, not for an acute illness setup. Thank you for patient listening.
Thank you, Dr. Natarajan. We'll have questions in the end, sir. Thank you very much. I would request everyone to please share your doubts, queries, and questions, comments on WhatsApp. Thank you. Now we have the last presentation of this session. Dr. Ramya Lakshmi, she's going to present on sarcopenia and frailty in patients with wounds.
Good morning. So, for the next few minutes, we'll be discussing on sarcopenia and frailty in patients with wounds. So, if you see sarcopenia, frailty and wounds, they share a bidirectional relationship. It's a vicious circle. In sarcopenia and frailty, because the muscles are weak, There is reduced physical activity, walking becomes difficult, and the patient gets immobile. And this immobility in turn leads to impaired wound healing, because there is reduced perfusion to the tissues and prolonged pressure on the skin and soft tissues, reduced collagen synthesis and immune function. This in turn leads to chronic painful wounds. These chronic painful wounds, they push the body into a highly catabolic state. So in order to increase the body's metabolic demands, the muscle proteins are broken down into amino acids. These amino acids are very essential for tissue repair and for immune function. And in the process, the muscle mass declines further, causing sarcopenia. With further muscle loss, frailty occurs. So it's a very brief pathophysiology. So what is sarcopenia? It's a syndrome that's characterized by progressive and generalized loss of skeletal muscle mass and most importantly, the muscle strength, which is the muscle function. This is a more formal definition of sarcopenia, which is given by the European Working Group on Sarcopenia. So it has three criteria. Criteria 1 is low muscle strength, and the second criteria is low muscle quantity or quality, and the third one is low physical performance. A confirmed diagnosis of sarcopenia is made if criteria 1 and 2 are present, and a diagnosis of severe sarcopenia is made if all the three criteria are present. And next, coming to the most important aspect, the diagnosis, because we as clinicians are very much focused on the blood sugars and HbA1c, we fail to see the patient who is sarcopenic in front of us. So, there are tools for assessment. One such tool is to find the case. This is very simple because it's a symptom-based questionnaire. All that you have to do is assess the patient and ask a few questions. This can be done even before the consultation. You can ask your assistant to do it and fill it up. So it's a 5-domain symptom-based questionnaire called the SARC-F questionnaire, which includes strength, ambulation, rising from chair, stair climbing, and history of falls. The total score is 10, with each component scoring 2. A score of 4 or more is predictive of sarcopenia. And next in the diagnosis is measurement of the skeletal muscle strength. The first in that is the hand grip strength, which is done to measure the maximum isometric muscle strength. This is usually done by a handheld dynamometer. The one you see here is the JAMA dynamometer, which is a hydraulic one. It is the most commonly used. And this assessment of hand grip strength is the earliest and the most clinically relevant marker of sarcopenia. Usually the grip strength is measured either in kilograms or in pounds. And there are digital dynamometers as well, like you see here. And so the cutoff for sarcopenia, the sarcopenia cutoff point for grip strength is less than 28 kgs for men and less than 18 kgs for women. The value will be displayed like this on the dynamometer. All that you have to do is squeeze the dynamometer with maximum effort for 3 times, and the best of the 3 readings will be taken. So next is the chair stand test. So what you see in the picture is the standard chair stand test. This is done to measure the strength of the quadriceps and the other muscles of the lower extremities, and it is also done to identify the fall risk. In patients with, in patients with wounds, it is used to evaluate the functional mobility and the rehabilitation progress. So this is the standard chair test, where you can see the patient has to keep the feet flat on the ground. The chair should not have an armrest, and the patient has to keep his arms crossed, and put a 30-second timer and ask the patient to stand up and down. So less than 12 chair stands is considered abnormal. I think tonight all of us can do this at home and see. But for patients with wounds, the same test is done with slight modification. You can use a chair with an armrest and a footwear. And of course, this modification, because so as to prevent the pressure and friction. Also, it is better to avoid this test in those who have an active ulcer or an open wound, or those with recent surgery, or have strict restrictions on weight bearing, or have severe pain at the wound site, and those who are not, they're very unstable, like not stand. So like I told you, so the cutoff is different for different ages and it is gender specific. But in general, a median cutoff of less than 12 chair stands is considered abnormal. Next is to assess the severity of sarcopenia, gait speed test. This is done to assess the physical performance in people with suspected sarcopenia. Like you have to ask the patient to walk for say about 6 meter distance and assess the time. So criteria for low physical performance is 6 meter, for a 6 meter walk is less than 1 meter per second. And next is frailty. So frailty, it is a state of reduced physiological reserve and increased vulnerability that can significantly affect the wound healing, recovery, and the overall outcome. So the common features of frailty are weakness and unexplained weight loss, muscle wasting, exercise intolerance, frequent falls, and immobility. Like in sarcopenia, we have some assessment tools for frailty as well, but there are too many tools. I'll just list out the important ones. So one is the frail scale. Again, it's a symptom-based questionnaire which includes fatigue, resistance, ambulation, illness, and loss of weight. So the total score is 5, each component scoring 1. If the score is, a score of 3 or more is predictive of frailty. And this is the clinical frailty scale. It's a 9-point scale that is based on function, mobility, dependence, and comorbidity. The categories range from 1 to 9. 1 is very fit and 9 is terminally ill. And in most of the wound care settings, if you see, clinical frailty scale and frail scale are preferred for initial screening because they are simple, they're well validated and practical. So if frailty is identified in these two scales, then you can go for a more comprehensive assessment like the Edmonton frail scale. Okay, so now that we are done with the assessments, how do we confirm? So DEXA is the most widely used to assess the lean mass for sarcopenia and the bone mineral density for frail patients. And of course, CT and MRI are the gold standard for assessing the muscle mass, particularly at the level of L3, because this corresponds well with the total body skeletal muscle volume. And these imaging techniques, they also provide detailed insights into the muscle mass and the myosteatosis, which can be further quantified by Housefield units. And there is also newly emerging literature on the use of mid-thigh ultrasound. And there are a lot of biomarkers as well. But the study, there are studies investigating the association between the biomarkers and sarcopenia. But till date, no blood or molecular biomarker is used for clinical diagnosis of sarcopenia. Okay, next coming to the management. The mainstay of management is non-pharmacological, which includes exercise and nutrition. So among the various modalities, if you see, resistance training has shown more pronounced effects on the muscle, the mass and the strength. A combined exercise regimen like resistance exercises combined with aerobic exercise and balance training has shown to improve the physical function, including the walking speed. Also in certain studies, this combined exercise regimen, when performed for 2 to 3 sessions per week, has shown to increase the muscle mass and the strength by 20 to 35%. And of course, for patients with wounds, there should be strict modification when it comes to exercise. So depending on the location of the wound and for patients with an active or an open wound. For the main goal is to stimulate the circulation and to provide tissue oxygenation while concurrently fighting sarcopenia. So for lower extremity wounds, upper body resistance training like seated chest press, seated biceps curls, and dumbbell rowing can be done. And for non-weight bearing aerobic and circulation exercises include recumbent cycling, pool walking or swimming, and ankle pumps. Of course, the last 3 that I told you, it's entirely the surgeon's call, depending on the wound status. Next is the nutrition. Protein intake, a higher protein intake of 1 to 1.5 gram per kilogram per day is recommended for non-CKD patients. And for CKD patients, if you see, Adequate energy intake is the first rule to increase the protein utilization. So the energy intake should be around 20 to 25 kilocalories per kg per day. And for those with stage 4 and 5 CKD, the protein intake, there should be a lower protein intake of 0.4 to 0.8 gram per kilogram per day. And for those patients who are on renal replacement therapy, a higher protein intake is advised, around 1.2 to 1.5 gram per kilogram per day, because through dialysis, there are a lot of protein loss. And then again, of course, vitamin D supplementation, around 800 to 1,000 international units per day in older patients with a vitamin D insufficiency. And a lot of clinical trials have demonstrated the use of essential amino acids, particularly leucine-enriched formulations can improve the muscle function. Around 4 grams of leucine can be supplemented. And also immunonutrients including zinc, selenium, omega-3 fatty acids and glutamine can support the immune function. They mainly target the chronic inflammation that is associated with aging. And coming to pharmacological therapies, if you see to date, no drugs have been approved specifically for sarcopenia. There are ongoing clinical trials for myostatin inhibitors, selective androgen receptor modulators, senolytics, and nicotinamide adenine dinucleotide precursors. Okay. And so, see, our muscle starts declining by the 4th or the 5th decade of life. So, strength training is very important because by the age of 60, there is an accelerated loss. Thank you. My special thanks to Dr. R.K. for giving me this opportunity.
Thank you, madam, for an excellent presentation. Since we are running late by 7 minutes in this session, we'll have one question each for the speakers. First, with Dr. Bala, he's been talking about inflammation and inflammatory markers. Is he looking after inflammatory markers in a holistic approach or an integrated approach for treatment in type 2 diabetes?
Thanks for the question. It's an excellent question. So that's what the integrated approach we are looking at HSCRP, right? In one study we looked at HSCRP, and that's the result that I had showed more than 30% reduction. In another study that we had done with SRM earlier 3-4 years back, so we looked at the whole inflammatory panel, right? IL-6, TFN gamma, all the 12 inflammatory panels. And what we have seen, the paper is currently under review. What we have seen is uniformly the pro-inflammatory markers decrease and anti-inflammatory markers increase through an integrative approach. So as I mentioned, inflammation is very key. It drives the insulin resistance and also drives the fatty acid synthesis, which also causes insulin resistance through IRS substrate inhibition. Yeah.
Thank you. And another question to Dr. Natarajan. Does weight loss actually helps in reducing the foot deformities, the pressure points, which we are looking into diabetic foot preventions? You talked about a lot of holistic benefits with weight reduction and with semaglutide, but what we are interested here is reduction in the pressure points, reduction in the foot deformities, which we are looking into prevention of diabetic foot.
Yeah, as I already showed in my slide, weight reduction gives a lot of benefit apart from cardiovascular and kidney benefits. The weight reduction also helps in managing the joint and joint stress. Everything will definitely come down. Also, as I said, the semaglutide, also the trials are giving a positive look towards peripheral vascular disease as well. It's not been approved as of, but there is an improvement. The inflammation reduces, there is an improvement in the vascularity. So in this way, it has been postulated, not yet been confirmed. Definitely the patient outcome will be better, and more important, the patient will not have hypoglycemia and have one more fall.
Thank you. And last question to Dr. Ramaya. Madam, we screen for retinopathy, we screen for all the microvascular complications, neuropathy, nephropathy, even macrovascular complications and NASH. Do you think we should start recommending screening for sarcopenia in all our patients, because they come with weight loss and muscle mass loss and all those problems? So when should be included in our guidelines in screening for sarcopenia?
So routinely screening is done for sarcopenia when they are more than 60 years of age, 60 to 65. But when they have comorbidities like diabetes, heart failure, or a liver disease, it can be done much earlier when they're present with the disease. And of course, when it comes to patients with wounds, it is better that the screening starts initially when they come, because it's an inflammatory state, and this inflammation actually exacerbates sarcopenia. So I think for patients with wounds, when they come, it's better that we start the screening at the earliest. Like I told you, it's a very simple symptom-based questionnaire, and even the equipments that I had projected are very inexpensive. They are even available on Amazon, like at less than 1,000 rupees. So we can do that, sir. It has to be done. It has to be done.
So thank you very much. Thanks to all the speakers and the organizers. A big round of applause for everyone. Thank you very much, and we conclude this session here.
Thank you, Dr. Vinay, sir. Now I request Dr. Rajesh Keshan, sir, to felicitate the speakers, Dr. Bala, Dr. Bala, Dr. A. Natraj, to Dr. Ramya, to the moderator, Dr. Vinay, thank you, sir. Dear delegates, we warmly invite you to join us today's evening music program at 7 p.m. and thereafter dinner will be served at 7:30. Thank you, please join. Next, we move on to the session 2, the weight loss journey in diabetic foot care. I request the moderator, Dr. Anirudh Deepak, to come to the dais, followed by Madam Dr. Bhavadarini, Dr. Sriram sir, we start with the first session, first talk with Bhavadarini Madam, 8 optimization strategies in diabetic foot management.
Very good morning, all. I immensely thank Dr. Rajesh for giving me this wonderful opportunity. And coming to the weight optimization strategies in diabetic foot, of course, does weight really matter? Yes, excess body weight increases the plantar pressure, and obesity as a chronic low-grade inflammation state that increases the cytokines such as tumor necrosis factor alpha, interleukin-6 and C-reactive protein, leading to callus formation, ulcer development, delayed wound healing, and of course strongly associated with insulin resistance and poor glycemic control. Why is weight optimization important in a diabetes? Weight loss is considered the key management of type 2 because of the potential to reduce blood glucose. Not only that, weight loss can impact other health problems commonly associated with type 2 diabetes. And if you see the pathophysiology, of course, excess weight leads to an increased amount of body fat in the abdomen, thighs, and legs, putting additional strain on the circulatory system. This can reduce the blood flow to the extremities, particularly the feet where the diabetic ulcers commonly develop. Additionally, the obesity can trigger chronic inflammation which further impairs the body's natural healing process. Then blood flow is vital for wound healing as it delivers the oxygen, nutrients, and immune cells that help repair the damaged tissues and prevent infection. And as a consequence, of course, the patient is going to get the peripheral arterial disease because of the blood vessels becoming narrowed or blocked, leading to poor circulation in the legs and feet, which further delays the healing and makes the feet more susceptible to infections and ulcers, elevates the risk of also osteoarthritis and osteopenia. What is this rule of 50 for a diabetic foot? The theory of half in diabetic foot is most diabetic foot ulcers is not happening because of one single cause. They happen because of two combined factors. That is what we call the theory of half. Of course, 50% is the primary factor, and it is again half contributed by the contributing factors like neuropathy, ischemia, and infection. Along with this, obesity further aggravates by metabolic dysfunction, immune suppression, and also aggravates the diabetic neuropathy and angiopathy with infection added leads to diabetic foot syndrome. And what is this weight impact on the obese diabetes? Of course, there is insulin resistance, excess fat cells, especially in the belly, actively releasing hormones like leptin, estrogen, adiponectin, and promoting chronic inflammation with tumor necrosis factor alpha and interleukin 6. This interferes with the glucose utilization for energy, requiring the pancreas to produce more and more insulin, leading to hyperinsulinemia, ultimately exhaustion of the beta cells and progressing to diabetes. Even a modest weight loss of just 5% to 10%, we can significantly improve your blood sugar, which improves the circulation, lowers the risk of heart disease, other complications, and in some cases, even put diabetes into remission. So the speed with which the weight reduction occurs can have an impact on the diabetes foot. Obesity and diabetes are on the rise, definitely, you'll all agree with me globally. The direct effect of weight reduction on the foot is underreported. And the speed with which weight reduction occurs has been shown to have an impact on the lower limb. And what are the goals of this weight optimization? It reduces the plantar pressure on the foot by minimizing the local stress and preventing callus and ulcer formation, and improves the glycemic control, that is our HbA1c, by enhancing the insulin sensitivity and metabolic stability, and enhances the wound healing outcomes through better tissue perfusion and cellular repair, and prevents the recurrence of ulcers. That's very important. They are the one who go for recurrent ulcers by addressing the mechanical and metabolic risk factors, and improves the mobility and functional status to support safe ambulation and rehabilitation, and reduces systemic inflammation by lowering the pro-inflammatory cytokines with like tumor necrosis factor alpha and interleukin 6. So what are the strategies we have for this weight reduction? Of course, the basic foundation is our nutritional management along with physical activity, which is the cause of all problems what we are facing, the lifestyle disorders. And of course, we need to depend on the medical management, which my co-speaker, Dr. Sriram Mahadevan, is going to explain well. And offloading what you heard adequate yesterday, and also the biomechanical support. And of course, the most important is behavioral and lifestyle modification to prevent such ulcers. Coming to the impact of diet on diabetic foot ulcers, of course, the blood sugar gets controlled, providing antioxidants and anti-inflammatory effect. And the well-balanced diet provides all the necessary nutrients for optimum wound healing and supports the immune function and tissue repair. It improves the metabolic health, reducing the risk of diabetic complications. And proper hydration is very important for the overall health and plays a crucial role in wound healing. In nutritional management, we need a structured calorie deficit diet, which has to be individualized according to the BMI, metabolic status, and ulcer severity. And you need to emphasize on low glycemic index carbohydrates, high fiber diet more than 25 to 30 grams per day, and lean protein intake to improve the glycemic variability and satiety. What my previous speaker was speaking, sarcopenia should not happen. And adequate proteins, 1 to 1.5 gram per day, to support the tissue repair and wound healing, but see to nephropathy. And reduction of ultra-processed foods, that is trans fats and high glycemic load diets, which are linked to systemic inflammation, has to be avoided. And weight loss of even 5 to 10%, as I said already, improves the insulin sensitivity and the cardiometabolic risk factors. Of course, when you are reducing the calories, see to that you balance the macronutrients, and above all, blood sugar regulation is very important, which has to be managed very meticulously, which is vital for avoiding food complications during weight loss effects. And engaging in regular activity is associated with many benefits for patients with diabetes, including weight control, reduction in BP, improved glucose control, reducing the risk of cardiovascular disease, and improvement in mental health and quality of life. Physical activity, of course, regular aerobic activity of more than 150, they say universally, but for our country, it's better to have more than 300 minutes per week, which improves the glycemic control and weight reduction, and prefer low-impact, non-weight bearing or protected weight bearing exercises, cycling, swimming, if no ulcers like that, in patients with active ulcers, not swimming. And high plantar pressure during weight bearing activity contributes to ulcer formation and delayed healing. Be careful. And evidence suggests that increased daily steps may negatively influence the ulcer healing in some patients, emphasizing cautious activity prescription. You can go for non-weight bearing exercises like this, not the regular walking or thing. Of course, you have to avoid exercises like running, jumping, or long distance walking. All these has to be avoided. And coming to the medical management, intensive glycemic control is very important. You need to achieve the HbA1c target, which will help in reducing the microvascular complications and help wound healing. And now it's very difficult to control our craving for food. So we are compelled to go for the weight reducing pharmacotherapy, that is our GLP-1 receptor agonist. What you heard from my previous speaker and also my co-speaker, Sriram, is going to explain clearly about significant weight loss with GLP-1 receptor agonist. And emerging evidence suggests that potential protective effects of diabetic foot outcomes and wound healing with that. And control of comorbidity is very important. Don't see the foot ulcer alone. See to his comorbidities like hypertension, dyslipidemia, peripheral vascular diseases, and also help in anti-inflammation, metabolic improvement, which will help in tissue perfusion and healing potential. That's what this GLP-1, which helps in stopping overeating and reducing the weight, my co-speaker will deal. And regarding foot health, optimizing weight requires a careful balance from day one of diagnosing diabetes. The patient medical community should not aim at blood sugar control alone, maintain the ideal body weight, good vascularity without any neurological deficit. Because weight-bearing activities can place high mechanical loads on vulnerable feet, it's crucial to focus on offloading, what you heard yesterday a lot, low-impact exercises and protective footwear to prevent the ulceration and support healing. And you need to wear custom footwear to relieve the high-pressure areas by at least 30%. Avoid barefoot even at indoors. Always wear protective closed toe footwear and moisture working socks to avoid friction and puncture injuries. Offloading devices, if a foot ulcer is present, strictly use removable cast walkers or total contact cast to prevent weight from worsening the wound. Offloading, you heard a lot, is the cornerstone of diabetic foot in ulcer management, and first-line non-removable knee high devices and alternatives, removable walkers, therapeutic footwear, custom orthosis. Obesity is associated with increased plantar pressure and abnormal pressure distribution, particularly in high BMI patients. So elevated plantar pressure is a major etiological factor, ulcer formation and recurrence. Our goal is to redistribute the mechanical load and promote healing and prevent recurrence. A spoon of prevention is always better than a pound of cure. And so always educate your patients. My teacher, Dr. Sundaram, always used to say in a diabetic patient, do not examine a patient from head to foot. Always, I am a teaching coordinator for the Tamil Nadu for diabetes program. I always teach them, start examining from foot to head. Any diabetic patient, you have to do that so that you can avoid ulcers and also give structured patient education programs and improve their adherence to outcomes and encourage them daily inspection of the foot. Even if it is normal, they should inspect it and have a good hygiene and have a better nail care and behavioral interventions like self-foot care practices, improving the adherence to offloading and activity restriction. Smoking cessation, of course, it's very important. This improves the microvascular circulation and helps in wound healing. And so long-term success, of course, depends on multidisciplinary approach with the physician, podiatrician, and also the dietitian. Of course, the surgeons also. Thank you.
Thank you, Dr. Bavadarani, for giving us that kaleidoscopic insight into obesity management as a whole, which is the need of the hour. And I think we're shifting from just an input versus output to a hormone and dysregulation. And on that note, I would hand over the dais to Dr. Sriram to get into the different aspects apart from just input-output in obesity management.
Thank you very much, my co-panelist as well as Dr. Anirudh. Madam Bavadarani has set the stage for me to proceed further in the obesity management in a diabetic patient from the pharmacological perspective. And I will be failing in my duty if I don't express my gratitude and thanks to Dr. Rajesh. He is my college senior. In addition to professional and academic relation, we have a spiritual relation. From Stanley Medical College, we always say we have the Stanley spirit going on. How many of you are physicians here? How many of you are surgeons? You're physicians? And surgeons? Oh, surgeons are outnumbering. So I have to be more careful in what I say now. I am primarily preventive, metabolic, endocrine, you can call it whatever. Too many expansive terms are used nowadays. And a disclaimer before I start is, usually we say disclaimer about conflicts as well as honorarium or any financial disclosures, which is not there for this talk which I am giving, but I have used AI. My daughter said, why are you wasting time in this? So I have used AI, all the slides, but all the contents are mine, human. So slides will be too bombastic to my... I never expected that within 5 minutes you can get so much of information nicely made. Anyway, we all know how difficult it is to manage obesity. Till recently, we have been devoid of various problems, mainly because we didn't have an effective agent, unlike our microbiological antimicrobial agents in infectious disease or certain other interventions. In obesity, our hands are always tied. We are diabetes physicians for a long time. Most of the diabetes agents, unfortunately, which control sugar very well, like insulin or sulfonylurea, they all cause weight gain. And on the other hand, we just now listen to the Ayush-based talk, how the cause is to be addressed. If there are Tamil people here who can understand, Thiruvalluvar, with his age-old wisdom, in Thirukural has said one nice thing about disease and prevention. Noi nadi, noi mudal nadi, adu tanikkum vai nadi, vai pachayal. That means you identify the seeds or root cause of a disease, address it effectively so that the disease is cured and prevented forever. If this approach is used, which is what we all want, diabetes obviously has a forerunner or a cause which is in the form of obesity and insulin resistance, which go hand in hand. Unless you address obesity, you can't address insulin resistance. All the other dimensions of insulin resistance, inflammation, prothrombotic state, etc., are always discussed ad nauseum in all these meetings. So unfortunately, we were addressing the top layer, the what you call the tip of the iceberg, rather which is called the hillock probably, not the bummock, which is actually submerged below. And that's what we are doing in the next few minutes to just allude to the points how we have advanced in the last few decades. This slide is the nutshell of what has happened in the era of obesity control with the pharmacological agents. Just to put in one word, except the last two, after 2021, all the other agents are banned for all reasons beyond very serious side effects which are not to be used commonly, except one or two which I will allude to now, except orlistat probably. We know sibutramine which went into disrepute due to hypertension, and fenfluramine with pulmonary hypertension, rimonabant with suicidal tendency and depression. I can go on and on giving you only the side effects of these medicines rather than talking positively about what they do. Then came this path-breaking research, which is the incretin-based therapies have revolutionized them, and definitely, as a person who is observing this field from 1999, 2000, for the 25 years of whatever observation, we have never had an agent where we can safely tell the patients, we have, as allopathic physicians, we understand even paracetamol has side effects. We know that even every agent we use, we has side effects. So it has its own share. But the effectiveness for which it is used is beyond. The risk-benefit ratio is overwhelmingly in favor of the benefits rather than the risks. I will allude to all these points between semaglutide and tirzepatide for another few minutes. Just to tell you that in addition to this, we are going to have in pipeline more agents coming. Already retatrutide, all these are tongue twisters coming up. You can call all of them are grouped under one class today, NUSH therapies. NUSH means nutrient-stimulated hormone-based therapeutics. The concept came in the early 1960s when they observed that you secrete more insulin if you take glucose orally rather than by injecting intravenously. So that means the gut also contributes to the overall homeostatic glucose mechanism after food, and they are all nutrient-based hormones, only acting when nutrient is sent inside. Either they modulate, regulate, or adjust the internal milieu. One thing before proceeding further, for example, the pancreas secretes amylin also, the intestine secretes local hormones, one of which is GLP, the other one is GIP. All these are secreted in an orchestrated, well-coordinated manner the moment you start smelling food, eating food, and they all act as a nice orchestra to control your sugar. Let us not forget this holistic concept. Unfortunately, we are not having all this to be given together, which is deficient, we don't know. We give supraphysiological doses of GLP and GAP, and they are excellently acting, that's no doubt now. But these are all the things which are happening. The last one, bimagrumab, just remember, this is not an anti-obesity agent. This is, it is in follow-up of the sarcopenia talk. One of the side effects of all these agents, which is already talked to, is they not only make you lose weight up to the tune of 20-25% in some studies, which means out of this 25%, around 30% is muscle loss also. It is not just fat loss. And for that prevention of muscle loss only, another agent which has come up. So on one side, if there is that the holistic approach to a patient does not involve just giving drugs. As a physician, we all understand that for every side effect, we create a side effect with one drug and we give another drug to prevent that side effect. That's also should not be the approach. And that's why, all these to be taken in that context and use it judiciously. So see the list of drugs. All the top list, almost all are banned. The last 4 are in the pipeline, and too many new things are happening. For example, the injectable forms are semaglutide, tirzepatide. Tomorrow you are going to get retatrutide, CagriSema. But the orforglipron already in market in the US, in India it's going to come by this year end, is an oral drug. Already the concept is changing now. You use this injectable as an intensive therapy, make them lose weight and maintain it with its oral drug. So something like how you use, in other therapies, intensive therapy followed by maintenance therapy. So 2 agents we are using now everywhere, all well known. It is unfortunate that the non-allopathic physicians, including clinical nutritionists, including gym people, quacks, I can put it, everybody is using it. They get these drugs. The market is fully flooded. It is unfair. The Indian government has tried to restrict as much as possible, but everybody is using it. Use it judiciously. They are very, very effective agents. They have their own share of issues, which I'll allude to a few of them. 2 important drugs are semaglutide and tirzepatide. The only difference is semaglutide is GLP-1 analog mechanistically. The tirzepatide is GLP and GAP, 2 hormonal agents. For the first time in the history of medicine, we have a single drug acting like 2 different hormones and 2 different ways, causing this tremendous efficacy. This kind of placebo subtracted 20% weight loss, unimaginable 10 years back without side effects. to the extent that our bariatric surgery colleagues have already taken this as our adjunct therapy. They are not doing that malabsorptive procedures anymore. They are doing only the mild restrictive procedures like a partial sleeve gastrectomy or restriction, and using this as an adjunct to it. So you can go on and on these things, but just to tell you that this is evolving into, it's not fully taken shape. We are learning many of these. Some effects, some side effects will come up which we need to be aware of. Pharmacovigilance is very, very important. For that only these kind of slides which tell, which describes about all the mechanisms, what are all the possible animal studies and other things which I've been saying, the mechanistic difference are important. It's very intriguing to note that the same GLP-1 analog which was derived from the Gila monsters, saliva and all, you would have learned all this, how those guys discovered all this is amazing to note. But you see the same when combined with GIP. Technically this increases glucagon, which is GIP, but this GLP suppresses glucagon. Glucagon is supposed to increase glucose, but interestingly, when given with GIP, along with GIP, together it reduces glucose, it reduces weight. That's what I'm saying. No, our understanding of these hormones are increasing. I am also not an expert in this, but we are learning day to day with newer, informations coming on this. Very, very reassuring slide to tell you that around 10 to 15 years of research in clinical studies have shown that cutting across from, if you take exenatide also, it will be from 2001. We have 25 years of all these agents getting used. The semaglutide and tirzepatide only in the last 10 years. Liraglutide for more than 10 years. You see, cutting across all these studies for 2 decades, so much of data, millions of patients have used this. And on average, they reduce at least 10 to 15% weight at the peak. So if you put it the other way around, at least 10% weight loss will be caused in 80% of patients, which is a huge thing to see. So who should be given obesity by your regional definition? In India, we use definitions like 23 and 25 with BMI. They are not the FDA approved indications, but you can use your common sense and regional cutoffs. And anybody with diabetes, this is primarily a diabetes drug. Don't forget that they are not obese. We are refurbishing, or the offbeat effect of this is taken as the primary effect, which is obesity. But they can be used for glycemic control alone. They can be used for diabetes with obesity, diabetes with any other comorbidity, where we have included newly the last 2 guidelines by ADA, even the liver side effects. The mechanical side effects like osteoarthritis, that's why Madam was alluding to now in her talk about how weight loss can improve your overall balance and other things also. So it is to be used in that context. These are all the cautions. Obviously, pregnancy and other things. The main thing is anybody with any history of pancreatitis, anybody with severe retinopathy, already an optic nerve problem, serious psychiatric illness, all these are some no-nos already. If you ask me personally, I wouldn't be very comfortable using how much ever obese they are. Very sadly, most of our psychiatric colleagues refer patients because they are already obese due to the drug and related things. And that's where we have some controversies whether these drugs also improve something or they can have some serious things. But in general, if you exclude these serious ones, most of our common garden obesity patients who after 6 months of very good trial of lifestyle and other things, still not able to lose, counsel them well about this injection. Not that it is a panacea, it is only an adjunct to your lifestyle measures. Use it judiciously for the shortest period of time. I am using so many adjectives and adverbs to drive home the point that this is not like giving paracetamol for fever or dehydration. You have saline, you have painkiller means diclofenac, you have antibiotic for something. It is not an ATT or an anti-tuberculosis, right? It is not an cure for obesity. No, you stop the drug, obviously you have to regain. The whole thing will reset. And that's where the pharma-oriented approach, if you say, if it will reback, you give a baseline dose, you continue forever. Already allopathic physicians are facing this problem. No, you don't cure diseases, you only maintain diseases. This is always there in the chronic disease segment at least. And that I think this will add to the already defamed situation. So we have to be very careful in addressing it in that candid way to our patients. So the initiating therapy, always the mantra is start low, go slow, learn all this very well. Semaglutide, it's not like, recently our Indian companies after patent have come up with 3 milligram, all big vials. At least 2 patients in the last few weeks in our hospital, they have come with wrong dosing, the dials, one comes with vial, the other one fellow, 3 months therapy, wrong dosing. All these are troubles created by our, so use it very, very carefully and tell about these effects and side effects. You don't know which patient will have it. Gradually increase the dose, monitoring it, and the tirzepatide is going in the easy to remember 2.55, but the other one will have some odd numbers there. These are all, as I said, tirzepatide is still not out of patent in India, pretty costly. So the Indian drugs use of semaglutide has already increased tremendously. The market share is so high. One of the common things are people, pancreatitis, other things are rare, directly injection site reactions. So the first 4 weeks, there will be severe GI disturbance in many people. You have to counsel them. But many of the motivated patients who already read about all this and come, or they are themselves asking, they know all this, they'll say, I will tolerate this. Usually it is a well-tolerated drug. And when you are using this drug, the other combinations should be reduced. For example, sulfonylurea should be reduced, insulin should be reduced so that they don't go into hypoglycemia. Yeah, 1 minute more. Monitor clinical parameters. Obviously, these are all agents which will not only reduce weight, even waist circumference, inches will come down. All the metabolic parameters will improve, provided they don't have other complications. So, and needless to say, we have to address them. The injection is once a week, and if they skip a dose, how to do it. You can start the next day, etc. Cost is not a major issue now with the out-of-patent Indian semaglutides, and motivated patients take it well. And the GI acting drugs like acarbose, the alpha glucosidase inhibitors, or our other drugs have to be adjusted according to the GI side effects of this patient. And please, you see here, so many indications, except for exclusion in pregnancy. Infertility, interestingly, in the Western country, we have this PCOS, which is relabeled as PMOS now. Obese patients who have fertility as an issue, you give this drug, 3 months, they lose weight, they're pregnant. Unplanned pregnancy are becoming common. So you have to advise even contraception before starting these drugs. So stopping therapy, obviously, for side effects, and cost is in an Indian way of stopping. If they're happy with their weight loss, you can go for maintenance, but nothing like you stop it, you have to, there will be a regain. How much will be, only God will know on that given patient. However, you have to caution that, I'm not here to say continue endlessly, but be aware of this. They may, if they are happy, you can continue for longer days. So what I'm trying to convey in the last few minutes is, we have excellent drug in the form of these incretin-based therapies. We have too much of reliable information on, and the physicians who are here and the obesity-related physicians who are here can be reassured that the data is highly convincing. Our own practical experience is also contributing that these agents are very effective. Use it like a knife. We say in steroids, it's a double-edged sword. So use it carefully in our patients. You will have the good benefits. And in the next few years, there will be more safety informations. Cardiac and other things have come up. But in a given patient, be pharmacovigilant and tailor it to the given patient and manage them holistically. Thank you very much for your kind attention. Thank you.
Now, Dr. Anirudh Deepak will share his expertise on strength training and exercise for diabetic foot patients.
First of all, I would like to request all of you all to keep sending in your questions. We have a couple, but I would like you to keep sending in your questions. To just sum up what Dr. Sriram said, do not be afraid. Get over the clinician inertia and use these agents wisely in where it is required. We have a plethora of agents. Patient selection is most important. Having said that, yesterday you would have heard a lot of, sorry, 1 second. So yesterday you would have heard a lot on offloading. Today I'm going to talk on a flip side of it. Why not only offloading and a protective mechanism of a footwear is important, but an active restoration of the muscle strength along with the lower limb kinetics is of utmost importance today. This is my talk about, this is what I want the paradigm shift in our clinical protocols to happen. Now let's get into a little bit of the kinetics and the pathophysiology. What happens is the chronic hyperglycemia causes ischemia to the peroneal and the tibial nerve. This causes a symmetrical atrophy of the intrinsic muscles of the foot, mainly the lumbricals and the interossei. Now this, coupled with the unopposed extrinsic extensors and flexors, pulls the foot into a clawed or a hammer toe deformity. Now there is no stability to the MTP joints, and all the shear stress falls on the metatarsal heads. Now what we also see is, in Francia et al., we see that this clawed toe or a hammer toe deformity is actually a precursor to even the monofilament test being positive, to show that this is a patient who would probably go into a diabetic foot ulcer. This is where we have to catch them. Now, what happens is, because of diabetic neuropathy, we have the patients going into, their foot goes into a rigid, stiff leg, which is characterized by pelvic anteversion. There's a forward tilt in the pelvis. Now, it's not only at the ankle, all the way up to the hip is where we see this change, and there's an entire loss of the structural lower limb kinetic chain. In the next slide, which I will show you, we will see the corrective measures as to how to improve with stretches and dynamic exercises to improve this pelvic anterior tilt. You would rather see that patients, they come in with a forward tilt of the pelvis like this. Now this is corrected with strength training and stretches. Now the first one that we'll see is the flexor stretch. Ask your patient to do that. This is the knee to chest. This is the glute bridges. And the last one that we will see is a dead bug. These are just examples of stretches and exercises that will help you correct the anteversion of the pelvis. Now, along with this, what we also see is that there is a glycation of the collagen, which causes stiffness in the Achilles tendon. So what happens is, it's not only the ankle involved, it is an ankle to hip shift in the gait dynamics. So what happens is, the foot goes into an equinus deformity. Now, along with the equinus deformity, what happens is, as a matter of survival instinct, the body uses the proximal hip muscles to move and walk. Now this, along with contraction of the knee and the ankle, causes repeated and premature firing of the rectus femoris. And this causes a drag and pull sort of a gait. So it is not only at the ankle and the foot that we see a problem. It is actually a terminal representation of what is a failure of the entire lower limb kinematics. Now, unless we treat this as a whole, we will never be able to either prevent or see a complete healing of the foot ulcers, because you'll be stuck in a vicious loop of healing, but not fully. Now, what we see in the SOPET trial, which was a 12-week trial given to patients where we had two groups. The study group was given a 12 weeks exercise protocol specifically targeting the various muscles of the foot. That is from the ankle, the calf, all the way up to the hip. What we saw is that not only was there a structural hypertrophy in the muscle, which again shows that with the right amount of stimulus, there can be hypertrophy of the musculature in spite of denervation. But we also see that at peak plantar pressures, in a dynamic gait, there is an offloading of pressure. So this reduces the risk of an ulcer. Now, this is one clinical trial. We also have the Amsterdam UMC, which is a meta-analysis which shows that a relative risk of a foot ulcer when targeted approach of strength training is given is only 0.56. That means that there's a 44% reduction in the chances of ulceration. Just let that sink in. This is a non-pharmacological management of a reduction in a foot ulcer, and mind you, there was zero adverse events. Now, how does this work? Apart this, I'm going to stress on this slide, I cannot stress on this more. Apart from strengthening the various groups of muscles, how, which, where, we will see in the upcoming slides. The exercises that we do causes a translocation of the GLUT4 receptors, which is an AMPK-mediated uptake of glucose rather than an insulin-mediated, which is already irregularly signaling. It also increases endothelial nitric oxide synthetase, which improves the microvascular perfusion. There is an upregulation of vascular endothelial growth factors, which causes angiogenesis and thickening of capillary basilar membrane. Now, why all of this? Because muscle is a metabolic organ. Now, if a patient with an active ulcer is prescribed non-weight bearing, I beg of you, non-weight bearing does not mean total bed rest. Like Dr. Lakshmi said, upper body strengthening exercises have to be given to prevent sarcopenia. I will show you a few slides later as to what the type of exercises can be given, but I please take this as a take-home message. Even with active wound ulcers, do not advise them total bed rest. Advise them non-weight bearing, but not total bed rest at any given costs. Why? Because active strength training reduces the pro-inflammatory cytokines, like Dr. Bavadarani already mentioned. It reduces the IL-6, interleukin-6, CRP and other things. But moreover, it is a psychological boost to the patients. Imagine someone with a foot ulcer asked not to bear weight on their foot and they're being, I wouldn't like to use the right words, but bedridden all the time. It is a huge psychological dump. But when you give them active upper body strength training exercises, they have a huge boost in their confidence. Now, these are the clinical protocols. I don't want you to stress too much. Obviously, one size doesn't fit all. That is my disclaimer. Please do not use the same thing for everyone. These are just some of the exercises that can be used. Obviously, it has to be done under supervision. I would request you to work with an exercise specialist or a physiotherapist, because you need to move from an area of passive loading to an area of active loading. Now, in the next slide, we will see on how to strengthen the intrinsic muscles. These are one of the two exercises. One is the marble pickup. Ask the patient to sit on a chair, pick up marbles with their foot and keep it on the other side. And the other one is a towel curl. Now, this helps to stabilize the ankle joint and offload the pressure of the MTP joints. Now, anterior posterior swing is controlled by dorsi and plantar flexion. We all know that. And the medial lateral sway is with inversion and eversion. So we have 4 planes at which we should strengthen. We can do this using the resistance bands, which show us all the 4 areas with which you can use to strengthen the ankle stability. I'm just going to let that play out. Now, we've finished the intrinsic muscles of the foot. We've stabilized the ankle. What next? That's where comes the calf complex or the soleus pump. We start off with the right side. I'm just going to play the right side first. You start off with the seated isometric exercises, then shift to a standing calf raises, which again gradually you can progress with load, without load. First seated without load, seated with load, standing without load, standing with load, and thereon. Now, unless this entire lower limb kinetic chain is not fixed, starting from the foot, ankle, calf, hip, correcting the pelvic anteversion, we are going to see patients with recurring foot ulcers and or a high-risk patient who can be prevented from having one, developing one eventually. These are some of the upper body strength training exercises. It's already been touched upon, but what I would like to add is that your body does not understand whether the weight that you're lifting is a dumbbell, a barbell, a kettlebell. It just understands load. Use anything as simple as a 250-gram soap packet, because that is also an additional load to the body. You can use soap bars, soap packet, salt packets, rice, sugar, or just simple take a backpack, fill it with books or full water bottles. Use water bottles as dumbbells to give your body load, but give it load. Upper body exercises of the chest can be done, for example, chest press, chest fly, rear delt fly, which you see over there. That is chest press. that is your shoulders, which is your front raises. These are you can take a picture, it's pretty self-explanatory. You work on different muscle groups, chest, shoulders, biceps, triceps, back. Your back exercises are usually only your seated rows, which you can give with a resistance band, but you can also give exercises for your back with a dumbbell in supine position, which your exercise specialist will be able to guide you with. Now, the do's and don'ts. When you have an active ulcer of grade 1 to 5, when you have a Charcot's foot, or you have an ankle brachial index of less than 0.5, absolute contraindication to weight bearing. So none of those exercises as of now. Once the epithelialization has happened, you can start off gradually. What I would recommend you to do, examine your foot daily, wear protective footwear, and never, 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 ever exercise barefoot. So this is my plea to all of you to shift from a reactive response of just offloading protective footwear and non-weight bearing into an active response of restoring muscle mass, restoring the microperfusion, as well as the entire lower limb kinetics all the way from the ankle up to the hip. If not, we're going to continue seeing patients coming back to us, and patient life care is going to not improve as much. So this is my plea to shift the paradigm of thinking from a non-weight bearing to an active prescription protocol. Obviously, there are do's and don'ts. When you're not supposed to weight bear, don't do that. When you are, please go ahead and follow some of the guidelines that I've just spoken to you about. Thank you. I would like to also add, thank you RK sir for giving me this. He's my mentor. Thank you for giving me this opportunity in presenting this lecture today in front of this esteemed audience.
Thank you, Doctor. There are a few questions.
This is directed to Sriram sir. Usage of steroids in diabetics with rheumatoid arthritis, what is your advice? What is your take, sir?
Usage of?
Steroids in diabetics with rheumatoid arthritis.
Oh, that is purely under the rheumatologist's purview.
I
manage the complications of, if they decide to stop steroids, that's where my role comes. I am there to taper, I am there to get off them. And we manage some of the complications of steroid, which includes the problems with glycemia, metabolic problems, and osteoporosis. So I am a steroid complication expert, not a rheumatology steroid expert.
And another question
But
for you, sir.
Definitely, don't be afraid of steroid. As Dr. Sriram said, you consulted a rheumatologist, taper down the dose. Please do not avoid steroids. Whenever it is necessary in autoimmune disorder, please allow them to take. It has to be tapered. They will advise everything. Don't be afraid of steroids.
Last question to Sriram sir again. What AA did you use, sir?
This is Claude. That's a good question.
Thank you. Now I request Dr. Saravana Kumar to felicitate our speakers, Dr. Bhavadarini, to Dr. Bhavadarini, to Dr. Sriram, to our moderator and speaker, Dr. Anirudh Deepak, thank you, Dr. Saravana Kumar. Now we move on to session 3, decoding diabetic foot infections. I request the moderators, Dr. Rajesh Keshavan, Dr. Aravind Rajagopalan, to come to the dais, followed by our speakers, Dr. Erika, Dr. Suresh Kumar, Dr. P. Sendur Nambi, Dr. Milent, Dr. Belahali, Dr. Pavan, thank you. Now we move on to the first session by Sendur Nambi, sir. Dr. Sendur Nambi. antibiotic decision making.
Very good morning. I think there is a small change in the jumbling in the order of the sessions. Thank you for accommodating it. I may have to leave a little early. The question is antibiotic decision making in diabetic foot infection. As people try to simplify antibiotic choice by looking into the culture report and then giving an antibiotic, but it's not as simple as that. So I think the focus is always on the patient as a whole and not the disease or not the culture report or the drug. So if you want to get the antibiotic decision choice right, we need to understand the patient. I think that is much more important than the diagnosis, the treatment, all those things. The question is, does your patient have infection or not? That's the first fundamental question to be answered. So that's the first question. If there is no infection, no antibiotic, and of course we all know in viral infections, no antibiotic. And if there is a bacterial infection, we need to give an antibiotic. It's as simple as that, but following that in day-to-day practice is actually very, very difficult. So sometimes that becomes the most complicated decision with respect to the choice what to do. What is very important is before even we react to culture reports, we need to understand the fact that the number of microorganisms that we have in our gut is 10 to the power of 14. The number of cells that we have is around 10 to the power of 11. So we have more microbiology living in our gut than the number of cells. And if you want to take the skin microbiome into consideration, that's a huge, huge numbers. So the question, you have to understand that just because there is a culture report that is positive, we should not be reacting to it. So it's always the clinical diagnosis. Is your diagnosis an active infection or not? If there is an infection, then it assumes significance. If the clinical diagnosis is not an infection, then let's not jump on to reacting to culture reports. The terrain is everything, the germ is actually nothing. Because we live with germs, we have to understand that. And we are actually 80% bacteria and 20% cells. That's the body mass volume. I'm 80% bacteria, and so you are. Please understand that before reacting to culture reports. And whenever you have made a clinical diagnosis of skin and soft tissue infections, you always try to understand which layer is involved, what is the localization, and whether it is a localized problem or a multifocal problem, is it an acute problem or a chronic problem. It's all clinical assessment, definitely. Is there a deep involvement? So is there a muscle involved? Is there a bone involvement or is joint involvement? Is it an exogenous infection or it is a hematogenous, endogenous? And then always you look into the host. So these are the questions that has to run through our mind whenever we have a patient with suspected infection in the foot. And why this distinction is important is you may probably get your organisms right if you try to localize based on the clinical diagnosis. When you get the organisms right, then we can get the antibiotic choice right. So it's very important when you think about an antibiotic, we need to always see where is the problem, what it could be due to, then you go for the antibiotic. The moment we see the problem, you're not going to give the drug. So you have to try to localize there. If something is at the epidermis, you're looking at impetigo, a dermis, or hair follicle, you're looking at folliculitis. At dermis level, it is usually erysipelas, subcutaneous fat, cellulitis, facial involvement, fasciitis, muscle involvement is pyomyositis. In general, whatever localizes to the skin and subcutaneous tissue is always gram positives. It will be either streptococcus or staph aureus. Anything deeper can be something else. There are tons of microorganisms. To simplify it, for a foot doctor, gram positives, streptococcus pyogenes and staph aureus. At times in long-standing ulcers, you may have this pathogen called enterococci. They are very rarely a community-acquired problem. Someone who's been exposed to antibiotics, procedures, or surgeries, that is when you may have the enterococci. Otherwise, a gram-positive, what you people have to understand is only strep pyogenes and staph aureus. Among the gram-negatives, it's usually the Enterobacteriaceae, the E. coli, Klebsiella. And again, someone who's been exposed to antibiotics procedures, you're looking at Pseudomonas acinetobacter. So these are all the 7-8 pathogens that a foot doctor has to be familiar with. And it's all clinical diagnosis most often times. Most of the times, the patient gives you the answer. The first picture is actually erysipelas. You're looking at involvement at the dermis level. It is usually Streptococcus pyogenes. Nothing else can cause erysipelas. And you're going to give ampicillin, amoxicillin. That is where it is. Cellulitis can be deeper when it precedes trauma, something like that. Again, it is strep and staph. So you may have to give a slightly broader cover. And patients with recurrent foot infections or recurrent cellulitis, it's a common outpatient consult for us. You always look for the antecedent factor. It could be a tinea pedis, that is the nidus for the bacteria to germ. Enter in if there is a psoriasis, eczema, scratching, saphenectomy, stasis ulcers, all those things are the inciting factors. With cellulitis, it's predominantly Streptococcus pyogenes and Staph aureus. With abscess, pus formation, you're looking at Staph aureus. With necrotizing fasciitis, it could be either monomicrobial, where it is a predominantly gram-positive syndrome, or it could be polymicrobial, where you have gram-positive anaerobes, and then you have the E. coli, Klebsiella, all those things. And we need to understand that any of these problems can be accompanied with toxic shock syndrome, where your patient is sick. Cellulitis, the antibiotic choice for an admitted patient is going to be cefazolin. Cefazolin, nothing else is required, cefazolin. If you want to give an oral therapy, cephalexin or amoxiclav is fine, because your top organisms is Streptococcus pyogenes. 80 to 90% is Streptococcus pyogenes. 10 to 20% you may have Staph aureus. Amoxiclav or cephalexin is an outpatient treatment. As an admitted patient, cefazolin is more than enough, or you can give cloxacillin also. Someone with a deeper involvement, you're looking at covering your gram-negatives like E. coli, Klebsiella, Pseudomonas, then you end up giving your piperacillin tazobactam or ceftriaxone sulbactam, or if your patient is sick, you're going to give carbapenems. And if you want to cover an MRSA, in that situation, you may choose upon clindamycin or linezolid. These two drugs have an additional effect in terms of, since they are protein synthesis inhibitor, they inhibit the production of toxins also. So that way, clindamycin and linezolid gives you an extra antibiotic action in terms of toxin synthesis inhibitor. This is the data from our hospital, looking into around 200 odd patients with strep pyogenes. With strep pyogenes, serious infections. As far as strep is concerned, ampicillin is the king. Crystalline penicillin is the king. If your diagnosis is streptococcal pyogenes cellulitis, clinically or whatever it is, all you have to use is only crystalline penicillin or ampicillin, ceftriaxone. The drug that we like, clindamycin, if you look into the data that we have, 20% is resistant, strep pyogenes. Clindamycin doesn't cover 20% of your MRSA. Whenever you depend upon clindamycin to cover strep pyogenes, this is local data from our own center. Please remember that. If strep pyogene cellulitis, the drug to be used is just plain amoxicillin, ampicillin. Nothing else is required. You don't need anything further. Even amoxiclav is not required for strep pyogenes. All you need is only ampicillin, amoxicillin, crystalline penicillin. So standard centers, academic centers like Christian Medical College, Vellore, they use crystalline penicillin as the treatment for cellulitis. They don't give anything further because it is strep pyogenes. As far as strep pyogenes is concerned, penicillin is the king, without any doubt. With respect to Staph aureus, you may have it as a methicillin-sensitive Staph aureus or methicillin-resistant Staph aureus. Linezolid, always think twice before writing it. Tedizolid overcomes the side effects of linezolid to an extent, but it does not negate it 100%. 55 years diabetic hypertensive, went for a pilgrimage, Sabarimala, comes back to the emergency with just 4 days history, and that is where it is. We all know that it is not a simple cellulitis. It looks much more deeper. There is skin sloughing, and there is an inflammatory reaction, blood pressure borderline, tachycardia, there is white cell count that is high. So the diagnosis becomes necrotizing fasciitis. It is not a simple cellulitis, it is deeper. So whenever you have pain disproportionate to the physical findings, you have violaceous bullae, cutaneous hemorrhage, skin sloughing, skin anesthesia, rapid progression, or when there is systemic features in terms of patient is an inflammatory response, the problem lies much more deeper. In that situation, simple oral drugs would not work. So what antibiotic can I give in that situation? Ceftriaxone, probably in this day and age, we would not start it empirically. It may be a tailored therapy, maybe. But for a workhorse antibiotic would be either piperacillin tazobactam plus linezolid or piperacillin tazobactam plus clindamycin, or we could use cefporazone sulbactam plus linezolid or clindamycin for a patient like this. Patient is sick with multi-organ brewing kind of thing, then we have to use a carbapenem plus a gram-positive cover. The gram-positive cover for this would be either linezolid, that is what would work best for it. Drugs like colistin, amikacin, they're exclusive gram-negative antibiotics, poor soft tissue penetration. So when you use these drugs, you need to keep that in mind. No gram-positive cover, zero anaerobic cover. So we need to keep that whenever you give colistin and amikacin. Most of the beta-lactams, whatever you and I use like pip-taz, cefporazone, sulbactam, covers most of the gram-positives, not the MRSA, and it has very good anaerobic coverage. At times, patients who've been exposed to procedures or multiple hospitalizations, we do have this carbapenem-resistant Klebsiella, E. coli, Proteus, all those things cropping up in the reports. For that, the drug to be used is colistin, polymyxins, but it has got a poor soft tissue penetration. So the purchase out of that drug, which is toxic, is going to be bad. So you may have to use either fosfomycin, tigecycline, ceftazidime avibactam, or this combination of ceftazidime avibactam plus aztreonam, or there's a newer drug called aztreonam avibactam. Minocycline is a wonderful drug. Sometimes you may have to use cotrimoxazole chloramphenicol. It all depends upon the culture report. But let me tell you, this is not for empiric therapy. This is definitely not for empiric therapy. The ceftazidime avibactam, aztreonam avibactam, all those things. Because zero anaerobic coverage, 0 gram-positive coverage. You cannot use this alone. These are drugs to be used only when you have a culture report which says that this is the only drug that would work. Otherwise, the workhorse antibiotic is always going to be a carbapenem plus linezolid, clindamycin, or a pip-taz or cefporazone sulbactam. They are very good workhorse antibiotics. These drugs are not good workhorse antibiotics. For example, like a drug like tigecycline, it does not cover Pseudomonas. It does not cover Proteus. And Acinetobacter, it's not 100% coverage. It's an excellent drug for skin and soft tissue infection. But don't use tigecycline empirically in all situations. If you have a carbapenem-resistant Klebsiella, which is the cause for the soft tissue infection, in that situation you can use. Empirically using tigecycline, not a good idea. All the drugs that I mentioned in the yellow, all of them have big gaps in coverage. They are not good empiric choice of antibiotics. With respect to gram-negatives in India, if you're looking at an ESBL producing E. coli, Klebsiella, what it means is ceftriaxone is not going to work as per the report. The drug of choice is always carbapenems. Beta-lactam, beta-lactamase inhibitor like cefosel, pip-taz are appropriate choices. Empiric carbapenem-resistant gram-negative cover, you may have to use polymyxins plus other agents. Other thing is all not as an empiric therapy. Let it be your ceftazidime avibactam, aztreonam avibactam, or ceftazidime avibactam, aztreonam avibactam, or ceftazidime avibactam plus aztreonam. You need good microbiology backup, without which you cannot use all those agents. Just 2-3 real-life cases. This is actually Dr. RK's patient. I do not know if he remembers actually. It was in a different hospital where I had seen on his request. 50 years diabetic male, poor control history of RTA. The wound looks pretty bad, and had some positive organism and all, and a gram-negative like Kleb. This was the wound. This is actually a picture he shared with me. I don't know whether he recalls that actually. So this is how the wound is. This is on good doses of linezolid and meropenem. And you're given the organism cover and patient is not getting better, and you obviously know that something is eating away the flesh there. This is a gram stain. Patient had Clostridium. So it was actually Clostridium actually. 60 years lady post intramuscular injection developed a gluteal abscess, debridement, multiple debridements, and that's how the wound looks like. And this is the antibiotics this patient had got exposed, multiple antibiotics. This is how the wound looks like, because all of us will think of some bacterial infection. This patient had mucormycosis, inoculation mucormycosis. So this was not a bacterial infection. So when a patient is not improving on your routine antibiotics, of course all of us think that this antibiotic is not working, let me step up. that may not be the right strategy. Reanalyze what you're dealing with. Tissue histopathology, tissue for fungal smear, fungal culture. All those things are very, very important in such situations. So when you look into antibiotics, you always look into, there is a so-called Indian dream. So a drug like linezolid, which is a restricted antibiotic in the West. Restricted antibiotic in the West. Here, thanks to Indian generics, there are multiple companies at very low rates. But if you don't have a mechanism by which you're going to ensure its use, a drug like linezolid in a country like US, a cardiothoracic surgeon or neurosurgeon cannot write. Cannot write. If they write, the pharmacy will not dispense. You need a clinical pharmacist, ID people kind of endorsing its use because they want to kind of reserve it. So this is where it stands. So you may have some X, Y, Z new molecule coming into the market, but unless you have some science behind its use or some kind of a regulation with respect to how it should be used, it's going to be a problem actually. And that's my last slide. This man, when he discovered penicillin, he got the Nobel laureate on the same year itself. This man said, penicillin should only be used if there is a properly diagnosed reason. Penicillin, okay, not our carbapenems kind of things. If it needs to be used, use the highest possible dose for the shortest time necessary. Unfortunately, Indian clinicians like you and me do the reverse. We always use the lower dose and longer duration. But this man said, use the highest possible dose. Of course, you should not have any toxicities. Of course, you look into that factor. Highest possible dose for the lowest duration. This is where it stands. I think with that, my time ends, and that's my last slide also. Thank you.
Thanks a lot, sir.
Welcome, sir.
I think a number of newer drugs have come against MRSA, the oral ones and all. Would you recommend using them in severe infections, gram-positive?
I think tedizolid we don't have as an IV preparation. If patient is sick, admitted, I would always prefer IV linezolid. Tedizolid, definitely, we don't have an IV preparation, so I would not use that. A drug like levonadifloxacin, which is probably available only in India, not in other countries. So we can use that. There's a data with a lot of antibiotic with a lot of data. But the only problem with the levonadifloxacin that I see is you don't have proper cutoffs in terms of standard microbiology criteria. It will be the CLSI or UCAST. So they have to give cutoff points with respect to how to reinterpret a susceptibility interpret. That is not standardized for levonadifloxacin, but it's an excellent molecule. That molecule has an advantage of giving us an IV plus oral. It belongs to the fluoroquinolone class, so it has got an excellent soft tissue and bone penetration. We can use that, and I think the people have used with very good results, levonadifloxacin. Tedizolid definitely as a follow-up therapy for linezolid with less side effects. Actually, tedizolid fits in very, very well.
Anyway, thanks a lot,
Thank you,
sir.
friend.
I think Dr. Sendur Nambi is
Doctor.
leaving for an emergency, so I'll...
Yeah, thank you, Doctor.
I'm
now
sorry.
I request Dr. Rajesh Keshavan to felicitate our speaker, Dr. Sendur Nambi. Dr. Suresh Kumar, please do come to the dais, sir. Thank you, Dr. Sendur Nambi. Now we move on to the next session. Suresh Kumar, sir. Okay, Dr. Erika.
May call upon Dr. Erika. She'll be talking to us on deep tissue sampling.
Good morning, everyone, and thank you, Chairman, for the introduction. So, infection can be considered the great destroyer of diabetic foot. Let's consider that diabetic foot infection remains the most frequent diabetic complication requiring hospitalization and the most common precipitating event leading to major amputation, and also can be a life and limb threatening condition. let's consider that infection can develop in 50 to 60% of ulcer, approximately 20% of moderate and severe diabetic foot infection can result in a major amputation, and the 1-year mortality rate after hospitalization due to severe diabetic foot infection can approach 20 to 25%. But why patients with diabetes are so vulnerable to infection? Now, we know that diabetes can lead to complications like peripheral neuropathy, peripheral arterial disease, which are the contributing factor in leading to diabetic foot ulceration, but also diabetes can be responsible of immunological dysfunction, which increase the susceptibility for this patient to develop infection. So those ulcers easily become infected, but also we need to consider the anatomy itself of the foot. So the foot consists in different compartments, and those compartments are intercommunicating between them. So it's very easy for a superficial, simple infection to spread contiguously to the deeper tissues. In terms of classification, this is the classification according to the International Working Group of the Diabetic Foot. We can distinguish mild infection, local swelling, erythema, more than 0.5 or less than 2 centimeter, moderate infection, erythema spreading more than 2 centimeter, and it is an infection with no systemic manifestation, and a severe infection, any foot infection associated with systemic response. We can see in this picture early sign of infection, so the base of the ulcer from pink granulation can change to gray, yellowish tissue with increased friability and increased amount of exudate. And it's very easy, as I said before, for this superficial infection to spread very quickly through the adjacent tissues and bone. As we can see, this patient came with this ulcer which is mildly infected, and then look in the next few days, this is a patchy necrosis which was associated with infection. The perfusion of the patient was absolutely fine, so it's a necrotic infected patch. And we can see osteomyelitis at the 5th metatarsal head. The patient underwent reamputation, and after intense wound care, we can see granulating tissue. Another example, this patient as well came with this heel ulcer, seems a superficial infection, quite manageable, we would say, but see how can spread very quickly. Another heel necrosis. We can see some gas in the X-ray, and extensive debridement. So this patient went to the theater very quickly. Extensive debridement, intense wound care with VAC therapy, and then granulating tissue. Another example, emergency department. This is a foot attack. Look, spreading cellulitis. Look, after 18 hours later, we have gangrene spreading. Infection, and 1 day after surgery, because of course the patient underwent toe amputation. So it's crucial to assess the severity of the infection. More is the severity, more is the hospitalization, failure to resolve the infection, risk of sepsis, amputation, and death. This is the pathway of the management of diabetic foot infection according to International Working Group of the Diabetic Foot. I'm not going through all the pathway. I want to focus on the first bit of the pathway. So when we suspect diabetic foot infection, we need to assess, of course, the patient from a foot point of view, neuropathy and a peripheral arterial disease, but also address the medical comorbidities of this patient, because those patients are very complex from a medical point of view, and assess the wound, cleaning the debridement, determine if we need surgical consultation. Very important, specimen for culture. Why the specimens are crucial? This is because diabetic foot infection are polymicrobial in up to 50 to 60% of the cases. So this makes the treatment very complex, and an inappropriate treatment, if we not recognize the real pathogen, can lead to prolonged infection and higher recurrence rates. Which specimen? So tissue debrided from the base of the wound, pus, bone taken intraoperatively or via sterile procedure. According to the International Working Group guidelines, we recommend a tissue sample if we suspect a soft tissue infection, bone sample if we suspect an osteomyelitis intraoperatively or percutaneously. We can see an example of a swab or a deep tissue that we normally do every day in our units. But what about the difference between the swab and the deep tissue? According to literature, the deep tissue sample can reflect the true infecting pathogen that are causing the deeper infection. They present the minimized contamination and are more effective in detecting resistant and anaerobic bacteria. And why is important to obtain the proper sample? Because the aim is to target the therapy, to treat the real pathogen, lead to the infection, so reducing the risk of antibiotics resistant and reduction of the broad spectrum antibiotics use. This is according to Lipsky, as the colleague showed early before. The main pathogen isolated usually is a gram-positive Staphylococcus aureus, followed by anaerobes, Pseudomonas, and others. This is another study. As we can see here as well, Staphylococcus aureus is the most common. But what about the study comparing the tissue samples and the swab in soft tissue infection? So in this study, we can see that there is actually a concordance between tissue and swab sample, but for mild infection, grade 2 pedis grade. But in the grade 3 and grade 4, actually there isn't a concordance. And actually, in this study was shown that the tissue sample were more effective in detecting also gram-negative and anaerobes. This is another recent study, the CODIFY study, where they evaluated the concordance between swab versus tissue sample, and we can see also here that the tissue sample are more effective in detecting more pathogen. There was a high rate discordances between swab and tissue with more pathogen and fewer contaminant reporting from tissue specimen. What about the osteomyelitis? So we suspect diabetic foot osteomyelitis usually in large ulceration, deep ulceration, long duration of ulceration, and usually in exposed bone and joint wound. And also those patients may present with raised infection marker or, for example, white cell or ESR and CRP. However, let's keep in mind that because of the immune dysregulation that those patients can have because of the diabetes, sometimes severe infection can present without a real systemic features. What do we do in osteomyelitis? Which sample? As I said before, is recommended, of course, a bone sample. But if we are trying to manage the osteomyelitis without an aggressive surgical management at the beginning, we could recommend a bone biopsy to confirm the osteomyelitis and document the real pathogen. I'm talking about percutaneous bone biopsy. I don't have a picture here, unfortunately, of the percutaneous bone biopsy procedure, but in literature has shown the percutaneous bone biopsy to be very effective in detecting positive cultures, is quite safe, and as we can see in this study, And we can actually perform a percutaneous bone biopsy in a clinic setting under local anesthesia. Is a very easy procedure, which may take 30 to 40 minutes. Usually, we discuss those patients in the MDT. We decide the angle of the introduction of the needle, which usually is 1 or 2 centimeters away from the ulcer. Can be done by trained podiatrists, surgeons, also trained physicians. And in particular, in our unit, we use percutaneous bone biopsy in 2 different type of groups. In non-healing patients with suspected osteomyelitis, to allow to target the antibiotics therapy and direct the trajectory of care, as we can see in this picture with the first to osteomyelitis. But there is also a particular group of patients where the percutaneous bone biopsy can be very useful, which are the patients undergoing Charcot reconstruction. So Charcot reconstruction, in particular in patients with infected Charcot, can be very challenging. As we can see in this example, this patient presented with osteomyelitis, was planned to have reconstruction. He had first stage reconstruction to remove the infected bone, and this is the post-operative X-ray after the first stage. So the first stage consists in removing the infected bone, and after a few weeks, normally we proceed with the final fixation, but we need to be sure that those patients don't have any infection. So in this type of patient, we can actually perform a bone biopsy to be sure that there is no residual osteomyelitis. And bone biopsy in this patient, as example, was showing no infection, histopathology, just reparative changes, and the patient underwent the final stage of Charcot reconstruction. So the percutaneous bone biopsy can be very safe and can be feasible, can be done in an outpatient setting, and can be facilitated greatly to target the antibiotics therapy. So in summary, deep tissue samples are superior to superficial swabs. Accurate cultures enable target antibiotics therapy. Proper sampling reduces contamination and inappropriate treatment. And deep tissue samples supports better outcomes and limb preservation. Thank you very much for your attention.
Thanks a lot, Dr. Erika. I think we will have the questions at the end of this sessions. Okay. Next, I would welcome Dr. Suresh, a very good friend of mine. He is going to talk on understanding culture and sensitivity reports. How do you interpret culture and sensitivity reports? So that is the base of this talk.
Good afternoon. At the outset, I would like to thank the organizers and particularly Dr. Rajesh Kesavan for providing this good opportunity. I think most of the things is covered by the previous speaker, and my other previous speaker also had spoken there. So I'll straight away begin with the case because this is a lunch session. I know you are in pre-prandial state. This is a 60-year-old male, diabetic of 15 years durations. He underwent recent temple visit with the barefoot walking he did recently. No fever, no pain. The ulcer is non-healing. He tried a lot of antibiotics, but nothing is moved forward. This is 1 month picture. I put a QR code there, so those who want to participate, those who want to reveal your answers, just go to the QR code and try to answer there. So what is your choice? What will you do now? How many says I want to take a wound swab? How many say I want to take a tissue culture? Just scan the QR code. The results will come to you. You can choose there. So instead of lifting your hands, just scan the QR code. Okay, good. Couple of people are scanning. Other people are stuck. So just scan the QR code. So what will you do now? I'll give the choices there. Take the wound swab, take tissue cultures, take bone sample. I think this is a pre-test to post-test to my previous speaker. Image first, start antibiotics. Okay, Already antibiotics tried. So I think hereafter, whatever cases I'm displaying, the QR code will come to you. You just scan it and answer it there so that we can have a discussions towards the end of our panel discussions. So before that, my disclosures, I'm a least earning specialty is infectious diseases there. If you see any specialty that's least earning, because we don't do any procedure. People who are making procedure like orthopedic surgeons, plastic surgeon, podiatric surgeon is missing here, but people are doing some surgery, they make money, they create problem, but we solve the problem, we don't make money. People creating problem, they are making money there. This is a paradox of medicine, but that is not, my objective is not that one there, to make you lose money, you want to make money, but my objective is only 5 things. We usually say in antibiotics, 4 things is there or 5 things is there. Right patient should get the right antibiotic, right dose and right duration. This is for the 4R. We always say 4R for antibiotic. Right patients, right antibiotic, right dose and right durations. Even not only the antibiotics, a test also, it's called a diagnostic testing also has got 4R. The right patient should get the right test. Not everybody should. Right patients, right sample, right test and right interpretation. That's most important thing. How to interpret the test is also most important thing. So we don't want any major things. I want a simple things to solve the problem. I don't want any major things to solve the problem. Simple things, I'll do the thing. So this is my talk for next 10 to 15 minutes. Again, this is a QR-based question. So this is a case there, 56-year-old male, diabetic, left foot, diabetic foot. He underwent, because of a lot of things he had tried, then finally he underwent below-knee amputations. Ordered, this is a site of the below-knee amputations. Small gap is there. If you see the small gap is present. Whether this patient needs testing, I'm not saying swab, this patient needs any microbiological testing. On the other hand, left side, if you see the person has got 60-year-old male, diabetic, the case what is shown. Who needs microbiological testing? Either on the patients on the right side or the patients on the left side. Who needs testing? Or 1 and 2, you can put it in the chat. 1 is on your, according to you, you are on the, your left side. And the second one is the right choice, right side. So just go and answer which one needs testing, not antibiotics. So managing infections need 3 things. Going to the war. When we go to the war, we need to know who is my enemy. And we need to know what weapon I'm going to use, that's a drug. And what sort of surface or where I'm going to fight, that's called the host. So which host I'm going to deal with it. As far as infection is concerned, we need to know 2 things, particularly the host, what sort of host the patient has got, and second thing, what is a bug or syndrome, then only comes the drug. Already the drug has been completed, so we need to know the 2 things. So for example, this is a big question. When you come across a diabetic foot ulcer, people always want to know to swab or not to swab. This is a bit difficult thing because we can't go for always. Most of the people are diabetologists also, not all podiatric surgeons. So as a diabetologist, when you come across a surgeon ulcer, whether to swab it or whether not to swab it. This is a difficult question people want to know. But as far as a diagnostic stewardship is concerned, my previous speaker clearly told there is no point in doing the wound swab. There's no point in doing the wound swab because it creates, I'll come back, one of the critical comment about doing a wound swab there. So right patients means which patients needs testing. I don't say wound swab, which patient needs diagnostic testing. That's the thing we need to answer. The person who has got infected, in antibiotics, again the antibiotic stewardship, what we do, first thing when we go to the patient say, I need to write the diagnosis. Before I ink my antibiotic, I need to think my diagnosis, what I'm thinking. Whether the person has got infected foot or it's a non-healing ulcers, just non-infected ulcer. So I need to think about whether the person is infected or not. That's the first mantra. If it is needed, second step only, I need to confirm with appropriate test. Not everybody needs test. Appropriate test for appropriate patients. Then if I start some antibiotic, I need to reassess whether it's really required or not, and short is sweet. That's most important thing. So which patients needs testing? These are all the patients needs testing. I'll show the guidelines to you. If you see what is a bottom line here, this is a busy one, but what is the bottom line? If you see all the things, infected, 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 infected. If you see infected, infected, infected only, you need to do the testing. Non-infected doesn't testing. So people ask how to find out infected. That's the bottom line. So this is the guidelines I use to find out the thing. This is the latest May 2026 publications. So how to find out? Sorry, I think 1 second. I failed to do. Okay, so when to think, this is I put an animation, but animation is not working there, no problem. So what I need to do, how to check the infections, clearly told. The infection means the person should have tenderness, purulence, some discharge, erythema. Classic signs of our inflammations. Redness should be there, swelling will be there, pain will be there, and purulence will be there. Similar, this is for cellulitis. I put behind this a cellulitis picture. When do you think cellulitis? This is a guidelines. For diabetic foot ulcers, lot of classifications, but we usually go with IDSA, Infectious Society of American Guidelines. Whether the ulcer is infected or not, how to do the same thing, whether the tenderness is there, what is the size of the lesions, surrounding erythema is there, whether purulent discharge is there or not. So we need to know about the signs of infections and what stage the person belongs to. So you need to find out whether the person has got infected ulcer or non-infected ulcer, or infected wound or non-infected wound. This is most important for you. So the first diagnostic step is whether the person needs testing or not, based upon whether the person is infected or not. How to find infected? This is the way we need to find out the infection. That's most important thing. This is simple thing. The person should have infection signs should present, at least inflammation signs. More than 2 inflammation signs present, yes, you can do. So this should be based on your clinical examinations, your clinical finding. You need to think the person is infected, yes, you can take it. The second part I'm coming, this is again QR based question there. So what test you want to do? I think the previous speaker alluded on this one. This is easy for you. Whether you want to send a wound swab, whether you want to send a tissue culture, whether you want to send a debrided tissue, because the person is posted for debridement. But if you see tempting lot of purulence, when you see obviously lot of purulence is there, people say, why I want to debride? I can take a swab of here. People want to know. So this is the most difficult, real practical changes we need to do. Again, if you do, what is the problem with wound swabbing? In the wound swabbing, there is no clear-cut guidelines. If you see 22% of the time, how to take a wound swab, nobody discussed it. And what method I need to clean before taking the wound swab. Don't do wound swab. If you do a skin swab of you, almost all the skin contains Staph aureus, Klebsiella, Pseudomonas. If I do a skin swab of your skin, external skin, you carry a lot of Pseudomonas Acinetobacter. You are not treating yourself. Similarly, if you do the wound swab, the chances of picking resistant bugs are very high. So why? There is no cleaning protocol, there is no proper sample. For example, 22% of the studies does not know how to take a wound swab. And almost 40% of the study says how to clean the wound swab how to clean the wound before taking sample. This is why wound sample is a bit difficult for us. And this is another 2004 paper, old paper. Always, if you do the wound swab, what is the other problem? Some of the fastidious organisms like your streptococcus or nutritionally variant organisms is very difficult to grow. And sometimes it creates a lot of confusions. Polymicrobial growth can happen. That is why best thing is either aspiration, minimum is aspirations, ideal is a deep tissue, clearly alluded by previous speaker, what we need to do there. If you think osteomyelitis, go for a bone tissue, that's most important thing for that. So this is a paper I'm talking about, how to diagnose infection. This is a old paper, 2004, but it's still valid today also there. So in short, the person should better to take a tissue sample rather than wound swab. That's the bottom line. Wound swab misses a lot of things and wound swab create a lot of confusion. That is why I try to avoid wound swab. So the second part what I covered is now what is a sample? What right sample? Right patients, infected patients. Right sample is the person should take a tissue or the deep sample or aspirated sample. Why we call the wound swab? This is called the zombie test. What is zombie test? Zombie test is a term we commonly use. Can anyone say, apart from the wound swab, what is a zombie test commonly we use? What is zombie? These tests are dead, but we are giving life to the test. We are keeping the test alive. What is the problem? If you're using the zombie test, 1, the diagnosis will be delayed. 2, the person will abuse a lot of antibiotics. That's called test called zombie test. Zombies are dead, but we are given life to the thing. The one common zombie test is a Vidal. Vidal is a useless test, but people are using it. We are giving life to the thing. Similarly, to make a diagnosis of antibiotic, people are using procalcitonin. Stop? Yes, but starting antibiotic, this is a zombie. And wound swab is a zombie test. That's a dead test, but you are given a life to the test. That's what we call the zombie. So this is the third part of it there. So what is a sample I told her? So what time? Timing also we need to know. Not only know that what patient needs, what sample needs, what is the timing of the patients. So the person already taking clindamycin, but unfortunately is taking some anticoagulant, so they want to do the debridement little later after stopping the clopidogrel and stopping the aspirin they want to do. So what will you do? You want to continue clindamycin, or you want to change it to IV, or add piptazo, or stop clindamycin? What will you do now? Please go ahead and vote. Please scan and vote. That's most important thing. So what are you going to do now? So what test? Ideally, without antibiotic, the culture yield is much better. If the patient is taking culture, we need to ask whether the person can stop the antibiotic. I need to get the bug. If you want to get the bug, please stop the antibiotics. Ideal time is 2 weeks, but 2 weeks is too long. So minimum is 48 to 72 hours. If you stop 48 to 72 hours before taking the cultures, the yield is much better. If you continue with the antibiotic, even for example, some of the cases posted for the debridement. If you post for the debridement, don't give your routine surgical prophylaxis. For example, people use cefuroxime. Don't give cefuroxime. Once you debride it, take the tissue out, then you can start the cefuroxime after taking the sample. So the yield can go up. This is not a clean surgery. For example, some of the cardiac surgery, I need to give antibiotic. But for this case, you need to take a sample, then you can give the prophylaxis or treatment, whatever you consider there. So don't give antibiotic. The right time is avoid antibiotics. This is my first case here, last case also. What test? So I told what will happen, right patients, right sample, right timing. Before antibiotics, the right timing. Non-healing wound, multiple antibiotics, tissue no growth. You did whatever, without stopping antibiotic, with stopping antibiotic, you did everything. So what will you do now? Treat culture negative diabetic foot infections. Amputate and send. The bone may be, because tissue is not yielding. Please go ahead and scan and answer. Do NGS. What is NGS? Next generation sequencing called metagenomics. A lot of things is coming up. So people will come and say, this is the best test, doctor, you can do. I can find out the organisms. Call the pathologist. What we need to do, or start ATT. If the wound is not healing, if the fever is not subsiding, that is malaria in India. If the wound is not healing or something is abnormal, that's TB. These things are not, ID doctors will not follow. We never start anti-malarial, we never start empirical ATT also. We make a diagnosis and start. So match the question. Does the patient has got appropriate sample, appropriate time, and the person is infected? Yes. If we answer the things, we need to know. We always said histopathology. Histopathology can give a lot of things. That's why I said call the pathologist. Histopathology can give answer. For example, fungal infection. This person turned to be a cryptococcus. So this is not going to grow in a culture. Suppose some of the organism is not growing, think about pathology support. Similarly, the person is immunocompromised, next generation, but next generation sequencing, it can pick up the live organisms and dead organisms. Very difficult to interpret. That's the most problem. It creates a lot of noise to you. Not only music, it creates a lot of noise to you. So next generation sequencing, all PCR can pick both live and dead organism. That's a problem with NGS as well as PCR testing. Culture is a gold standard, but proper sample. If the culture is not giving a clue, rely on histopathology. So what is the best antibiotic for this one? How to interpret the culture? That's my main topic there. So what is the best antibiotic? Can anyone say ciprofloxacin, colistin? Anyone can find the error in the culture report. Sorry for the poor quality. They put a lot of antibiotics. Which one should not be there? If it is a pseudomonas, I can find out whether this is a good lab or bad lab. Anybody can say, how many say this is a good lab? They given MIC, they given sensitivity, this is a very good lab. But as an ID doctor, when I saw, I doubt who signed the paper. People put cotrimoxazole, people put ceftriaxone, cefotaxime for pseudomonas. Ceftriaxone, cefotaxime is inherently resistant. Don't put in the pseudomonas. Cotrimoxazole will never act for pseudomonas. So don't put these things. So the lab should know, the microbiologists know, but most of the time the pathologist sign. Any report giving a long list of antibiotic, the culture is useless. The person give a short list and know what they're doing it, that's most important thing. Microbiologist should sign. For example, here people say, people want to compare MIC. For example, MIC of cotrimoxazole is low, but MIC of vancomycin. You should compare apple with apple. For example, if you want to compare with the linezolid, compare with the tedizolid. If you want to compare vancomycin, compare with the teicoplanin. Don't compare vancomycin with cotrimoxazole. That's a bit difficult. So we need to compare apple and apple, not apple and orange. So we need to know this is the same group, meropenem, imipenem, compare. But don't compare meropenem with ceftriaxone. Ceftriaxone is the third generation, this is a carbapenem. So we need to know what we need to interpret, that's the most important thing. For that we need to know the spectrum. I think my previous speaker would alluded. For example, anti-pseudomonas means cefotaxime will not work, ceftriaxone will not work, ceftazidime will work. So we need to know the spectrum. Accordingly, the microbiology lab will put the sensitivity. So these things you need to keep in mind. So how to read the culture report? Who signed it? What is the culture report? Everything we need to know. Unless we need to know, this is a bit difficult for you. If you don't have any lab, what we need to do? What is the common organisms? You need to go through the national literature. So we are working on the thing, what is happening in the community. We are collecting for UTA, what are the 3 common organisms. So we need to learn this one, what is happening in my community. I don't have a lab, I don't have a good lab. So these students go for a culture report of the community. That's most important thing. We are working on this, different sites. What is the 3 common organisms in meningitis? 3 in the pneumonia, 3 in the UTI, 3 in the skin and soft tissue. We are bringing your job easy for you. So in summary, patient who's got infected, do the cultures. If you want to do, tissue culture is more important rather than wound swab. Timing before the antibiotics, what test, culture is a gold standard. If culture is not giving, histopathology, AAP culture also we can do, and interpretation is most important thing. If you find very difficult to these things, you can use these guidelines we are creating, how to algorithm, how to simplify, we are giving everybody to you, so you can read. Because for example, any updates is coming to you too within your bedside. And this is my last slide. Thank you for the wonderful opportunity. Hereafter, don't do the wound swab. Thank you very much for the wonderful opportunity.
Thank you, Dr. Suresh Kumar. Can we have the next speaker, Dr. Milind Roque. He'll be talking to us on biofilm management.
Good afternoon, all of you. I, at the outset, would like to thank Dr. Rajesh Keshwan and his team for such a wonderful conference and exchange of ideas, and to share my views on this very important topic. So, diabetic foot infection itself is a very dreaded disease. Infection. So, but we have two important things that we should discuss: biofilms and osteomyelitis. I think Pawan is going to discuss osteomyelitis, so I will stick to my topic of biofilms, and today I'm going to discuss biofilms in this is the outline of my presentation. So diabetic foot scenario is more than 77 million diabetic patients in India, and double the amount of foot to be taken care of. 1 out of 4 diabetic patients have lifetime risk of developing chronic wound, and 1 out of 5 diabetic foot patients undergo amputation. In India, about 2 lakhs amputations are done. This is our paper on what is happening in Southeast Asia and in India through DFoot International. And the challenges of diabetic foot management, and the most important challenge which I'm going to discuss today is the biofilm. So it's a primary driver of chronic wound care failure, being present in 60 to 80% of all the chronic diabetic foot ulcers, DFUs. They directly elevate the risk of lower limb amputations by 14 to 24%. So in 1989, in St. Vincent's Declaration, they had advised certain preventive measures to decrease amputation rate by 50%, but we have still not achieved that, except Poland, and the Berlin Declaration in 2070 has reiterated this, how to prevent infections and ulcers in diabetic foot. So how do you diagnose a diabetic foot biofilm? So it is mostly clinical, heavily exudating wound bed covering with fibrinous or necrotic tissue, and requiring repeated debridement. It looks pearly white like this, and persistent wound infection despite the correct dose of and duration of appropriate antibacterial therapy. Microbiological evidence of localized infection by tissue culture is made, which is an evidence. So biofilm is a conglomeration of microbial species attached to an extracellular polymeric substance which covers, and this is the most significant aspect of biofilm, and it protects the microorganism from external threat. What does it contain? It contains polysaccharides, proteins, eDNA. Now these are the genetic material that it is imbibed in the external polymeric substance, and it has a role to play in giving antibiotic resistance and preventing the antibiotic to reaching the biofilm. Then you have water and biosurfactants. The water and the nutrients also has a different kind of methodology where it circulates in the biofilm. So you got a center group of dormant or core group of bacteria and planktonic bacteria living in this extracellular polymeric substance, which communicate with each other through a mechanism called as quorum sensing, where water and nutrients are exchanged. Genetic materials are also exchanged. Now the most important aspect is the EPS. It has got a mass diffusion which causes physical shield. So it prevents the antibiotics molecules which are large to go inside the EPS, and it not only physically inhibits, but when it goes inside, the EPS is negatively charged, and all the vancomycin and all the other antibiotics, aminoglycosides, are positively charged. It neutralizes it through electrostatic barrier. And then you have structural scaffolding. So it's a very strong, if you try to debride it, it looks very flimsy, but it regenerates. It's got a rapid reformative kinetics to regenerate. There is accumulation of beta-lactamase from different sources of bacteria, and that also causes the antibiotic to be resistant. Metabolic and oxygen gradient is generated. So the oxygen, it cannot reach the center of the biofilm, so it becomes a hypoxic state, and metabolism also is very low. So when the antibiotic, if at all, goes inside, in spite by your debridement, it doesn't act on a dormant cell. So some of the bacteria, they remain dormant, which is called as persister cells, and they reactivate once your antibiotic dose is lowered. So that is why you get recurrence in biofilms. Host-derived material, so they hijack the host-derived material, camouflage themselves, and it is not even responsive to the personal immunity of the patient. And in horizontal gene transfer, they are lying close to each other so much that the genetic material and the plasmid is transferred horizontally, and even the resistance is transferred to each other. So this is very important property of the extracellular polymeric substance which should be considered when you are treating. The biofilm timeline is adherence. Within few hours, it causes multiplication, and the adherence becomes very fixed. It anchors to the wound surface. Then there is multiplication, and a proper architecture of biofilm is formed. And then after some time, after a few days, it can liberate the planktonic bacteria, and you have this phenomena called SIRS, systemic inflammatory response. So to summarize, this is the planktonic infection with host, immune response less in diabetes, and different kind, the EPS, the persister cells, the stress response gene, the gene transfer, the genetic modulation which happens, it causes antibiotic resistance. So it happens only in chronic wounds like diabetic foot because of hypoxia, which is necessary for this kind of phenomena, decreased immunity of the patient, abundant necrosis, hyperbuffet or nutritional state where glucose is readily available for the organism to have nutrition, and prolonged inflammation, as compared to acute wounds which are rarely having biofilms, but definitely they have if something goes wrong. So this causes a persistent 80% of chronic wounds having polymicrobial, difficult to treat. The antibiotic resistance, you have to give very high, multiple times antibiotic dose, because they are all resistant, and this causes stalling of the wound. Some of the common bacteria which causes this kind of biofilms are Staphylococcus aureus, Enterococcus, Pseudomonas, coagulus negative Staphylococcus, and Proteus in diabetic foot. In UTI, you have Enterococcus faecalis and coagulus negative Staphylococcus. So biofilms are so difficult to manage because of chronic long-term infections, resistant to host defense such as phagocytosis and killing, difficult to diagnose, frequently recalcitrant to antibiotic treatment, and difficult to treat. Only cure may be removed. So the fact is to detect them early. So what do we have? We have new detection sensing devices now. First, we were relying only on traditional methods of microbiological culture, and then you have genetically, DNA-based analysis and RNA-based, molecular-based things. You also have scanning electron microscopy and confocal laser. These are all very expensive and only available in very research institutes and tertiary hospitals. Now we have sensors, bacterial species sensors, specific sensors, pH sensors, which show the change in pH of the wound, enzyme sensors, temperature sensors, and biomarkers, and wound film matrix sensors also. So we'll try to see one by one. This is the microbiological assays. So this is a very standard clinical microbiology that we do, and then molecular assays we do. This is a specific bacterial species and wound biofilm EPS sensor where the material from the wound is taken and mixed in a liposomal fluid which is having a polymer coating. So the bacteria, if it is having biofilm, it will cause a burst, and this burst is detected by the fluorescence of UV light which is put on this wound or the agar, if it is available. Mostly it is in the tube. So you require a clinical person who collects the thing, you put it in a tube, incubate it to 40 to 60 minutes, and then you put the UV light. You can sense a different, you will see the different colors that you come. In Pseudomonas, it is almost green. If you see Staphylococcus, it is blue. In the second method that you see is a visualization of polymicro population by putting 405 nm violet molecule light. Now this is used in Western countries where this is put directly on the wound. Now you don't have to collect in the tube, and there are cameras which can detect the porphyrins which are secreted by these organisms like Staphylococcus and Pseudomonas. So if you see, the difference between them is the source of glow in the polymer sensor is artificially added polymer or liposome, and in the natural internal bacterial proteins which is in the porphyrins or the direct camera that you see. So in the EPS, you have inside a diagnostic tube, whether on the porphyrins you will have directly on the patient's wound bed. In developed countries, the molecule light is used as the point of care. Also, the DNA sequencing is used. In India, we are still dependent on visual inspection and tissue culture. So that causes a delay in diagnosing and giving the right antibiotic dosing and the right antibiotic. So you have sensors like optical and electrochemical sensors, temperature sensors, which are having about it detects the temperature. The moment you find that the temperature is high, a UV light is focused in, and it is treated by UV light. Also, sometimes there is a gentamicin-like drug which is secreted. Now, this is again in research, and it will definitely be a game changer. Different biomarkers in wound films are noted. The principle of management of diabetic foot is basically debridement, then using a anti-biofilm strategy, and then reassessing the wound, whether it is healed or you go back to the debridement status. The debridement can be done by, so the conventional method is what I just described. The novel method is ultrasound debridement, metal-based nanoparticle, which is non-invasive, polymeric nanoparticles, and metal oxide-based nanoparticle therapy. There's some of the cases, a wound which having a classical biofilm, which was debrided, and immediately now we are using negative pressure wound therapy about 20 years back when the anti-biofilm strategy was not there, and we could achieve granulation tissue and put a graft. We have started now using cadexomer in most of the government hospitals where I am the head of the unit, and this can be again combined with negative pressure wound therapy, and we have this patient wound foot saved in spite of having osteomyelitis with biofilm. So iodine-related releasing dressings like cadexomer polyhexamide, and acetic acids are some of the antibiofilms that you can use. You get an opportunity of window between the debridement and the next debridement or dressing. So you can use barrier dressings, and you can use cadexomer and PHMB. A lot of studies have shown encouraging results by cadexomer where you have the iodine released in a sustained manner over 72 hours instead of direct bolus like povidone iodine. And it has also got a bead-like structure which is hygroscopic, which can act on the EPS. This is one of the burns patient, diabetic foot got burned during the Padayatra. So we did a debridement, put cadexomer and this is the healing. Evolvement debridement technologies, ultrasonic debridement, hydrosurgical systems. In ultrasound debridement, we can use the bubble technology with antibiotic like vancomycin, and you see with combination, you get a complete clearance of the greenish organisms. This is a small video on which water jet technology, which is available in India, if ultrasound is not available, and this is how the biofilm can be specifically removed without damaging the deeper tissues. Then you have nanotechnology, which can be used as the antibiotic, can be used with the nanoparticles, which can reduce the size and it can reduce the charge of the antibiotic negative, and it can go into the through the EPS system. Then there are metal nanoparticles which can be used, which causes the reactive oxygen species to be generated in the wound, and it can destroy the biofilm. These are some of the recommendations of how you will treat different kind of chronic wounds with biofilms, and these are available in this paper that was published in 2019. Next generation smart dressings are also available, which are having nanocomposites, utilize advanced hydrogels embedded with cerium oxide or graphite oxide, antimicrobial peptide matrices like bioengineered dermal substitutes, and Coram sensing inhibitors are now in the research pipelines. Bacteriophage and enzyme therapy is also going to slowly come as a deterrent to biofilm. You must have seen yesterday a workshop. This is in courtesy with Dr. B.R. Srinivas. This is a traditional use of very badly infected diabetic foot wounds with very bad biofilms, and this is by B.R. Srinivas. So we have, here you use Lucilia sericata, which secretes enzyme and physically breaks down biofilms, maggots, allowing the larva to eat the bacteria. So it destroys EPS, downregulates the specific genes, and prevents genetic transfer. So combining maggots with antibiotics is, which is badly infected wounds with biofilm, can salvage a limb. What Srinivas uses is a cryosoma megacephala larvae, and this is some of the cases. So if you see this patient with complete biofilm in the plantar and the dorsal aspect, and this is the maggots that he puts on a daily basis. He removes the which are slugly moving and puts new maggots in a smart technology now he has developed, and he may patent it, with a good healing in the later stages. So this is a traditional use which was used before in India, which I think should be spread all over India and other parts of the world also, to use this where the limb salvage is very, very difficult. This is another case. This, if it comes to our medical college, we would straight away do amputation. But here also, Srinivas has used maggots, which is showing in the next, absence of slough, a good granulation tissue. So biofilm treatment has now been revolutionized. A lot of new things are coming. Everything is available in the literature. The only thing is you have to be bold enough to use all these things. So to summarize, bacterial sensors, pH sensors, biomarker sensors, temperature sensors are going to detect that biofilms, and nanoparticle-based treatment is going to revolutionize. But nothing is going to replace the debridement by an experienced surgeon. So that is the takeaway message. Everything follows after that debridement. Thank you.
Thank you, Dr. Milind. May I call upon the next speaker, Dr. Belahelli Pavan. He would be talking to us on managing osteomyelitis in the diabetic foot, tips for practice.
Good afternoon, everyone. Big thank you to Dr. Rajesh Keshwan sir and the whole team. Now, being the last batsman, my work has become, you can say, easy and difficult. Easy because I have to just retell what the stalwarts have been telling so far, and difficult because I still have to talk something new, so that my audience here do not get up and go for lunch before my talk ends. So I will, being an orthopedic surgeon, I'll try my level best to keep you here till the lunch is served. Now, coming to osteomyelitis, this is the classical when we are talking of osteomyelitis. The 3 circles represent clinical features, radiological changes, and blood assays. So you will invariably see that the classical osteomyelitis lies in the center, but you will always have people coming to you with blood assay involvement and clinical features with no radiological signs, coming to you with radiological changes and clinical features with no blood assay involvement. So we have to keep this in mind. Coming to why this is a problem. This is a problem because this is a mole which becomes a mountain. So if you know, I mean, most of the surgeons, they know that if they are tackling a wound which is more than 4 to 6 weeks old, the chances that this is going in for osteomyelitis are very, very, very high. And a simple bedside test which can tell you. So this is a simple AI generated image which tells you how that osteomyelitis can give rise to septicemia. So the breach, the compartmental spread, and the ischemic cascade, the 3 features. The simple bedside test that we are talking of, and if I can play the video, let me try my best. Yes. So that's one of my sisters doing the probe to bone test. It's a simple test in which we use a blunt steel probe, take it down and feel for the grating sensation below. And as you can make out, the sensitivity and the specificity is in the mid-80s. So even then, it's a very good bedside test to say that this wound is probably going in for osteomyelitis. And coming to the diagnostic escalation, clinical suspicion, probe to bone, and if it is positive, treat it as DFO. If it is equivocal, order a plain X-ray. But I will tell you what are the problems with a plain X-ray and why we cannot keep ordering MRIs and PET scans, especially when in a place like mine where I see 80 to 100 diabetic foot in a diabetic foot institute in a government setup. But yes, the ultimate standard, the gold standard remains a bone biopsy, which many of the stalwarts have already spoken about. Coming to the diagnostic modality matrix, plain X-ray, the pros are widely available, low cost, but insensitive to acute osteomyelitis. And in 2023 IWGDF recommendation, it's a routine initial assessment. Serum biomarkers, ESR, CRP, PCT, easily obtained, tracks the response, but it is non-specific, affected by comorbidities, especially in geriatric diabetic people who might have multiple comorbidities. MRI, extremely sensitive, maps soft tissue changes, bone marrow changes, but then we have to understand that MRIs are not always possible. Bone biopsy, absolute criterion, standard, definitive pathogen identification is possible with a bone biopsy. And that's why we surgeons keep telling that please go for a bone biopsy. And microbiological sampling protocol, the do not protocol. This is important because many people would want to know, would tell you what is the do protocol. I'm trying to tell you what is the do not protocol. Do not use superficial wound swabs, obviously has been already spoken. Do not routinely use molecular next-gen sequencing. This is something which is happening, and we see this especially when people are coming to my clinic or my institute. They already have a NGS sequencing report, which actually creates more confusion. So I don't know, the stalwarts can have a say in this, but absolutely a do not protocol. The standard of care, aseptic tissue procurement, conventional culture, and bone over soft tissue. If you are suspecting osteomyelitis, obviously you have to look at the bone getting infected. Coming to the targeted versus empiric therapy, I will not go into details because already a lot has been spoken about this, but please remember the stewardship rule. Always de-escalate from empiric broad spectrum to targeted narrow spectrum, preferably oral, once the culture returns positive. How many days do we give? So this is one question which many of my physician friends keep asking me, because once they have sent a patient to me, I have already done a debridement, I've sent them back, and they ask me, don't you want to give them the oral antibiotics for 6 weeks? And then I ask them, that's the reason why you had sent the patient to me, so that the patient need not take antibiotics for 6 weeks. So we have a small chart here which can tell you, yes, if there is skin and soft tissue mild infection, up to 2 weeks of oral in skin and soft tissue post-debridement, I would stick to around 7 to 10 days. In a diabetic foot osteomyelitis case with resected bone, obviously if you are comfortable and your resected margins are negative for infection, just 1 week of antibiotics is enough. But then if it's a positive margin with infection, then probably for 3 weeks. But if you are treating him completely conservatively, then you might require oral antibiotics for 6 weeks. So always there is that dilemma, the scalpel versus the pill. So which is the better outcome, which gives you the better outcome? So we have to understand that we will choose the medical pathway when there are proper indications. Forefoot osteomyelitis without immediate need for any surgeries, no severe peripheral arterial diseases, no exposed or necrotic tissue. But yes, the surgical pathway, in case the patient is at a bad shape, patient has already come to you in septicemia, there is absolutely no role for conservative management. As I was talking to you about the clinical representation of the osteomyelitis, this is the Venn diagram for Wilhelm salvage when the patient with DFO comes to you. So diagnostic precision, PTB at the bedside, advanced imaging, aseptic bone and tissue cultures, antimicrobial stewardship, it's a very important role. Please understand, we cannot give antibiotics to all our patients left, right and center. It's causing more harm than good to the patient. Surgical and biomechanical control. The final insight is DFI and DFOs are not siloed conditions. Successful limb salvage exists exclusively at the synchronized intersection of microbiology, pharmacology, surgery and biomechanics. So this is something that we have to understand. It's a team approach. So again, this is the end of my talk, just trying to show you some cases where how the DFO was treated from my side. This was an elderly male with PAD, surgically corrected with non-healing wound over stump of the 4th toe, developed swelling of the 3rd toe with no systemic features. Coming to the x-rays, that's how the x-rays look. As you can make out, the bone which has been excised on the 4th, there is some amount of osteomyelitis. You can make out some soft tissue swelling there. It has now started giving rise to septic arthritis of the 3rd metatarsophalangeal joint. Although his ABI was, he had already undergone peripheral arterial disease corrections, but then looking at the X-ray and the swelling, we went ahead and did, as you can see, it was osteomyelitic, and there was a lot of infected tissue there which had to be excised. So in hindsight, probably that was the better move, rather than waiting and giving these patients antibiotics, because this is a high-risk patient. This patient is a PAD patient who has already been corrected. If you don't do something, chances that you might lose this limb are very, very high. So these are the post-op images. Obviously, the patient walked away with a simple surgery. Case 2, this is very interesting. This is a young 19-year-old type 1 diabetes with swelling of the right great toe, brought reluctantly to my OPD for a checkup by his mother. There were no systemic features or draining wounds, except a hemorrhagic callus under the right great toe. But when we saw that, there was, you can make out, there is some amount of swelling in the pulp of the great toe, and that is when the x-rays did not show up anything, the ABI was absolutely normal, but then because of the fluctuant swelling in the pulp, we went ahead and debrided this. And when we debrided it, we also sent a deep culture, tissue for culture. Now, this patient happens to be an intern at one of these hospitals, the hospital management guys, and it was a very pleasant surprise because he came to me for the follow-ups, and after the wound reached this stage, we lost him to follow-up. And I was very surprised to meet him in one of these conferences where I was speaking, and he came up to me and asked for a small snap. And then I asked him what was this about, and then he told me, and I remembered. But in hindsight, as you can see, the pus, the culture and sensitivity, even though it was done on OT with proper precautions. A deep tissue was sent. Nothing was indicative of any infection. But yes, we have to take this, as surgeons say, with a pinch of salt. All's well that ends well. A young guy with toe and foot salvaged, doing his best to support his mother, meets me at one of the similar conferences. The story. Yeah, this is a case 3, elderly female, comes to me with a swelling, duskiness of the second toe. As you can see, the x-rays are already showing some amount of distal phalanx involvement of the second toe. And this is how the great toe and the second toe wound looks like. So these are the patients. Now this patient, ABI was normal, obviously was neuropathic. So in this patient, we took a chance of conservative management with calling the patient regularly to our institute probably once a week. And this X-ray that you are seeing is after 4 weeks. And needless to say, the patient is still under follow-up, but the wound is settling down with no signs of any exacerbation. This finishes my talk, and I also give regards from the 23rd annual conference of DFSI, DFSI Con, which will be held in October in Bangalore. Here's wishing you all that all of you will be there and support us similarly. We have a small stall outside where you can register for the same. And calling all the PGs here, we have a big national level quiz on podiatry, the Pod IQ, which is going hand in hand with DFC Con. So calling out all PGs to take part in this. And obviously we have already started something called Prayas, podiatry outreach across India for awareness and screening of diabetic foot, where we are presently covering Karnataka, but we wish to come to different places, including Chennai. We will require all your support when Prayas is here. Thank you.
Thank you, doctor. There's a question.
Yep.
So this question is directed to Suresh, sir. So in the case of CKD with pseudomonas, osteomyelitis sensitive to both meropenem and piptas, what should be the ideal choice?
So come again? Sorry.
So in the case of CKD with pseudomonas infection, osteomyelitis sensitive to both meropenem and piptas.
Okay.
What should be the ideal choice, sir?
The differences between the BL-BLA versus carbapenem is the main question they are asking there. BL-BLA means piptas and cephalosporin sulbactam, carbapenem. What is the differences? We need to know the antibiotic 2 things. What is the spectrum? Piptas and meropenem. Both cover pseudomonas, both cover enterobacteriaceae, both cover methicillin sensitive staph aureus. What it won't cover? Carbapenem resistance organisms, as well as it won't cover HAMC producing organisms for piptas. So what is the difference? Penetration wise, meropenem has got better penetrations into the bone, better penetration to the soft tissue. Piptas has got slightly inferior. One of the big randomized control called Merino trial conducted in the Western world says piptas is useless, but Indian scenario piptas is still working for UTI, for cholangitis, cholecystitis. If the involvement is skin and soft tissue, piptas is good. If you think the person has got bone involvement, yes, we can use like a meropenem, because meropenem has got better penetrations to the bone. Ideally, this is for the first speaker. In fact, I also want to leave. So what I did is, I got a second brain. I just asked my second brain, so what is going to do there? The second brain, what they are asking is, what is the differences between piptazo and meropenem in skin and soft tissue infections? Can you tell? Differences between piptas and meropenem in skin and soft tissue infections. Now, what is the differences between piptas and meropenem in skin and soft tissue infections?
To ESBL producing bacteria. Meropenem carbapenem covers an even broader range, including resistant gram-negatives like ESBL producers. In short, piptazo is often sufficient unless you have a high risk of multi-drug resistance. Then meropenem steps in. Always narrow based on culture.
So if you want anything about the antibiotics culture sensitivity, my second brain is here. I want to leave the thing there. Yeah, sure.
No problem at all. Whenever you have any questions or
Thank
need a
you,
quick
sir.
clarification.
May I now request Dr. Rajasabhabadi sir to felicitate the Dr. Suresh Kumar. Dr. Milin. Dr. Pavan. And to our moderator, Dr. Arvind Rajagopalan. Thank you, doctors. Now we move on to book launch ceremony. Book preserve knowledge, inspire innovation, and shape future generation. May I respectfully request our distinguished dignitaries, Professor Seshaya sir, Dr. Rajasabhabadi, Dr. VBN, Dr. Rajesh Keshavan, Dr. Sanjay Vaidya. Kindly come forward for the official launch.
I would also like to request Ms. Usha Ramakrishnan and Swati, representing Minds Lab Publishing, the publishers of the book, to come on stage. I would request Dr. Bhavatarani to give a short introduction of Professor Seshaya.
Very good morning. Our Honorary Professor Dr. B. Seshaya established the first Department of Diabetology in India at Madras Medical College in 1978 and the Diabetes in Pregnancy Division in the Institute of Obstetrics and Gynecology, Government Maternity Hospital in 1980. He is the patron Diabetes in Pregnancy Study Group DIPSI and Army Decorations Samar Seva Mitra in 1965 and Sanya Seva Medal in Himalayas. He is the recipient of B.C. Roy National Award in 1988 for the development of diabetology as a specialty in the country. He has got the Lifetime Achievement Award by International Diabetes Federation in 2017. And he has won the Padma Shri, he was Padma Shri awardee in the year 2022 by our President. And he is the one who has given the national guidelines for the diagnosis of pregnancy, the single-step procedure. Thank you, sir.
Thanks a lot, Dr. Bhavatarani, for your kind introduction. So, we will now go forward for the book launch. We are extremely happy and we thank the publishers of Mind Lab Publishing for having brought out this beautiful book. The book is called Wound Management Simplified, an algorithmic approach to infections. So the book will now be launched by Professor Seshaya, and the first copies will be given to Professor Narayanamurthy, Dr. Rajasabhabati, Dr. Sanjay Vaidya and to myself. Now, over to the launch, sir. Professor Arunbal sir has not been able to come over because of certain medical issues. Now, Professor Arunbal is going to just share his thoughts. I think we have a audio file on I think he will be joining us live. Thank you.
Hello, good afternoon. At the outset, let me thank RK Diabetes Food Care Center plus Dr. Rajesh Keshavan for giving me this opportunity to explain and narrate my journey of diabetic food management. Diabetic foot was not a specialty at that time, and though the diabetes was one of the commonest diseases in India that time. In fact, just as an interesting episode, two senior diabetologists and endocrinologists from Jocelyn Center had come to India, and that time they asked Dr. Ajgaonkar, how many diabetic foot patients you have? So we had only 3 or 4. They were shocked because in America there was a flood of diabetic foot patients. Dr. Ajgaonkar once called me, SS Ajgaonkar, and asked me, have you read anything about saving the foot? At that time there were no books, and it was very difficult to get any foreign journals because of a foreign exchange regulations were very strict. So he gave me the first diabetic foot management book published that time in 1988 by Dr. Levin and Dr. O'Neill, and he said, you read this and start doing this. Here everybody does the amputations of the leg, which makes the patient invalid for lifelong, and this is not what is done abroad, and we need to improve. So I started reading and doing that, and I realized that I can save the feet. So I shifted my focus from doing routine wound care, routine debridement, to trying to save the foot, and I found it works. So we formed a team, myself, Dr. Prakash Ambardekar, who was an anesthetist, and Dr. Sudhir Karmarkar, who was that time professor of plastic surgery in KEM hospital, and we started working together, and we found that there were a good result of our work, and we could save many feet. So we started working on that, and as an outcome of that, sometime in 1987-88, we held a first local meeting with a local diabetologist here to update them on the diabetic foot management. The next major step was sometime in 1997, where we held the first international diabetic foot meeting in India. The next step was, there was a major national meeting in 1999 in Chennai, which was held by Dr. Sharath Pense and his group. And as an outcome of that, an organization called Novo Nordics Educational Foundation was formed. As an outcome of that, in 2005, Diabetic Foot Society of India was formed. First comprehensive center in whole Southeast Asia, As a outcome of that center, we started a fellowship in diabetic foot surgery, first time in Southeast Asia, and one of the first student was Dr. Manisha Singh from Gwalior Medical College, and second was Dr. Rajesh Keshavan, who is a host in this conference. Also, the fellowship in Raheja Hospital started in 2012 under the Maharashtra University of Health Sciences, and Raheja became a very major center in whole Western India. As of today, we have an annual patient attendance in OPD of more than 9,000, and which is the largest number of attendance in whole India. Southeast Asian organizations as well as International Working Group on Charcot Foot, International Working Group on Diabetic Foot Management, and then as an outcome of that in 2005, Diabetic Foot Society of India was formed. Now we have got an alliance with many other organizations, and we have now formed another branch of foot related society called Podiatry Surgical Society. Podiatry is a separate subject across the world which is non-existent as of today in India. But now we have formed last year Podiatry Surgical Society along with my colleagues like Dr. Rajesh Keshavan and others. So this will be a new vista which will open for the new graduates who are either MBBS or they have done orthopedics or surgery. And because this was one lacuna which was there across India, because all over the Southeast Asia there is a podiatry as a subject which is not there in India, and now we have registered this organization. So in coming 2-3 years, I think this will grow and become a big thing, sort of a movement. I think we are on a right track, and I have done my contribution to that, and I feel that this will be carried forward by my younger colleagues like Dr. Rajesh Keshavan and others, and this will become an internationally well-known organization and a movement. And also simultaneously, I would like to thank Dr. Sheshayya for agreeing to release my recent book on wound care, which is my second book on wound care, which will be released in this conference. And I profusely thank Dr. Sheshayya, who is my senior colleague, for agreeing to release this book. Thank you.
In addition to what Sir had said, Sir was also very much instrumental in starting diabetic foot care in Africa. So he had he was going there and he had taught a number of surgeons there in Africa, especially in Tanzania. And the similar things he had also started both in Burma as well as in Myanmar. So he was instrumental in spreading the care for diabetic foot patients. So as the founder president of Diabetic Foot Society of India, he has done immense work, immense things for diabetic foot care in our country. I would like to thank Professor Arunbal sir for bringing out this beautiful book and giving us again mind bits of what he is thinking, and I thank the august audience here for bringing all this together. Thank you. Next, I would request Professor Sheshayya. Again, he is going to give us a few thoughts. He is going to talk on the lessons from the legend, and he is the senior most diabetologist in the country. So he is going to address this August gathering. Thank you.
Yeah. Yeah, yeah. Are you able to see?
Can you?
Yeah, I'm seeing you.
So you want to sit and do or you want to come over there?
I'll come there.
That's what is spiritual.
What they are a teacher. Long many years. Friends, ladies and gentlemen, I'm sorry I'm taking few minutes here about what I'm going to speak, what is my experience. Those days when I was a young fellow, undergoing student, those days, you know, yeah, if you know medicine, you know diabetes. Now what I want this time, you will see here, I don't know how many people know here Professor Sam G. P. Moses, who was my teacher. Then from that time onwards, I became, though I was started as a physician, then because of working with him, I went into more of diabetologists here. And the moment I stood with that, I started writing the books. Here I wrote all these books written by me, a number of books only I was writing. Then came, this is the first book I came, Justice Diabetes Mellitus in India, first book. Then again second book came with that. Then finally we came on Diabetes Mellitus about the this year, latest book written by me here. Now what happened, 222, I was given award by President of India those days in 2022. So from 1974, I became professor in the Department of Diabetology. I started diabetology 1974. Then slowly, 2022, by the time I left the service, but government wanted to give me that award, I could not keep myself. I hear this audience, the problem came because of this. How to avoid diabetes, how to prevent diabetes. This is what I'm doing here. Primordial prevention of diabetes. Can you imagine how can you prevent diabetes in the world? If you do that, you would avoid all this problem which I was listening here for so many hours. Now, how simple you can do that, prevention of diabetes. You can save food. You'll see here. I will give ideas what happened. Estimation on projection of the number of people 20 to 79 years with diabetes in different editions will be now. Next slide. Here, 2019, it was 463 million. When it went to 2021, it became 537 million. When into 245, it is going to be 783. It goes on increasing. Population is increasing, diabetes is also increasing, food also increasing. Now, what is the final message? Pre-diabetes approximately 318 million, which is likely to increase to about 481 million by 2040. It's going to again have more of problem of diabetes. And so what we can do here, and I think this is what, now I'm going to give the answer to the problem what I'm going to face here. Detection of diabetes does not mean prevention of diabetes. Our idea is to prevent, there's no part detection. So what we need and what steps can be taken for primordial diabetes, it is desirable, disease should not develop. What is the answer? Now I'm going to share with you, please take this message. You can prevent diabetes. When you prevent diabetes, diabetic food can be avoided, whole country can have safe people here. Then this what can, diabetic perception of GDM, all things starts from pregnancy. GDM is not adults here. GDM, gestational diabetes mellitus, is possible by very diagnostic criteria, and then what prediction, perception, prediction, is at which week, what glycemic level, and how to test for developing gestational diabetes mellitus, Why I'm telling about GDM is important. The next will be prevention. So prevention means measure to avoid the development of gestational diabetes mellitus and its consequences. Please, this is my final message here. Unless we prevent this, you can't prevent diabetes. That means you must prevent GDM, you must treat. Next slide. Now, you again, I don't know, it's a little problem in this extreme audience, almost seems to be surgeons here. So still I'll give some few idea on this, because in this concept of what they do in diabetes pregnancy, in our session here, if we take International Diabetes Pregnancy Study Group, this will be different, IDPG, and then that cover. Isn't it? Yeah. Then comes here, the same people, when they brought down this IADP, International Diabetes Pregnancy Study Group, they said it themselves needs the revision. As even at centers that accepted recommendation, the approach has to be taken away, varies. Then what they should do here? So what we are telling is, different countries have different guidelines. If you go to Europe, any country you go there, there is a problem here. Different countries, different guidelines for diagnosis of GDM, and even the same country has two guidelines which led to confusion among the healthcare professionals. So what is answer now here will be close. What is happening now, what I am started telling the government in 2022, we said therefore the physiologic glycemic level in normal pregnancy has to be recognized, implemented. What happened here, this is what we found out. The blood sugar, this should be 2 hours, should be less than 10 milligram during pregnancy. This, I know, this has to be promoted everywhere in the country. The 2 hours, how many people know about blood sugar level 110? Very people, I don't think anybody knows unless now you've heard about me. What I told you, it should be 110. Less than 110 should be normal. If anything more 110, that lady will become diabetic. That once she becomes diabetic, child is going to be diabetic in the future, and she also. So 110, this is the number. Less than 110 should be there. Next slide. And then the glycemic level at which GDM, prediction of GDM is going to occur will be National Institute of Health Study. 2018 they told, but people never followed properly. A1 5.3. If postpartum blood sugar, please here, if more than 110 milligram, fetal beta cell starts secreting more insulin around 11th week, and fetal hyperinsulinism occurs, and followed by here, yes, prevention, blood glucose has to be brought to less than 10. Please, this message you can carry on with your colleagues. Anybody sees a pregnant woman, sees that her blood sugar is less than 110. More than 110, the chance are that she will become diabetic. Now, this is, leave it here, embryology is over. Next slide. Next slide, Paral. Now, finally, this is what I was told, 2022, prediction and prevention of gestational diabetes mellitus and its sequelae by administrating, we used to treat the metformin in the early weeks of pregnancy. The concept is here, you can use metformin provided you prevent the blood sugar more than 10. This is also published. Latest journal you published here will be here. Groundbreaking concept for prediction and prevention of GDM and its sequelae. That shows everything comes from mother, GDM. Here, gestational diabetes mellitus can be predicted if the 2 hour postprandial blood sugar is more than 110 milligram in the 10th week is a problem. EGI, early gestational glucose tolerance. What we should do, preventive measure must be implemented by the end of 8th week itself to ensure that mothers postprandial blood glucose. This, I think you must, I don't know how to spread the message here. This preventive measure must be implemented by the end of the 8th week to ensure mothers postprandial, nothing to do worry about glucose and all. just personal blood glucose remains less than 10 milligram throughout the pregnancy, preventing diabetes from developing is well established, applicably and achievable. Now, the outcome is so good. So, indispensable postpartum glucose, indispensable. When I was young, 1986, that time I told it should be less than 10 milligram, but people did not believe it. Now, Leo Jaunwig, an American lady, she said yes, fetal threshold should not cross 110. If it doesn't cross, that mother will become diabetic. If it doesn't cross, and treat them with medicine, particularly metformin, that mother will not become diabetic. A child also will not become diabetic. So foot also will be saved. Diabetic foot gone. Then Hernandez, again 2 hours, less than 10. NIH National Health, again less than 10. Sasha's concept will be again less than 10. So, my friends here, what I will be given, Government of India, for saving this 110 million, God knows. Next time you will know what is going to happen here. So, the message will be here, prediction of GDM, 2 over PG more than 100 milligram or 10th week is a problem. So, preventive action has to be taken at the end of the 8th week itself, start testing the mother's sugar, so that maternal blood sugar remains always less than 10. I don't think anybody has known about this, what I am telling you now. Recently, it is, the past 3-4 years I am telling this. I hope it spreads. If it spread, the child will not become diabetic, you can definitely save the foot. Probably diabetic foot won't occur, you can save them. So the maternal blood sugar should be less than 10 throughout pregnancy. If at all, to mother, MNT and metformin should be given. Finally, so for diabetes-free generations, if you want your diabetes medicine to occur, diabetic-free generation, 2 hour per, very simple, there's only one value. If 2 hour PPG should be maintained less than 10 milligram, whole world can avoid diabetes. How to do it? Previously. This is what happened here. Pre-conception care, blood sugar is 110. If it goes pregnant woman, again less than 110. Postpartum 100. This value if it's got, whole world can avoid diabetes. You can totally avoid all the diseases possible if they can do is 110. That's what I'm telling you. Hence, decoding hyperglycemia and pregnancy, urgent and important will be the one test only one test. 2 hour postprandial blood sugar, one value, that is glucose will be 1. Nothing to note, not to give glucose to the mother. You meal, after a meal it is less than 10 milligram, it's very good, euglycemia. That is early gestation glucose tolerance should not cross 119. So it should be less than 110. Finally, this is my final message, prioritizing women's health and implementing evidence-based strategies for current concept of early gestational glucose intolerance and its management. That's what my message here, for we can pave the way for a brighter and healthier future. So final message here, female gender, again I'm coming back, there's only one slide here, final. Female gender is the key for diabetes prevention that man has got nothing to do. So, man has nothing to do. Happy? Happy? Diabetic foot won't, no problem will occur. Either men or women, nobody else. You start thinking about that. Female gender, because mother is very important. This fellow has nothing to do. Female gender is the key for diabetes prevention. Lysol King is told. Body's susceptibility to lifestyle diseases was programmed intrauterine by David Barker. Focus on the fetus for the future is my statement. So all this is very important. Finally, this is what I told here. That means one simple test. I think you will all should take this slide. one simple test during pregnancy can protect two lives. Not only two lives, continuously, if it doesn't become diabetic, a child will not become diabetic, a grandchild will not, so whole world will become prone diabetes, so we can say all along our beautiful food. This, what you are struggling for the food can be avoided. Thank you very much for your fascination. Thank you very much. So what prize next time?
Thanks a lot, sir. Thanks for being here and gracing this meeting, sir.
This is not known so far anybody in the world. I don't know how you are all going to spread this message.
So in addition to preventing diabetic foot, we also have a duty to preventing diabetes. Again, this prevention starts at the fetus level itself. That one test, postprandial levels of glucose has to be checked. It has to be kept less than 110. Anything above that has to be managed. So thanks a lot, Professor. And
88. I want to see 100.
Sir, you will be seeing more than 100, sir. And
now,
a copy of this Professor Arunbal's book is kept in your kit bag. It will be given along with the kit bag. I thank the publishers for giving us a complimentary copy to be given to all the delegates who are attending this conference. Thanks a lot, madams. I would also like to call upon Dr. Subramania. Now I think Professor Seshia had talked about diabetes prevention from the fetus level itself. Now Dr. Subramania, a senior researcher, is going to give his thoughts on diabetic foot prevention.
Thank you, Rajesh Keshavan. First of all, thank you for giving me this opportunity, I think out of the box. So before the food, there is some food for thought, real food for thought. We heard Dr. Arunbal's speech on, how it all started for diabetic foot. From that to Dr. Sheshaya's vision for a diabetes-free world, to eradicate diabetes from this world, I think it's a mind-boggling thoughts in between. What can we do and what are the low-hanging fruits for diabetic foot is something I would like to share my thoughts on. So what we know is that diabetic foot, problem is because of the neuropathy and the peripheral arterial diseases. Together, roughly half of the 30% to half of the diabetics, are at risk. So it's a big social burden because out-of-pocket expenses, multiple hospitalizations, and then amputations leading to depression, and then loss of income and productivity for someone, say in his 40s or 50s, having a lot of responsibilities towards the family and the society, and disability reduces the quality of life. But more than that, what I learned recently, I'm a newborn baby to this diabetic foot science, as a branch of science, maybe 7 to 8 months into this. And what I'm learning is that it's a disease that kills people. And the 5-year mortality rate of 42% for all DFUs is something that really bothers us. That means, 60% may not survive 5 years after a diabetic foot ulcer occurs. And with amputation, the survival rates are less than 20%. Now, this is something really worrying. This is as dangerous as some of the worst cancers that we are aware of. But is the world aware of diabetic foot ulcer as a disease that kills people? Now, the foot ulcer alone, does it kill? Or is it a symptom of something inside? More processes that are happening, is something that we need to understand. But definitely it's an indicator that is pointing, and therefore action is required. So, Global Diabetes Foot Guidance says regular screening is required, and more importantly, patient education and self-care is required. Regular screening in terms of, annual surveys going house to house and, identifying diabetic patients and their feet status. Perhaps I don't think anywhere in the world this is happening, and if at all anything that I've heard, I've learned is Tamil Nadu has done a wonderful job with Padam Padukapam Thittam. And last week, 3 days back, I had an opportunity to interact with Chief Secretary and Chief Minister of Bihar. And I shared that, and they are interested in starting in Bihar, sir. Something because they have got a fantastic public health resource at ASHA level in their villages. So they can actually do a survey, and they were telling me that, why don't you call, the people from Tamil Nadu to help us out. So we can think about it. So that is regular screening. But more important is patient awareness and regular care, including inspection almost on daily basis and early reporting. So what I learned also is that 2/3 of the patients never come to a doctor. That is 60 to 66% don't come to a doctor because it's a painless ulcer. Painless wounds do not trigger any alarm to the patient, and unless it is very late, they don't come to a doctor, and that's the reason we are losing the limbs and the lives. So what can be the strategic actions for prevention? At individual level, of course, diet everybody knows, exercise, let us focus on low impact exercises. Walking, running, jogging, skipping, these are all high impact on foot exercises. For those with neuropathy and for those with ischemic disease, vulnerable for diabetic foot, or all those who already have some diabetic foot ulcer, definitely these things should be avoided, and we should focus on, low impact exercises. At community level, raising the awareness. I saw the piece in newspaper today, sir. Thank you, Dr. Narayan Murthy, sir. I think, this kind of, news items should come regularly across the country, across all news channels, and that's important. And at the government level, we already said, Tamil Nadu has done something, establishing diabetic foot clinics at the medical colleges, at the district hospitals, maybe across the country. Every state has to do it, and maybe other countries can take a leaf out of what India is doing in this. So we appreciate that. So, again, we have got a lot of wound care guidelines, but for the health workers and the staff at the periphery, what are the screening guidelines? Now, if self-care is required at home, what should the family members do? These kind of guidelines need to be drafted, and patient education is required. And I think there is a lot of work that can be done around it, and a lot of research that to support that. Now, just one word on how exercises help diabetes mellitus. This is no rocket science, or to skeletal muscles to consume the glucose. It doesn't require insulin, and therefore skeletal muscles have to be used. But not necessarily only the legs. I think, we can use, other parts of the body, standing exercises in the form of Maipadam. Again, another thing from the Tamil culture that can show a way to the rest of the world is something, we are looking at. It can help in, neuropathy, addressing the neuropathy also, these stationary traditional exercises. I am particularly fascinated. We need to do more research on this. Maipadam, and Guru is here, Dr. Narayan Murthy sir, and of course there are so many practitioners across the country, across the world. I think we need to study this and establish this. Now, beyond this, we talk of self-care. The self-care can be something like, why put a mirror when you have a smartphone, under your feet? Take pictures regularly, and maybe, your AI camera can tell, how is the wound? Maybe, sir, I think, for the biofilm also, the markers that you are saying, we can train AI to recognize the wound itself, and to recognize whether there is a biofilm developing and what is happening. It's a lot of possibilities are there with the modern science, and we need to work on it, and we will hear more about that in the afternoon, I understand. So I think recommendations for, these are some of the things that I'm mentioning. AI-powered diabetic foot self-care is possible. But again, to do this, a lot of diabetic foot surgeons and DFSA members have to come together, because we need the collection of big number of pictures to train the AI itself. So I would like to come to the last slide. At the individual level, actions are required, community level actions are required, and government level actions are required. And we can formulate a policy, document based on this and submit to Government of India. Thank you very much. And lastly, self-care application that Sir Narayan Murthy had developed, is still under, review by the experts, and research will be published. And he wanted it in different songs. And in Sanskrit, one of the Sanskrit scholars in Karnataka, Sridhar Bhatta, converted the table, calling it a padayantram that saves lives. Artha Vishanna Shithilascha Padaha Goreshu Madhumehas Vartamanaha Samyojya Padambuja Yantra Yuktam Vimukta Dukkhas Sukhino Bhavantu. By adopting this table and self-care, people will be saved from their distress. Thank you very much.
Thanks a lot, Dr. Subramania. As you had said in your talk on AI, using AI to look at the feet. So we have developed one app, I think, which one of our researchers, Dr. Biki, will be talking in the afternoon, sir. Thanks a lot for your excellent
Wonderful, sir. We look forward to learning more on that. Thank you.
Thanks a lot, sir.
Thank you, Doctor. Thank you. Now I request Dr. Rajesh Kesavan to felicitate Professor Seshaya. This includes our DFSI Tamil Nadu chapter. Thank you, sir. Now I request RK sir to felicitate Rajasabhabadi sir.
We invite Dr. VBN, sir, to be the moderator for the next session. Dr. Sanjay Vaidya, sir, Dr. Srinivas, sir. The session is going to be advanced wound modalities. We request Dr. VBN sir to enlighten us on hyperbaric oxygen therapy.
Good afternoon, and this topic is a very interesting topic to me. As a person whom I had not spoken or done much in English till I came into medical college. I had studied in Hindi medium. First time I started talking English was in medical college. So my thinking always is in my own native language, and then I translate into English. So when this came up, does HBOT work? I said, "Nada, ittana naala pannittu irundhom nalla irukku. Inniki thidirnu indha mari kelvi kekkrangala." So that was the first thing I was thinking. So I said, why do you have to talk about this? Does it work? Then I thought, in this day and age, should I ask my AI to talk about it? So I do have, I'll show it to you. This is my AI. Okay. You can see that's the AI there. And I started talking to my own AI. Avatar. Will this video come? This video should come. Yeah, I think without the video it will be no. வெளியே play பண்ணுங்க அப்படியே. இங்கே play பண்ணுங்க. So anyway, if it okay, anyway, if it doesn't come, you can actually focus the camera here. Okay, so I'll activate the AI in my phone, and I'll ask my AI. Okay, so I'll ask the avatar, as you can see here. So same thing what I recorded last night, I'll show it to you live. So just connecting.
Helping patients understand hyperbaric oxygen therapy with clarity, care, and safety. HBOT can support healing in selected medical conditions, but the right decision depends
Sir,
on
good
your
afternoon.
health, your wound, or...
Can you tell me?
Good afternoon.
Can you tell me after treating patients with HPOT, can I ask you, does it work?
I understand why you're asking about the effectiveness of HBOT. It can be beneficial for certain conditions, particularly where oxygen delivery is compromised.
So anyway, so I thought, you can actually ask, but then that is not what we are supposed to do here. Can you go back to the presentation? Okay, next slide. So conventionally, when we say, well, does it work, then we go back, and this is my previous lectures, how I would approach this particular subject and say, well, these are the recommendations by the American Undersea and Hyperbaric Society, what are the various evidences and why they have recognized and what are the indications. Then we'll actually go through a lot of tables and then we'll explain about. So basically this is a good table talking about various people who have done work on controlled studies on hyperbaric oxygen, without hyperbaric oxygen, looking at major amputations, minor amputations. Two people are very important. You can see that Abidya in the first one and Lodal. So UK and Lodal, these are very prominent things which they have been quoting. So not to get into, so this is how we used to talk about it. So we used to talk about the papers, what they did. We talked about each person who has done a lot of work, right? This is what conventionally we used to discuss. Then we said, how good is it? Is using that, how do we disseminate the knowledge? And then we say, what is the effects of HPOT, how they work. So this is how we used to approach something, a question. Then I can tell you that this rest of the entire presentation was made by Claude. I had nothing to do with it. I put the same question, and this is what he said. First it said, please reject the question. And I think it's true, because it says, will you ask, does surgery work? Will you say, does injections work? Does radiation work? So then I said, what does it really say? So HPOT basically, it looks at what AI has now taught me to think is, first you see what it is doing. So first it gives you an answer that HPOT is nothing but oxygen given to you at high pressure, which dissolves in the blood. So that is what it means. Okay. So then you had two or three things. One, you had to see how that physical principle helps in treating or how you're going to treat these patients. Then you had to see at which level, various tiers of evidence where it is helpful. Then you should say whether it is used as a placebo, does it work or not. Then effectively, you have to see whether it harms also. So this is how we have to approach any problem. I also found, because I had not much of experience in language, you are now, with AI, you have to start more and more of English, because we are now looked at lots of new terms are coming here, okay? Mechanism, plausibility. And then what it basically says is, plausibility means, these are all new terms I'm trying to learn, but it does make sense. So what it means is, supposing you want to see the physics of hyperbaric oxygen, and will the physics work? And physics obviously will work 100% if you use hyperbaric oxygen where there is carbon monoxide poisoning or other blood poisoning or when there is decompression sickness, because direct physics principles are used there. There's no question that hyperbaric oxygen is not going to work there because it just mimics the physics of what is hyperbaric oxygen is. Whether that property of a hyperbaric oxygen to release extra oxygen, will it help ischemia or hypoxia in the wound? We have to know. Whether it is going to help infection in the wound, we have to know. Whether the claim that hyperbaric oxygen will cause anti-aging, we have to know. So it looks like we have to understand this in a totally different area rather than just listing this which has been happened. So then you look at it. So first thing, we know that according to the physics, hyperbaric oxygen will definitely work in decompression sickness. It will work in gas poisoning and carbon monoxide poisoning and arterial gas embolism. It has also been well recognized in lots of RCTs that late radiation industry, clostridial anaerobic infections and other things, it works. Then we come to tier 3, which is supposed to be, which is, I think, genuinely and honestly contested. So we have to know whether it works in diabetic patients. The fourth one is interesting, emerging and hype prone. During COVID and so many other things, it was said that it can be used, but again, not much of evidence. And the fifth is interesting because you have bought a machine, you are using it for various other unrecognized, unsupported indications, which is like number 5, no credible basis. It's sold anyway as a cure or for anti-aging. So as far as diabetic foot is concerned, there's really, the evidence is actually 50-50. Okay, we're not going to the details. So SPOT did reduce indications of amputation in patients with diabetes. And again, in another study, you'll find that if you don't use the indications properly, it may not work very well. So here, it may not be the hyperbaric oxygen itself, it may be the choice of patients, the way it is given, all those things. So yet it does prove that SPOT will help to some extent. The problem is SPOT cannot substitute. However, SPOT can be an actual adjunct, but it cannot be a substitute for any of these things. Having come to know that SPOT can be useful, we had to know what is the number of times you have to give, how much you have to give, and what is the harm. So you have to know how much it gives, what is the harmful effects of HPOT. And just because you bought a HPOT machine, you can't just put everybody in to run the place to make money. So the principle that ties together is evidence tends to track mechanistic determination. So your evidence should align with the evidence should align with your purpose. So with that in mind, the 4-step rule for any HPOT claim is you should first find out what is the indication based on the different levels of evidence, based on the physical principles of how this is going to work, and make sure where you are going to place it. So those 5 tiers you talked about, you have to place it in the right place. Make sure that you have completely understood, you have exhausted other methods of treatment, and use it as a adjunct treatment and not as a substitute. And lastly, specify the subgroup. So before you start treating a patient, you have to make sure that it actually satisfies all these criteria before you can put him into these patients. And I'd like to just tell you this. So what I think, when it says, does it work? What I thought we should do is, we should try to analyze and see whether it works or not, because it's not easy, and then try to endorse it or dismiss it. So does HPOT work is a wrong question, because there are a lot of areas where it is supposed to work. There are areas where it doesn't work. Most importantly, trust the evidence most, where the mechanism is most deterministic. Demand the correct compactor and the physiologically selected subgroup. Rigor on the strong users is exactly what protects them from the hyped ones. So don't just look at hyped claims, use it on strong evidence. So with those 3 things, I'll just give you some examples. This is one of the very, very difficult patients where angiogram was looking very bad. This patient's almost, upper third of tibia was exposed. no vessel was manageable to be reconstructed, and this patient almost, he would actually end up with a above knee amputation, because even a below knee will not be possible. We gave him HPOT with wound management, and slowly you can see that it's completely healed. So this is one of the indications where there is ischemia, no infection, but with HPOT and other management, completely healed. You can also see the bone is also reformed. The TBI is nice and strong and well. Another indication where the patient, again, his vessels are not reconstructable, so he had to be given only HPOT, and this is about 25 sessions where he got healed. Another example of a patient where there is severe osteomyelitis for all the bones in the midfoot, not reconstructable surgically or otherwise. We had HPOT and it healed well. So again, before we do, we had to know the evidence, look up all the research, and the good thing about AI, it actually gives you all the references. So all the more reason now where you had to read up all this before we start presenting. Thank you very much.
Thank you, sir. The presentation has provided clarity on the role of HPOT and embracing AI in your journey. Now we call upon Sanjay Vaidya, sir. To present on neuromuscular stimulation, diabetic foot healing.
Good afternoon, everybody. So I'm going to talk about the Gecko device, which is a very useful adjunct modality in the management of diabetic foot ulcers. And as you can see, it is a small wristwatch-like device which can be placed over the common peroneal nerve and over the neck of the fibula, and that stimulates the calf muscle pump, the muscles in the anterior and anterolateral compartment. Now, remember, this location marker is very important when you are placing the Gecko device over the patient's leg. Remember that location marker has to come over the common peroneal nerve and not the dial of the device. Because as you can see, there are electrodes which are placed there at the site of marker, whereas the dial itself contains only a battery. On right hand side, you are seeing a diagrammatic representation of the Gecko device stimulation, showing us the twitching of the dorsum of the leg and muscles twitching. And on the here you can see a real life evidence of one of my patients who has been applied with a Gecko device. And when you see this kind of a good stimulation, dorsiflexion along with a contraction of the anterolateral compartment, you know that we have got a adequate power and which patient can tolerate. So I will of course come to the details of how to adjust that. See the marker, as you can see there where exactly it has been placed, so that it gives a proper stimulation. These are the, I need not go into the anatomy. Actually, a common peroneal will stimulate deep as well as superficial peroneal nerve, giving us stimulation to the anterior and anterolateral compartment of the leg and foot muscles. Now what it does, actually, it increases the blood volume as well as velocity equal to 60% of walking. It is not a substitute for exercise, let me tell you, but yes, what we must remember is this, again, modality can be used in long transatlantic flights where you are sitting for a long period of time. The Gecko device can be put, I mean, this is just additional information I am giving apart from DFU. To prevent DVT, this device can be used by elderly people. And as you can see here, there are volumetric flow increase in a venous channels up to 100% increase, arterial up to 75%, and microcirculatory flux, which is about 400%, which I will demonstrate in next few slides. Now this is with a Gecko device switched off, and you will see the comparison. Once the Gecko device is on and is optimally working, you can see a good amount of volumetric increase in the arterial as well as venous blood flow. And more importantly, as you can see the flux map with Gecko device, you can see a significant increase in the flux in the wound as well as the peri-wound area. Now, this gives us an idea as to how the RBCs are going in the wound bed and near the wound bed by using a speckle contrast optical spectroscopy. And gradually, as you can see, initially the device, when it is not activated, then 15 to 30 seconds once it is activated, there is a 100 to 200% increase in the flux, and gradually you see almost 1000% increase in a microcirculatory flux over a period of time. This is another speckle imaging of the lower limb in real time, as you can see here. Again, left-hand side before the device was put on, and you can see a significant increase in the flux post application of the Gecko device. And there is almost a 225% increase in flux in the wound bed, and peri-wound about 67% increase in the flux. So there was one study in UK which studied the TCPO2 levels in venous leg ulcers, and they found there is significant hypoxia at the venous ulcer site, which leads to non-healing of these ulcers. And apart from that, even the arterial ulcers, obviously because of PVD, there is less oxygenation, and there is a mixed variety of ulcers which will be about accounting for 10 to 15%. So there will be a perfusion deficit as well as oxygenation deficit is hypoxia. So combined together, the patient has a challenge in healing the ulcer. So why it is important to increase the perfusion in a chronic wound healing? Of course, it plays a role at every stage in wound healing, whether it is the inflammatory phase, proliferative phase, remodeling phase, and as we know, the ischemia obviously results in non-healing of the ulcers, which we have to somehow get over by different adjuvant modalities. And Dr. VBN had just now talked about hyperbaric oxygen. Now, this is something which is can be used by patient himself or by a caregiver at home. So that's a distinct advantage. And as you can see, the patient adherence is about 94%, 42% of the wounds healed in 16 weeks time, 52% patients reported a reduction in pain, and a reduction in leg volume, of course, is an indicator of reduction in the edema of the leg, and a reduction in nursing visits in UK is up to 33%. Patients were more involved in the study because they could handle, they could see the result. They are able to adjust the power to which they can tolerate. They can go up to maximum 10, and if they are able to tolerate that, they can continue their activity. Either they can put it during daytime or at night time when they are resting after dinner, and it's very easy to operate. Now, if a DFU is not healing, we can definitely use that. Remember, it should never be used in a case where we are suspecting DVT or confirmed DVT or acute Charcot. It's a strict contraindication for using this device. But again, we need to have somebody who can help the patient in using this device. This device has been in use for quite some time, and typically in India we were using 2 hours in the morning, 2 hours in the evening or night. Now they have come out with an improvised device which continuously runs for 12 hours. So effectively the device remains active continuously for 12 hours. We can't switch it off once it's switched on, and that will lead to more patient adherence and compliance and better results. Then actually the per device we get the activation for 2 days. So now I'll just show you some quick case summaries. There are studies which assess the blood flow and studies assessing the wound healing. Now this was one study which showed use of device showing the increase in the velocity in VLU patients, and we'll just quickly go through. Again, it showed improved venous and arterial blood flow leading to healing. Then microcirculatory flux and pulsability in arterial leg ulcer, that is patients with a PVD, it again showed significant increase, and as a result of increase in microcirculation. Now, this was something which showed the next 6 studies are about healing potential, which has increased by using this gecko device. Because of paucity of time, I'll have to just run through these slides, but these are freely available and I have given the references below. Now, this is another study which was done in lower limb wounds, and again it showed a significant increase in the reduction of wounds area and also healing. This is the last study, and then coming to a few case studies quickly. Now, these are few patients, as you can see, age is no bar. This is an 87-year-old patient, chronic heel ulcer with a mixed etiology, arterial and venous, and the wound which has got closed in about 23 weeks time post application of a device along with standard wound care. Another 78-year-old male, again, significant reduction in the wound size. Or one more case, good reduction and peri-wound skin improvement after about 4 weeks. One more case again, I'll just quickly run through because of lack of time, I think. I'll just go to one of the last case, which is quite interesting. As I'm scrolling through, you can see a significant improvement occurring in all the cases which I'm showing here. Now, this is the last case I will show just before the bell rings. Now, this fellow, because of improper nail cutting and since he had PVD, developed tip gangrene and it got infected. That's when he came to me. I got angioplasty done, and because it was infected, I had to do a partial toe amputation. But as you can see, the suture line is ischemic. That's when I applied a gecko device, and you can see a complete nice healing achieved at the end of 6 weeks. So this, ladies and gentlemen, actually is a very useful device, a very portable small device which can be used as an adjunct modality when you are looking at difficult to heal DFUs as well as venous ulcers. Thank you.
Thank you, sir. Your presentation has introduced us to innovative approaches that may enhance wound healing and wound recovery. Now we welcome Dr. Srinivas sir on the podium to throw us some light on regenerative medicine, which continues to open existing new possibilities. Regenerative lasers, sir.
At the outset, I would like to say that it's always a pleasure being in the RK meeting at Chennai Advanced Wound Care meeting. So, to achieve diabetic limb salvage, we need teams, techniques, and technologies. You can see a lot of things there, a lot of multimodality approach, a lot of things that we use on a day-to-day basis in diabetic foot clinics. Boiling down to my specific topic, which is a regenerative laser for wound healing. Laser is nothing but light amplification by stimulated emission of radiation. Basically, a laser beam or a device produces a precise, narrow, high-intensity beam of light. Unlike ordinary light, these laser lights have specific wavelengths for which they are designed for. It can be focused accurately onto very, very small targets. Lasers can cut, vaporize, coagulate, or ablate tissues, and they are delivered through various types of delivery systems or machines. Common surgical uses that have been traditionally, that we have heard of is cosmetic and plastic surgery for scar revisions, tattoo removals, lesions of the skin, vascular lesions of the skin, skin resurfacing, in ophthalmology, in colorectal surgery, in dental procedures, etc., and lately in wound healing too. The major surgical lasers, as far as it concerns to wound healing, would be a CO2 laser for precise cutting, or a laser debridement technique that can be done by a CO2 laser, which has that wavelength of 10,600 nanometer, and an ND YAG laser, an erbium YAG laser, which fires at 2940 nanometers, which specifically has superficial tissue ablation property and high water absorption. So lasers can be delivered as continuous wave or pulsed waves. The continuous wave basically, the energy is emitted onto the wound surface continuously, whereas in the pulse mode, you give high intensity energy delivered through short or pulsed bursts separated by a small time gap in between. Which is better? Pulse delivery is preferred because when precise ablation or fragmentation of your tissue, basically the ablative mode of the laser is helpful to debride the biofilm and cause that debriding effect of the regenerative laser. Normal wound healing would look at the wound repair through scar formation, contraction, secondary intention, whereas regeneration that is stimulated by these lasers generally look at restoration of tissue architecture and function, restoration of function of the tissue that's been lost. You look at the laser, basically what does the regenerative laser does, or the erbium YAG laser that I'm going to talk about today, does is stem cell activation, growth, production of increased growth factor production activation, cellular signaling, and tissue engineering onto the wound. Laser-based regeneration or healing of wounds basically can be through low-level lasers, which are called photobiomodulation, fractional lasers, or erbium YAG, which I'm talking specifically today. The erbium YAG platform basically uses 2940 nanometer wavelength, as I told you. It has high water absorption and precise tissue interaction. And there is something called, so the laser basically, the regenerative erbium YAG basically goes through two things. One is you ablate the surface, or you debride the surface first by the ablative mode, and then you do what is called SMA, or spatial modulated ablation, to actually combine the regenerative stimulation to the wound bed. And the proposed mechanism, like we talked of a minute back, is fibroblast activation, neoangiogenesis, epithelial regeneration in the wound. So currently we do not have large publications on, in terms of quality-based evidence like RCTs. We have mostly only published case reports and case series. So we need the present evidence or published literature does tell us that it's biologically plausible, but it has weaknesses in terms of lack of controls or lack of RCTs and smaller group of cohorts. So how do I choose a patient? Any patient with a chronic ulcer, be it a DFU, venous ulcer, pressure ulcer, which has an adequate perfusion, or if the perfusion is poor, try and revascularize first and then add, like Professor Murthy said with HBOT, it cannot replace the standard of care. It can be given as an adjunct to the standard of care, and you should take care of the active sepsis. The ideal treatment protocol for a YAG laser, erbium YAG laser, would be the ablation using the ablation mode and the SMA. Once every week is what I practice. The literature says, published literature says once every 5 to 10 days. Typically in 6 to 10 sessions or 6 to 10 weeks, you see a significant difference in the way the wound bed would move. So in our series, in our work, we've done a few diabetic foot ulcers, one pressure sore, a couple of venous ulcers, a couple of vasculitic ulcers. So this patient presented with a large midfoot, collapsed midfoot, a Charcot midfoot, deformed foot, as you can see in the X-ray, a complete arch collapse, as you can see in the X-ray. And he was advised below-knee amputation. He comes from one of the peripheral districts of Telangana, from Nanded, adjoining Maharashtra. And all that we did is put him onto a plantar slab to offload him and fire the weekly laser and give him just dry gauze dressings. Week 1 to week 6, you can see a significant change and a complete healing brought about by just giving an offloading slab and a dry dressing in addition to the erbium laser application. And then subsequently, once the wound healed, he went on for a correction of his Charcot deformity with modern Charcot reconstruction principles of internal beaming. And today the patient walks on a crow walker. My slide is not moving. Yeah, so this is a go back. One more. Or I can use the mouse? Okay. So this patient is a heel abscess patient, mid to hind foot abscess that was debrided, treated by, it's moving too fast. That was debrided. I'll move it. So we went through this patient. and he's walking on a crow walker now. This patient had a heel abscess, he was debrided, all the pus drained, all the tissue wound bed debrided well, and then he was exposed to weekly laser. In about 10 weeks of laser therapy and just a dry gauze dressing and offloading, he is almost near closure. This patient is a skin donor site which failed to heal in the expected time of healing of the donor site, which is 3 weeks, and this patient was subjected to a weekly laser. You could see that in 4 weeks, weekly application of the erbium YAG, you can see the regeneration and the almost scarless healing that he went on to progress to. This patient is a chronic lymphedema patient who did not respond to anything that was given prior to the laser. And once we started a weekly laser, you can see that in the 3rd week, the significant wound bed improvement and epithelialization process starting by the 3rd week. My next patient is a pressure sore of the sacrum. You can see that this patient was my longest laser. It's almost 20 weeks by the time we reached to the last picture there. This patient came with a very bad second toe wet gangrene and a plantar abscess. I'll talk about plantar abscesses in my next talk, mistakes in surgery. Now, this patient had a transmet amputation and a VAC with installation, and then you can see that a lot of maceration, and then we had changed and given regular wound care, put a skin graft as you saw there. When the patient came back for the graft dressing, I could see discoloration, paleness, and I thought it's almost a compromised skin graft. It's going to fail soon. And then at that point of time, the first picture on the top left, we started using the regenerative laser. In this particular patient, we only used the spatial SMA mode and not the ablative mode because I didn't want the debriding action of the laser onto the graft that was placed there. And you can see that what I clinically thought that this is almost a lost graft, improved very well, and by the end of 4 to 6 weeks of, now I think this last week he had his 6th sitting, and almost the whole thing has regenerated and closed. So expected clinical outcomes out of erbium YAG laser would be improved granulation tissue, improved wound bed, progression of the wound towards epithelialization, and regeneration of tissue of the wound bed by replacement of tissue that's lost and not by scarring. It's an outpatient treatment. Patient does not need hospitalization. Patient does not need surgery. So in patients who are too comorbid, do not want multiple procedures, this is a very good option, and it has good limb salvage potential. Again, it fits as an adjunct to standard wound care and other modalities like the negative pressure or grafting pathways or your artificial dermal substitutes, etc. Still needs quality evidence in terms of histological validation, comparative studies, RCTs, and long-term outcomes. So, possible future direction that this could become placed in our reconstructive ladder or in our reconstructive armamentarium. Promising regenerative technology that helps very well in wound care and needs definitely further quality control studies before we could include or adapt it into routine wound care protocols. Thank you for a patient listening.
Thank you, sir. Thank you for highlighting the evolving role of regenerative laser therapy in wound healing. So there is a question to Dr. Sanjay Vaidya from the audience. Shall we use this device for other purposes? Apart from wound healing, let's say for muscle stimulation, electrical nerve stimulation.
Definitely you can use it for other purposes. As I mentioned during my talk, that actually in the long flights you can use this for prevention of DVT. But mainly when we are actually focusing on DFUs and VLUs, because that is where we see a significant improvement in the wound healing vis-a-vis standard wound care alone. Or actually one of the studies which I showed in a hurry, it also showed that only compression therapy versus gecko plus compression therapy, it showed significant improvement. So as of now, of course, I am using it only in ulcer healing, but definitely there will be indications, as I have said, because it's like your circulation increases to 60% of the walking cycle. So probably in bedridden patients, whether we can use that as an adjunct just to, but as I said, it's not a way of exercise and it's pretty expensive.
Thank you, sir. Now we move on to the next session. The moderator will be Srinivas, sir. I request him to stay back. We request Srinivas sir to stay back. We request Ms. Tang, Dr. Erika, Dr. Ashwin Baba, Mr. Bikki Kumar Shaha, Dr. Vikas Kakar to be on the stage, please.
Do we have enough chair? Can we have one more chair, please?
The session is going to be on integrated perspectives in wound care, modern wound care for that matter.
May I kindly invite the first speaker, Ms. Vegan Tang, a senior podiatrist from the King's Hospital at London. What we do at King's, the podiatrist perspective.
Good afternoon, ladies and gentlemen. So I'm going to talk about what we do at King's, the podiatrist perspective. Oops. So I have no conflicts of interest. So the King's Diabetic Foot team is the world's first diabetic foot MDT unit, which was started by Professor Edmonds, who we can see here, in 1981. So we celebrate our 45th birthday this year. The aim of the unit was to reduce amputation rates in patients with diabetic foot complications. It started with one consultant and one podiatrist. So 45 years later, we have a much bigger team. We are very fortunate to have Professor Venukava Farpu, who is our head of diabetic foot and ankle surgery. We have our vascular team, our podiatrists, our diabetologists, and our nurses as well. So the King's Diabetic Foot Clinic has now transformed into an acute day unit. So we aim for a one-stop shop where we try to do imaging, bloods, scans, and treatments all in one day. A lot of our patients are still working, so multiple hospital appointments are not great with their employers. We have an 11-bay outpatient clinic, 2 minor surgical procedure rooms, and we offer a 5-day-week service, seeing approximately 600 patients a month, and all our patients are able to attend as a walk-in SOS between Monday to Friday before 12 o'clock. So, as I've just said, we have a big team. So we have our diabetes consultants, our podiatrists, our orthopedic, vascular and plastic surgeons, our infectious diseases consultants, our nurses, and also other allied health care professionals, including physios, occupational therapists, and orthotists. This list is not in order of importance. We work as one team. So what do podiatrists do? So in the United Kingdom, if you ask 9 out of 10 clinicians who do not work with a podiatrist what they think we do, the answer is they cut toenails. So we do much more than that. So the podiatrist at King's is the gatekeeper for gold standard diabetic foot care. We are responsible for wound assessment, neurovascular assessments, sharp debridement, dressing plans, which we create and implement. We also are responsible for checking the results of any imaging and blood test results we request, biomechanical offloading, and we take part in all our MDT specialist rounds, both on the clinic and in the ward, including discharge planning, which is really important because we can't have a patient who is medically fit to be discharged occupying a hospital bed, which is required by somebody else. And of course, we also attend our infection control MDT, where we have patients who have concerning microbiology results. So as you can see, King's likes to keep the podiatrist busy. So what we do is we triage our patients into the appropriate pathways. So twice a week, we have our orthopedic MDT. We also do an orthopedic virtual MDM, where external surgeons refer their patients to us, either for a second opinion or for us to take over their care. We do twice a week vascular clinics, and every day we see our Charcot patients and our ulcer patients. So in our clinic, for wound assessment, we routinely use a 3D wound imaging system to assess our wounds. So the camera we use is a silhouette laser camera, which measures area and volume of the ulcer. So the measurements are sent to a computer, which clinicians and patients can both see, and they can track the progress of the ulcer. Studies have shown that a percentage area reduction in wound size is an early predictor of treatment outcomes and can be used to guide treatment pathways. So PAR at 4 weeks has been used to assess the likelihood of ulcer healing. So here you can see the camera on the left. So this is the laser camera. We take a picture of the ulcer and then we can trace around it. So these measurements are then plotted on a graph so that we can see the trajectory of what the ulcer is doing. So for our neurological assessments, we use the neurophysiometer. Obviously, the vibration perception threshold varies with age, but as a ballpark figure, a patient with diabetes who has a VBT of over 25 is considered to have a loss of protective pain sensation. We do use the 10-gram monofilament as well, but very rarely the tuning fork. So for our vascular assessments, the most important assessment for this is the clinical observation. It's what you can feel, what you can see, and also what the patient tells you. Because invariably, if I ask one of our patients with PAD, do they have any pain? They'll probably say no. But then if you say, if the pain comes on, how do you relieve it? And they will always say, I put my leg down to get some relief. So we use the handheld Doppler, but we also have an incredible vascular laboratory as well. So sharp debridement is one of the biggest part of our job. So wounds don't heal, as we all know, simply by putting a dressing on them. So we need to debride our chronic ulcers to convert them back into an acute lesion and then manage them with our choice of topical management. Our podiatrists also assist our orthopedic surgeons in our procedure rooms to do minor surgeries. Here we have Professor Kavafapu and Patricia, one of our podiatrists. So this gentleman who they're treating now came as a new patient on the day with quite a nasty toe infection, which actually needed to be removed straight away. So we were able to do that on the same day. So for our dressing regimens, the podiatrist will decide what is suitable, and we implement it both on the wards and in outpatients. So in the UK, patients can be seen by the district nursing team at home if they are housebound. The DN team will classify housebound as somebody who is unable to leave the front door of their home. I would argue that all our diabetic foot patients who have an infected ulcer that needs redressing is housebound. However, we do appreciate the finite resources available. For patients who are not housebound, they are referred to community clinics. But we also encourage patients and their family to change dressings if they are able to. Our policy is that all patients are sent home with 2 weeks of a new supply of dressings if we change the regimen, and then a letter is sent to their GP to request prescriptions. So offloading is one of the most important parts of a podiatrist's role, as incorrect offloading can be the major reason ulcers don't heal and reconstructive surgery fails. Oops. Sorry. Oh, I don't know where I'm going with this, sorry. I'm going back, aren't I? Sorry. I need to go back to... this one. Oops, this one here. Thank you. Thank you very much.
I think your hand moved too fast than your talk.
Oh, okay.
You can use the keyboard instead.
Oh, okay. Right. So anyway, so there are lots of conventional ways that we encourage our patients to offload. For example, using an electric scooter on the left, using crutches, and also using a knee scooter. There are unconventional methods that patients can be offloaded, which we don't approve of, such as demonstrated by my colleagues here. We don't ask for patients to be carried around to take pressure off their feet. So our favourite form of offloading is, of course, the total contact cast. The main function is that it facilitates offloading of the foot, reduces mechanical forces, edema and inflammation. It redistributes plantar pressure, it limits bone and joint destruction, arrests the progression of deformity, and allows soft tissue to recover. So the total contact cast was first used in India, actually, in the 1930s for patients with leprosy who had neuropathic ulcers. It was rediscovered by Dr. Paul Brand in the 1960s and used for leprosy for patients of velour in India. My apologies, I spelt velour wrong. And it was imported to the USA by Dr. Brand for patients with leprosy and diabetes. This technique was first applied at King's and also in the United Kingdom in the 1980s by our very own podiatrist Ali Foster and used as an offloading technique for diabetic foot complications. So for the TCC, the picture in the middle is our classic total contact cast, which we can upgrade to the one picture on the left, which includes a bowler walker for our post-surgery patients. This technique allows the foot to be suspended about 1 to 1.5 inches off the ground, which allows a little bit of mobility, but without them putting the weight through their foot. We can also then downgrade it to a bivalve cast seen on the right, which is a 2-part total contact cast. This enables patients to transition from cast to surgical footwear if they need to travel overseas by plane, as you can't travel with a fixed device on a plane. And it also allows patients who need regular wound dressings to be managed without having to change the cast each time. So we can adapt our cast with a window, which we can see here. This is really useful if patients live quite a long way from the clinic, because it allows us to manage and monitor their wound, and the cast doesn't have to be changed every time if it is functionally good. Our orthopedic surgeons have recently started using the transverse tibial transport device, and they challenged us to put a total contact cast on. It took me a long time to work out how to do this one, but we managed it. We also use off-the-shelf offloading devices occasionally, such as the Optima Diaboot on the left, which has the rocker bottom and gives a certain amount of support with the free-layer insole system. We always use the diabetic air cast, and of course, this good old simple semi-compressed felt to take pressure away from an ulcerated area. It is the podiatrist's responsibility to look out for any results, for any imaging and biochemistry for the patients that they are looking after. So what we do is we then flag the results to the diabetes consultants for action as needed. And if on imaging there's any broken metalwork for our reconstruction patients, our surgical team are informed of it straight away. This ensures that problems are identified and actioned immediately, and that there is a continuity of care. So as I said before, we do have a range of our specialist MDT rounds, which we all take part in. And we've also we also participate in clinical research. Here are some of the projects that we've worked on. And at King's, we are very keen to share our knowledge and experience, but also to learn from our international colleagues as well. So we organise a 2-week placement programme for overseas podiatrists. Here you can see the team last year who came from Hong Kong. We also had somebody from Saudi Arabia. And the idea is that they experience what the MDT at King's does. So our orthopaedic surgeons are very good. They teach the flexor tenotomy workshop. The podiatrists at King's are taught how to do flexor tenotomies by our surgeons, and we do them with them. So we have Tim here on the right, who retired 2 years ago. He has taught every podiatrist at King's for the last 24 years how to cast, so he is the genius. So we do work hard, but we also have a great team, and we play hard as well. So thank you very much.
Thank you, Vijan, for that podiatric perspective. I would like to invite the physician perspective at King's. Dr. Erika Vaineri will tell us how the physician's perspective, how do the physicians in the diabetic foot clinic work.
Good afternoon, everyone. So I'm going to continue the talk on what we do at King's, and this is a physician perspective, I mean, diabetologist perspective in a world of surgeons, like in this room, actually. Now, we know very well the relation between diabetes and food. So diabetes, peripheral neuropathy, peripheral arterial disease, development of a diabetic foot ulcer, the predisposition to the infection, and the high number of infection in this patient. So we know this, but those patients come along to our observation also with complex medical background. They can have cardiovascular issues like coronary artery disease, heart failure, peripheral arterial disease, renal disease like chronic kidney disease, and stage renal disease, metabolic problem like hyperglycemia, obesity, malnutrition, and we know that patients with diabetes have a 2 to 4 high risk of cardiovascular disease. The cardiovascular disease is actually the leading cause of mortality in this patient, and diabetic foot ulceration are actually associated with a mortality at 5 years, which is equivalent, you can see in the picture, to all cancer. But when it comes to major amputation and critical limb ischemia, it's also more than all cancer. So this is from the National Diabetic Foot Audit in UK. We can see that the 6 months mortality, the variable associated to the 6 months mortality are mainly heart failure, ischemia, renal replacement therapy, smoking status, high BMI, but also we can see the variables associated with major amputation, ischemia, age, smoking, renal replacement therapy, and infection. So those complex patients we know are very complex from a medical point of view. So we have established, in view of this at King's, different type of MDT to address all those complexity. So we have multiple diabetic foot MDT, like joint orthopedic MDT, Wijan mentioned before, the joint vascular MDT, microbiology MDT, and renal MDT. And those MDT are linked together, are not separated each other, of course. So in the joint diabetic orthopedic one-stop treatment clinic, we review imaging, we plan total contact casting, we plan complex surgical correction, and we review post-surgical patient, providing joint care and surveillance. In the joint diabetic vascular MDT, we review usually all patients within 3 days of referral. If they are urgent, within 24 hours. We have access to vascular lab assessment the same day. We can provide duplex angiography, and patients are referred the same day for angioplasty assessment or a bypass assessment if required. And joint diabetic foot microbiology MDT, twice a week ward round and twice a week outpatient review, where we analyze together the microbiology samples. We aim to target the therapy essentially. And what about the joint renal foot MDT? So I want to spend a little bit more on this topic, because there is a strict relation between diabetes and kidney disease. We need to consider that 30 to 40% of patients with diabetes may develop kidney disease. So chronic kidney disease and end-stage renal disease are associated with higher risk of foot ulceration, delayed healing, higher amputation risk and mortality. And the presence of renal disease can make challenging very aspect of our care, like antibiotic dosing, the use of contrast, the fluid balance, electrolyte management, and of course wound healing. There is a bidirectional relationship between kidney disease and diabetic foot ulcer. From one side, we have a kidney disease, which can worsen the neuropathy, the peripheral arterial disease, the infection risk, And on the other side, the presence of the diabetic foot ulceration can actually trigger the nephropathy because of a chronic inflammation, which can lead to increased level of cytokines and increased risk of acute kidney injury during, for example, an admission. And what about the patient on renal replacement therapy? The problem is even worse. Those patients in dialysis are subjected to reduced oxygenation, in particular in the foot, reduced foot oxygenation, so the microcirculation is worse. And other factor, they are subjected also to deformity like variation in foot size due to fluctuating edema during dialysis. They have also less podiatrist access than other patients, and also the prolonged immobility can lead to heel pressure. So those patients are have an increased risk of diabetic foot ulceration, higher risk of major amputation and mortality. So those medical complex patients require often also complex surgical intervention like surgery for infection control, complex revascularization, or Charcot reconstruction. We can see here a patient coming with a superficial wound rapidly spreading the infection, and the patient underwent an extensive debridement, and after intense wound care, we can see a granulation. And we need to consider that also in infection, there are comorbidities that can actually worsening the prognosis of infection. You can see in this study how the peripheral arterial disease, the chronic kidney disease, the dialysis, cardiac failure, transplant, liver cirrhosis, and cancer can make worse a diabetic foot infection. Those patients require often also multiple intervention. For example, they require not only a debridement, but also a vascular intervention from endovascular, like we can see here, an angioplasty, to high-quality modern revascularization technique, as we can see in this picture. And also, there are very, very complex surgeries that they may require, like complex Charcot reconstruction. Those pictures are courtesy of Professor Venu Cavatapo. You can see here this patient coming with a severe foot deformity and also SFA stenosis, popliteal stenosis, underwent an angioplasty, and after the angioplasty, Charcot reconstruction, and we can see after the reconstruction aligned foot. Another example of complex surgery, infected Charcot foot. And in these cases, usually we plan with the surgeons, two-stage reconstruction where the first stage consists in removing the infected bone, as you can see in the picture. Then we achieve a good healing, and after a few months, we can proceed if we are sure that the infection is not present to the second stage. So very, very complex surgery. And sometimes we used to say, oh, why the surgery has failed, why the patient is not healing? There are many factors influencing this, like a poor vascular supply, persistent infection, poor glycemic control, renal dysfunction, cardiovascular factors, and malnutrition and inadequate offloading. So when it doesn't matter how the surgeon is brilliant, but we need to have medically optimized patient first. This is a recent meta-analysis where they have analyzed the association between diabetes and postoperative complication in non-cardiac surgery, which has showed that patients with diabetes have high risk of infection, renal insufficiency, and myocardial infarction. So the key pillars of the medical optimization are metabolic control, so glucose optimization, lipids optimization, renal, liver assessment, multimorbidity control, like cardiovascular risk optimization and weight management. We have seen this morning a beautiful, extensive session on the weight management in this patient. Infection assessment, is there any infection, what type of infection, and decision on the antibiotics. Vascular assessment, what type of degree of vascular disease, do we need intervention, what type of intervention. Wound care, the podiatrists are the pillar in this, regular wound checking, appropriate dressing choice, and also offloading planning, total contact cast, ortho and orthosis. Now, regarding the glucose optimization in the UK, we follow the NICE guideline, essentially in elective surgery. We recommend HbA1c less than 69 millimoles, which is 8.5%. However, there are some particular surgery where we cannot really wait, which are the time-critical Charcot reconstruction. I showed you an example before. This is, I want to bring our experience to you today. This is a recent publication from our unit, where we have evaluated patients undergoing elective time-critical Charcot reconstruction. And essentially, those patients, we evaluate those patients in our MDT, where we evaluate surgical risk, which can be aggravated, we know, by the poor glycemic control, like high risk of infection, cardiovascular complication. But also we evaluate the risk of delay in surgery, because if we delay this type of surgery, we can have a progressive deformity with increased ulceration, and we know that the ulceration in those patients can actually increase the risk of infection and amputation. And also, we need to consider that those patients waiting for complex Charcot reconstruction frequently have a limited mobility, and the limited mobility during time can increase the weight. The weight can bring more insulin resistant. Insulin resistant makes the glycemic control very, very difficult. So we have evaluated those patients retrospectively, and we have divided in two groups, patient with a target HbA1c preoperatively and patient with non-target HbA1c postoperatively. And you can see the HbA1c level in both groups after 12 months of surgery was significantly lower. We had in both groups satisfactory bone healing and fusion at 12 months, and the bone fusion outcome at 12 months was actually satisfactory in both groups. So the preoperative HbA1c level did not affect the bone fusion, and also very good functional outcome. So this is our experience from King's, that in a context of MDT, multidisciplinary approach, some elective Charcot reconstruction can be feasible option even in suboptimal preoperative HbA1c level. So the MDT is the crucial point to treat those patients. And in summary, diabetic foot disease reflects an advanced systemic pathology. Cardiovascular and renal disease strongly influence the surgical outcomes. The surgery must be planned within a coordinated cardio-renal metabolic care pathway, and the perioperative optimization is central to limb salvage. Thank you very much for your attention.
Thank you very much, Erika, for a wonderful talk of the physician perspective. It's my pleasure to invite Dr. Ashwin Bawa all the way from Punjab. He has come for us. Is going to speak on a very interesting thing, which is photographing and documenting wounds. A lot of us are poor at documentation, and a lot of us keep meddling with our WhatsApps and emails. We get a lot of pictures day in, day out from various patients at various stages. Probably, how can we make sense out of photographing and documenting? And he happens to be my AI guru as well.
Thank you, sir, for the kind introduction, and thank you, Kesavan, sir, for inviting me. I'll start with a small story. So this is 2010, young surgery resident, senior resident, Always enthusiastic about buying the latest iPhone. Started clicking a lot of photos. Photos. Wife's photos were less, but wound photos were more. 2020, COVID made me really free, so I thought I'll start collecting a lot of photos. So I put my carbuncle photos together, and I was applying negative pressure wound therapy to them, sent it to a journal for publication, 16 unique cases of carbuncles, back, everywhere, negative pressure wound therapy. I'm very embarrassed to tell you, and I thought I'll put a screenshot here. The journal replied back, excellent photo documentation, never seen before in the world, but dear sir, remember to put a foot ruler with your wounds, and you need to have a measurement for standardization. This never got published. It's still not published, by the way. So the images, evidence, as sir told, I love AI, and a lot of slides are made using AI. So I just put a camera to myself. I'm a general surgeon, was professor and unit head, just left that role. I love technology, and I can call myself a better wound photographer since then. Just to see my AI progress, you can scan this and just give me compliments. I made the website myself. This is what AI has progressed into. Hernia has nothing to do with wounds, but sometimes we have infected meshes, and we land up in some sort of a soup where we need wound management and negative pressure wound therapy. So the first thing is, how do you capture wounds? The second is measurement. Reading, matlab, how do you see tissues? Beyond white light, how do you use fluorescence imaging? I have a separate lecture on this. How does AI come into the picture, and how does governance in terms of consent, data protection, and other things come in? This is me, again, used AI for creating this, a confused surgeon. Dr. Keswan sees a wound, Dr. Bava sees a wound. Dr. Keswan says, this is healing very well. Dr. Bava says, this is better today. And Dr. Vibian says, oh no, this is bad. So 3 perspectives, no image captured, and that's it. That's how our life goes on. A wound described is interpreted, a wound photographed is a standard, is recorded and can be compared, transmitted, defended in court, and maybe studied together. Again, very interesting slide. Where are we? I think so all of us as podiatrists, diabetic foot surgeons, can see our entire gamut of where we are in terms of imaging. One is, sometimes I'm like that naked eye notes, that's how our residents are. The other is between wife pictures, children pictures are wound snapshots. That's there. Then there's app-based 2D planimetry. These modern innovative apps are there. Then you have these 3D structured light, and I'm glad that I've been using such tech in my practice. And there's fluorescence imaging. And then let's imagine this with the kind of data this room holds, the legends that we hold are there in this room together. We could capture all our data and maybe predict wounds just as we, put in age and input, and that is very much possible with AI coming up. So 44% reported error when you just measure the length and width of a wound. You require just 3 views to complete defensible records. So what does a photograph give you? One could track healing. One could hand over, my patient can go to Dr. Keswan and I can share my image. Telehealth, you could remotely see how your patients are doing. Medico-legally, it is very, very important. You can land up in a soup anywhere for any sort of wounds. It's very important for research and audit. And one can engage patients. If you just tell them that, your wound is being tracked, I have patients who say, can you show me the next image? I want to see the percentage of wound that is healed. So how do you capture wounds? One is take a wide view to know the orientation. Just a close-up. It might be a perianal wound which would look like a leg ulcer. So be very, very sure. Have a full orientation from a distance. As I told you, my sob story, reference it with 2 scales, length and breadth perpendicular to the wound. Third is, which I learned today while I was making these slides. Oh, I told you that I made these slides today. You have to place a color calibrator, either a gray calibrator or a multiple color calibrator to, have a white balance to your images. Again, the first wound should be orientation. I can share the slides, by the way. There's nothing special. Don't click pictures. Please have the full gamut. Always place and tell your assistant to, place the wound parallel. And I learned it again today that you can have an oblique wound even if it is a cavity wound, just take an oblique view as well. So these are important things. Tell your assistant distance, the same fixed distance every time. It gives you consistency in images. Lens always square. So if you're taking your wife photographs, with all due respect to my wife, she might be sneezing somewhere, but always keep the subject in the center. So that wound has to be in the center. Diffuse, consistent lighting. Do not use flashes. Flashes obscure the images sometimes. Have a good fluorescent light. Use the same room. Maybe put a background to the images. You can use the same drape every time, blue colored drape to, be very consistent. And if you are a part of the RK team, you could brand every time, have a RK logo to all your things to, add it to the slide. A scale marker, as I told you. And maybe have the same device. Do not use your personal devices. Because I would tell you about the DPDP Act, which is coming up. Very, very dangerous act by the government. That could land you up in a soup, or maybe you'll be, poorer by 50 crores. This is coming up next year. DPDP Act, please search for it and know what it is. Again, keep the sensor of the phone parallel. Repeatedly, same distance, the hero has to be at the center of the frame every time. Color is a clinical signal. Wound bed color, we all know about red is healthy granulation tissue, slough, and black. Red, yellow, black is the color of your life for all wound healers. Again, white balance is not optional. We have those HDR beauty modes on. iPhone has this setting where you have the color gradient. Be very sure of what you're capturing. Measurement from picture to number, I spoke about, placing two scales parallel to each other. What a flat image cannot see is depth, undermining, tunneling, and volume. I'm just worried about the time, just in case, Chairman Sir, if I exceed, just let me know. So that's why I'm trying to be fast. So there are 4 ways you can measure wounds. Ruler, length and width, acetate tracing, digital planimetry, calibrated area from a photo can be used to convert, the software can help you in converting it into length and breadth, and 3D structured light. I've been using one of these devices called eCare, and I think I have images of that as well. So most wounds are closer to an eclipse. About, there is a mismatch of about 27% when you measure length and width. If you use these modern devices, you can capture depth and volume of the wound as well. This can give you tissue composition. It can measure your borders automatically. So this is an image out of eCare. I'm sadly paying about $700 for every 3 months of their usage, just calculated in terms of rupees, but it is crazy. I'm subscribed to them because I have a lot of image stored since the last 4 or 5 years. COVID made me buy this device so that I can be perfect with images. Our friends at Advio Diagnostics have this measurement now available with them. But again, you can measure length, breadth, volume. So this was a non-healing ulcer. And this was an uncle of mine who was not healing, used negative pressure wound therapy. You could see the granulation tissue increase from red 18% to 74%. So doing better. This is from 2022. Finally I grafted the wound and the final result is this. It can take out digital reports. I am still a fully practicing general surgeon. Showing a pilonidal abscess or a pilonidal wound is, I don't know, counted or discounted in a diabetic foot conference, but this is a wound that I captured recently where I applied negative pressure wound therapy to a wound. You can take out reports and you can see the healing graph in the patient. So what a flat image cannot see is depth, undermining, tunneling, and volume. These 3D devices can help you capture all of this. So reading the tissue, there is a problem in terms of knowing the viability of tissue, infection, inflammation, moisture, and edges of a wound. Come on, all of these are clinical assessments. So the slide has been added to tell you and reiterate again that there's nothing better than clinical assessment. So a photograph can mislead you. You could miss non-blanchable erythema. You could miss a deep wound, or slough or eschar obscures the base. You do not know what is happening underneath. You might have osteomyelitis. So there's nothing like photographs might support the assessment. Never let the photograph make it alone. I have a full talk on fluorescence imaging where, all these, where you could read infections in wounds, and I would talk about this in detail in the next session. So this is where you could read infections in wounds using fluorescent light. Once it's thrown over a wound, you would know about gram-positive and gram-negative. You could capture bioburden more than 10 raised to power 4. So this could help you in targeted debridement, guided sampling, dressing choice, and track response. So again, we're moving from naked eye to AI integrated capture. So I'm going to talk about intelligence, prediction, AI, and telehealth. So this is important. If an area is reduced by 20 to 40% in week 4, we know that a wound is healing. So all these devices help us in knowing where we are progressing to. So you could track area and time and see if a wound is healing or not. And by the way, the image I showed you is doing exactly that. So we know that AI in the future would help us, see little multiples and tell us where the wound is heading towards. And then there is telemonitoring where you could, use patient's camera to, sync their data and know what is healing. Of course, there are warning signs. There is fever. There is redness. You have to be very apt in knowing what is happening with the patient or not. The next is governance and implementation. For all these wounds, please make sure you take consent. With DPDP Act coming in, you need to kind of tell, and if I'm adding identifiable things like there's a tattoo involved or there's patient jewelry involved, even if the name is de-identified, the patient can still see you in court. So have your consents there in place. So all your data needs to be stored properly. It should be stored in the cloud properly. I'm asking you, please go through the DPDP Act. It is really, really going to be a game changer. It is tougher than any HIPAA compliance or any European guidelines that exist. So a good photo is a habit. A great archive is a system. My topic was not only photo, but documentation also. Discipline gives you one excellent image. A system turns thousands of them into a teaching, research, and instant recall without losing a single file. So I must tell you, again, advices, I'm looking at the time again and again, but designate 2 to 3 people in your office who can take these images consistently. It is a habit. One written protocol, the same distance, the same angle, the same background every time, and the same branding. Same hands, same image, and audit. Somebody has to look at these images again and again. Dedicated capture device, do not use personal things. Have a password biometric lock. Auto-sync to the archive. Review and quality checks. Segregate and classify. Flag errors. Assemble and report back. I have these things organized on my Google Photos where there is pilonidal sinus, diabetic foot, NPWT. You cannot leave hernias from me. So, hernias a separate folder. Surgical site infections. We use that for our photographs, for our Instagram favorites. Have your favorites stored. Now, archiving is very important. So 3 copies of every image should exist. Have a NAS attached to it. If you're a bigger hospital, have a network attached storage where you store every data very carefully. These hard drives can conk off, and whenever you need them, it would not work. So one is Google Drive. The other is a network attached storage, which has multiple backups of hard drives. So a hard drive can have a hard drive backup, and if your data is very important, I need not tell again and again that buy a NAS, invest in a NAS. So capture, review, classify, curate, store, and then we become a publication powerhouse. So I think this is the last slide. consent and expose. 3 views, use proper color, scale, fix the variables, same device, light, distance, angle, background. You have to move from 2D to 3D to fluorescence imaging and encrypt timestamp ID. You never know where this image might be helpful. You need to defend yourself in court, maybe, but this is the way forward. Thank you so much.
Thank you so much, Dr. Baba, for a wonderful, as usual, wonderful, exciting waking up talk post-lunch session.
Thank you.
I would like to invite our next speaker, Mr. Biki Kumar Shah, who's again on similar lines going to speak to us on app-based preventive wound care. So we're going from photos to apps. By the time technology helps us, I think if there are any questions for Vigin or Erika, Dr. Erika or Dr. Ashwin Baba, you can, from the floor, you can kindly discuss by the time they open up the system.
So just to reiterate about the DPDP Act, be very careful of your WhatsApp posts. Remove all identifiers from the photos that you post. And you never know what happens next year. They've started fighting a case recently that was supposed to happen from May 10th to May 14th, where they filed against the DPDP Act. But till then, one has to be very careful. In fact, our hospital had an internal meeting to have these consents in place before anything. As a part of your general consent also, you need to take consent for image capture and other things. So I'm not scaring you, but it's my duty to tell you that this is going to be big. So be very careful to remove all de-identifiers. I have loose strings everywhere. So I have my Excel sheets hanging around in various WhatsApp groups. You have, when you work with an enthusiastic bunch of residents, it's not usually you, but the leakage can happen anywhere. So be very careful. Use only initials in your datas and everything. Do not put your patient names. Be very, very careful. Thank you.
Okay. To Srinivasan sir, in a weekly laser therapy, should we go daily dressing with dry gauze or else any specific dressing in between laser sessions?
Usually, there are 2 ways of looking at it. As per the laser protocol, they say every alternate day, dry gauze dressing is enough. But Dr. Vaidya has been using laser for a longer period of time than us, last 4 or 5 years plus, the same erbium YAG laser. And Dr. Vaidya combines other dressings like foam dressings or alginate dressings or Orgostard dressings, NOSF dressings with the laser. So you apply the laser, apply them, and the frequency can vary based on the individual patient, based on the level of exudate.
Thank you, sir.
Please, sir. Oh, we are on. We'll finish with this, your question.
Hello. Question to Dr. Baba. nice and very informative new technology. What gears you advise while taking photographs? A mobile phone or a DSLR?
DSLR, sir, any day.
Okay.
DSLR is better, but maybe if you have a very compact practice, have a phone especially for image taking.
Okay.
So
In phone also there are various like iPhone or a small Android.
I am not promoting one brand, sir.
No. It's a question of quality of the lens.
So
It's not a brand.
So all these newer lenses which have a wider aperture, the Samsungs and the iPhones of the world with a wider lens is better, sir.
Thank you, sir.
Yes, sir.
Thank you, sir. I think we'll start off with Mr. Vicky Kumar, please.
Hello, everyone. Good afternoon. Always happens in the live demo, but thank you for sticking with me. So I am not a medical, sort of a medical surgeon or a medical person by trade. I am actually a software engineer. I got into medical device engineering really early on in my career, and it is something that has excited me throughout. So I have been working with Dr. R.K. Podiatry and Dr. R.K. Diabetic Foot Center to develop an application where we are going to democratize the image taking at a very personal level. Now, we have a solution which are sort of costs lakhs of rupees and sort of comes with their own trade-offs. But we wanted to think of a way, basically where we would have a solution at a very root level in the villages and the places where the development has not penetrated yet, and find a way to basically monitor and resolve this particular condition. So when we see the number, it is so big. It says that a limb is lost due to the diabetic foot ulcer every 20 seconds. Now this number is so vast and absurd that it sounds made up. So the amputation, it does not start with a, immediately like an emergency. It's a small ulcer which people might neglect because of the neuropathy and the associated condition that might mask the pain and so on. So every doctor in the room does prescribe that the highest yield for prevention is actually the daily foot inspection. But does that work in practice? We saw a few slides where it was recommended that patients take a regular photo of their foot or do regular monitoring. Now, I have sat down with multiple patients, our team. We have actually seen the mobility of these patients. And what we see that these patients have really a hard time sort of having that mobility, having that dexterity. The vision is also sort of compromised, and they could not even see the screen, let alone, hold a phone, press the shutter button at the right time, ensure that the foot is in the frame, all of those things going on at the same time. The language is also a huge barrier. So we sat with the patients. We did not start with a model first. We actually started with the patients, sat with them, and understood their problems and designed a solution around these points. So there is one use case that I am going to present. One specific use case is how a patient takes the photo of their feet. Now, we went through multiple iterations. At some point, there was a selfie stick involved to take the photo. But finally, we conversed on this way that there would be a lightweight sort of a model running on the phone that would segment the foot in real time, which runs more than several frames per second on the device, and does a great job at segmenting the foot. These are the images taken, intentionally taken at a very busy background. The first image that you see is very busy, and the second image is also sort of blends in with the background. These are all taken at very low lighting condition, just to show how good it performs. Now, the procedure for taking the image is that the patient would hold their phone first on the fore of their foot. The model would detect automatically that the foot is in the frame. If it is not, it would guide the patient in their own regional language to move closer, sort of move away until the until the foot is right in the center, it will automatically take the photo, guide the user to move to the next foot, and then when both the forefront of the foot are done, they will be asked to place the phone on the floor. It will switch to the front camera, and we are going to image the heels now. This particular model right now that we see is running on a flagship Google device with a very high performance chip. Now, that's not really true. So this particular segmentation model is actually running on my mom's phone, which is 4 years old Android phone, which cost around 20,000. So this goes to show that these kind of technologies, when incorporated in an application, can run in a phone which can run common applications like WhatsApp or Facebook. And you don't need to buy a personalized hardware in order to do that. And moving on to the next one. Once the image has been taken, the next part is the analysis and understanding the features of the image. Now, this is where the foundation model comes into play. Dr. RK and the team, we have worked on annotating 10,000 clinical images. Now, these volume of images that we have analyzed and the number of features that has been annotated is, I think, one of a kind, and it truly sets a benchmark of how diverse and comprehensive a data set can be. And in terms of the accuracy, extracting ulcers, the accuracy is around 90%. And this particular model, it runs on the cloud. Once the image has been taken and the patient can just rest the phone, the rest happens in the background. So in order to ensure that, so we saw some false positive being marked in terms of the blue pixels on the toes. So in order to suppress this false positive, which are going to always happen in machine learning applications, we have developed a pipeline for the entire end-to-end capture analysis pipeline that is going to suppress these kind of noises from the signal. So first of all, we are going to ask the patient by sending them daily reminders to image their foot 2 times a day. That each capture session is going to be repeated twice. And then we are going to do an image level analysis on this, on each of these images. And basically, we are going to collect the metadata, the usability signals, and so on. Then we are going to run the daily summary on top of the images that were captured on that particular day. Now, all of these things that are happening in an isolated, deterministic way. So in order to ensure that the reliability of this entire pipeline is met, we are using really scoped down data structure in order to track various conditions that are happening at an image level. Now, once we have the daily summary ready, we are going to have a sliding window where we are going to calculate the cumulative trend, which basically shows the various conditions that are happening in the foot. Then at the very end, we are going to have a translation layer that is a generative AI model, which is going to run on top of the anonymized daily trend data structures to translate that into clinical narrative and patient-facing sort of a calm and safer way to inform the patient about what's happening with the foot. So the DFID's job is to triage and surface, and the diagnostic and treatment remains the doctor's job. Now, here is the quick architecture view, a very high-level architecture of what's happening. And we do also have a reshoot mechanism. So in any case, the patient has quickly moved their image, moved their phone. There was a bloodiness caused due to any rare edge case. In that case, we are going to have a reshoot option, which would just resume for the image that was not correctly taken. We can see that the generative layer sort of the layer that we are applying on this entire pipeline is towards the very top, or in this case, towards the very bottom. Now, the reason being that the recent FDA guidance, which is the draft guidance which came out, which talks about the post-market submission of the devices. This is about the AI-enabled medical devices software features. In this draft, they talk about the transparency of the model being used, versioning of the prompt, the configurations of each model calls, what are the parameters that are used to call the models. So all of those things we are trying to also capture early on, because we know from the trend that since it's a draft, it's going to be soon proper guidance. This is a quick snapshot from the doctor's view. As you can see, on the left, we have the patient name, the patients which are associated with a particular doctor, and then we are going to have the longitudinal view of all the foot views, basically, and then we have the insights, or basically the trends in each of these regions, and then we can see the impact over time, the trend over time. Is it actually worsening, or is it getting better? Now, these sort of also shows how many days were used for doing that prediction. So a longer trend window is always better. Now, this is an organizational view of this application, and basically here the organization admin can manage everything at an admin level. They can manage the roles, they can manage the pipeline, and if anything breaks and so on. And yeah. Moving on, this finally closes the loop. The patient who could never inspect their own foot are now able to take images. The DFIT works in the background, silently processing these images and surfacing the insights for the patient as well as the doctor. The worsening can be caught really early, and the user can be notified. And the doctors can see the clinical narrative, they can see the longitudinal view of how the foot has evolved over time and so on. And yeah, thank you so much, everyone.
Thank you, Mr. Vicky Kumar, for that role of applications or developing application in wound care documentation. I'd like to invite myself for the next talk.
So, Dr. Srinivas, my friend, will speak on tips on starting a diabetic foot clinic.
I think let's keep this as interactive as possible. We have so many senior surgeons here. Dr. R.K. runs the first tertiary exclusive single specialty diabetic foot hospital in India. Professor Ajay Kumar runs a multidisciplinary private hospital which has podiatry as one of the lead services. We have Dr. Sharvan Kumar, we have Professor VBN, we have Dr. Kakkar. So probably I'll take in some inputs as I discuss, and we can make this as interactive as possible. These are basically a little cues that you can. So looking at, I think I'll need my spec for that slide, I'm sorry. Looking at any diabetic foot clinic or any diabetic foot service, we need to be able to do 8 collective clinical skills. That is, the members of this diabetic foot clinic should be able to perform hemodynamic and anatomical vascular assessment and neurological assessment, the need for revascularization, ability to perform a neurological workup, ability to do site-appropriate culture technique and take specimens, ability to assess the wound and document the wound, as we just heard from the previous last 2 speakers, ability to initiate appropriate culture-specific antimicrobial therapy to the patient, appropriate ability to post-op monitor and do wound changes and wound care, regular wound care to the patients, and ability to do foot care education, impart foot care education knowledge to the patients. And based on these 8 skills, you can have multitasking doctors or multitasking professionals or paramedics in the clinic who can equip themselves with any of these 8 skills, and then risk stratify these patients into active foot disease that need urgent attention, low risk, high risk, and medium risk based on their risk factors, i.e. neuropathy, significant vasculopathy, or significant deformity, risk stratify the patient, and then personalize the treatment given to individual of them. And it's worthwhile to actually look at any diabetic foot clinical service to be stratified as different times of the day or different times of the week, as an acute foot line which operates 24/7, emergency heart foot attack kind of patients that come into emergencies, a wound healing clinic wherein advanced wound healing is done, a remission clinic wherein a healed patient but has significant neuropathy and deformity, the ulcer would have healed. So you need to look at the offloading measures and ongoing offloading measures, footwear strategies, remission clinic to keep them in the remission, and basic screening clinic or screening programs like it could be part of a diabetic clinic wherein all patients with diabetes be screened for their foot risk at least once in a year. Now, most of our diabetic patients, at least Tier 0, Tier 1, Tier 2, need a small foot care service, a room wherein, or a room and an equipped paramedic who can do the basic foot risk stratification. Only the strata 3 and strata 4 or the high risk ones need an actual MDFT, like the King's Hospital people told us how they work as an MDFT. So this is basically a risk stratification slide. I'll skip through. So any diabetic foot clinic giving service can be 3 models: minimalistic model, intermediate model, and tertiary care or center of excellence. The minimalistic model will have basic ability to do a foot examination, screen the risk stratify these patients, give basic treatments for cons, callosities, and routine foot care, preventive care with an emphasis in education and footwear advice. Basically manned by the surgeon, the diabetic foot specialist himself, or a diabetic foot physician for that matter, plus minus a podiatrist, which our country lacks largely. Basically, the minimalistic model would provide prevention and basic curative service. I will look at one small room which can have the equipment to test neuropathy, vasculopathy, which are relatively very cheap, and risk stratify these patients. It can be a part of the regular diabetology clinic. The basic equipments that you need are like we saw in the podiatry tray yesterday while we demonstrated the trays: basic tissue nippers, scalpels to remove the calluses, nail files, ability to put a slab or a contact cast, ability to do the neurological equipment, the neurological testing and vasculopathic by i.e. an ABI machine or a handheld Doppler. Now this is an example of a clinic. This is a picture from Amrita Hospital at Cochin, where we all trained as podiatric surgeons. You can see this room has been currently bifurcated. It's a bifid room where both patients cannot see each other, or they're ideally isolated. You can see the basic requirement of that clinic basically is you need to have a dressing trolley with the basic dressing equipment. You need to have a couple of cupboards wherein you can store your dressing materials. You need, this can act like the multiple bays that Wegin told us at the King's. They have 11 bays. So depending on your work, amount of work you do in your center, you can have between 2 bays to 8 bays or 10 bays. And this can be, the same space can be used because even neurological testing and ankle brachial index testing can happen in those bays itself. A contact cast or a slab can be happening in the same bay. A wound dressing can happen in the same bay. And a dressing trolley, storage space, a patient podiatric chair or a patient examination table. So everything that a diabetic foot patient needs can just be done in that small bay. Now this is the RK Center reception wherein you have 10 bays. You can see on the left-hand side there are 5 bays, on the right-hand side there are 5 bays. All that the patient needs can be done in those small bays. And what does that small bay in RK look like? A similar structure that we saw as in Amrita. You can see a podiatric chair, a stool, a low-lying stool, height adjustable stool which can help the podiatrist do the callus trim or the dressing change. Application, you have a small doctor's table and a computer to do the documentation and prescription work. You have a small cupboard. Additionally, if you want, you can still have a light source on the wall like that. A light source on the wall which can have a documentation, photography or documentation device, a bay there, and then a doctor's prescription table and documentation on the computer through EMR, a dressing trolley, and a wash basin. This is all that a basic diabetic foot bay or in a clinic needs. Based on our workflow, based on the size of our hospital, we can have multiple number of bays. Going on to the intermediate ones are probably part of hospital setups, small-sized, mid-sized hospital setups, wherein in addition to giving that preventive care and treatment and screening for these risk, you can also have treatment for all types of ulcers and infections. You have admissions, you have inpatient services, you have services to drain abscesses, or basically an operating room setup is what I would mean there. There you would probably definitely look at having a physician to take care of the medical issues, a surgeon or a podiatric surgeon and an orthopedic surgeon who deals with the infection and these ulcers. Aim at preventing and curative care of all types of inpatients with advanced assessment and diagnosis, wherein a mid-sized hospital, you will expect a radiology to do x-rays and a Doppler study, usually within the hospital setting, and you will need a central motivated coordinator to manage the whole service at all. Equipment, like I said, x-rays, tissue nippers, all the rest remain the same. Radiology services like Doppler x-ray, operating room to do your basic surgery, full set of podiatry instruments, lab facility to do microbiology, hematology, blood tests, etc. So moving on to tertiary, something like we saw above, plus a complete full foot MDFT, which has podiatric surgeons, which is orthopedic surgeons for deformity, vascular surgeons, intervention radiologists, all anesthetists, all visiting the center. And the center does active research, managing all kinds of patients, and also trains paramedicals and paramedicals at the at local level, state level, or national level. So here you have a complete MDFT. In addition to the intermediate model, you would look at CT scans, advanced MR scans, pressure studies like pedobarograms, in addition to what we saw, maybe advanced transcutaneous oxygen measurements, lasers that we talked of in the morning. This goes to the tertiary center. I would like any of the audience, if they want, can discuss up or ask a couple of questions, because we still have 1.5 minutes. Does Professor Ajay Kumar want to comment? Madam, there.
One addition. Srinivas, nice practical presentation. And one addition, we should have two streams, one infected stream and non-infected stream. That is very important in the era of multi-drug resistant bacteria, and the uninfected stream.
Preventive podiatric stream.
Yeah, preventive and minimalistic approach is enough. For the infected stream, you need all these dressings, everything.
Plus minus two things that I left out on mentioning is, you can have a cast room for putting contact casts and cast removals, a casting room. The other thing is a room where footwear can be measured, for measurements for footwear, and disposal of footwear can happen in a or P&O bay.
Just social points, maybe getting a clinic in a ground floor in a less traffic area with more assistive device like wheelchair, something like.
Perfect. Dr. Kakkar, you want to add? You have started a foot clinic, or you already have been running one. So any comments or additions?
Of any cross infection on.
Perfect.
Just a quick comment, sir. I just because of my interest and love for wounds and everything, I visited Dr. Keswan sir's hospital 3 years back, and I'm very proud, incredibly proud to say that for me it's like I visited Cleveland Clinic for my hernia and other work. It is like the Cleveland Clinic that exists for wound care. Every device that you could think of, MRI, specific MRI for foot, a special orthotic division, there is a full cath lab. So if you call it a tertiary rather than quaternary care that exists for diabetic foot, and any of you, I must say, it's incredibly proud to have such a center in India. And thank you, sir, for creating something like this. And I still remember it was full Chennai heat. I was staying at Grand Chola for a hernia conference. Took a Rapido bike, went through to that place. It's a long distance, 1 hour drive, and it is always imprinted in my mind. The quality of bandages, the quality of staff, it is incredible. So if you have not visited, do visit and see.
I think to add on, Dr. Bava, it is the passion that will drive you. It is the passion of the person running the unit or the chief coordinator of the center for giving that service that runs it. And depending on your equipment, your time, your number of patient load, you can devise any system between minimal to quaternary.
Even think of that. He has got those stands to have those diabetic feet in the air. So there are multiple stands available so that the patient could have their limb up. So which is incredible. It was missing in your presentation, sir. Thank you.
Thank you. And I would like to invite Dr. Kakkar to give the presentation on PHMB.
Thank you, Srinivas sir. And at the onset, I would like to thank Dr. Keswan sir and the entire organizing team for conducting such a wonderful conference every year and inviting me. Greetings from the holy city of Amritsar. So, my gratitude to my professor, Dr. Kalra, who taught me plastic surgery and the basics, how to manage wounds and all. So, the topic which we are going to discuss is role of PHMB in wound bioburden management and especially in biofilm management. So, friends, diabetic foot ulcer is just not a simple disease. Basically, if we don't manage it properly, it leads to complication, and complications are such devastating that we lose a limb. Once you lose a limb, the person is half done, and as my earlier speaker have told, most of these patients won't be there after 5 years because the mortality is so high. Once you have an amputation, the pressure shifted to other limb, and within a year or so, you get an ulcer in the other limb, and gradually so many comorbidities occurs, and the patient we lose usually within the 5 to 7 years. So we will be discussing about what is PHMB, the pharmacology, mechanism of action, some clinical evidence, and how we can use this in our routine clinical practice. So as my earlier speaker told, we are becoming the diabetic capital of the world. And there are studies that the incidence of a patient with diabetic having a diabetic foot ulcer is ranging from 15 to 34%. That means every third to fourth person who is having diabetes will end up in a diabetic foot ulcer. And what is more important is that 85% of the amputation which occurs in these patients proceeds with a small crack, small ulcer. So these all amputations are preventable if we pitch in early and manage at the stage when it is preventable. So next is, most of these wounds are either infected or colonized, and most of the organisms which occur in these are biofilm producing. So addressing the biofilm is a priority in these patients. And as ma'am has already told, that the incidence of losing a patient is much more in 5 years once the patient has a major amputation. So what is PHMB? It is polyhexamethylene biguanide. So this molecule is not new, friends. This has been there since 1940, and it was earlier used in the industries. But after repeated research and all, it has been found that at very low concentration, it is non-cytotoxic and is very effective against the biofilm. So this works at a stable pH from 4 to 10, and it is very compatible with moist wound healing. And till date, it is not, there are no papers or research regarding resistance to this molecule. So how it acts? PHMB is basically a positive cationic, and it is attracted towards the cell membrane, bacterial cell membrane, which is negatively charged, and it binds with that and also with the biofilm EPS matrix. So once it absorbs over the surface, it just penetrates into it and leads to the leakage of the cytoplasmic contents, leading to death of the cell. So not only this, it also binds with the DNA, penetrates the DNA and ruptures it so that it prevents the multiplication or replication of DNA also. Same as it attaches to the EPS matrix, it helps in deeper penetration of the normal medicine or normal antiseptic because it removes the biofilm and helps in wound bed preparation and early wound healing. One more important thing is the mammalian cell cholesterol, it has less affinity than bacterial cell. That is the reason why it is selectively more bactericidal than a normal tissue, less cytotoxic. So coming to the most of the common bacteria like staph, both methicillin positive and methicillin resistant, methicillin sensitive are sensitive to it. Along with that, most common Pseudomonas, Acinetobacter and the common fungi all are sensitive to PHMB. So when we compare with other common antiseptics, you can see it is effective both against gram-positive and gram-negative. More important is it is effective against biofilm, where most of the other comparable drugs like povidone, iodine, chlorhexidine and silver, they are relatively less effective. And it is low, cytotoxicity is less, and it doesn't impair the wound healing, which normally if we use povidone, iodine, it delays the epithelialization, which is not there in PHMB. So some clinical evidence is, in this study, it showed that when we compared with normal saline, there was the bio burden and the biofilm reduction was much more with the PHMB at 4 weeks when compared to normal saline or placebo. Another study also showed that there was less of pain, odor and exudate within 2 weeks of application of PHMB. This study, which was a comprehensive study around 40 studies, has concluded that PHMB is effective against 90% of the common pathogens, including MSRA, and no resistance has been reported since it is considered superior to common chlorhexidine and even iodine. So why PHMB is important is because we have to understand the biofilm, and as around 90%, 80-90% of these infected DIU, the bacteria are forming biofilm. So we need a drug which removes the biofilm or penetrates it and helps the wound healing, because it is the biofilm which inhibits the wound to heal, and it either the wound stays at the same or it leads to chronicity. So there is enough evidence that PHMB helps in removing the biofilm. So how we should use it? That it can be used as irrigation solution, the concentration of which we can use up to 0.1%, and the main point is the contact should be at least for 2 to 5 minutes for it to be effective. Other modalities, like we can use it as gel in deep wounds, and if we have a sinus cavities and all, we can use it as ribbon or gauze. If it is highly exudant, then we can use it as foam dressing. These are available. So how to start? First of all, we have to examine the wound. We have to document what is the size of the wound, what is the depth, what is the odor, and what is the character. If a wound is having biofilm, it will look dull and slippery. And once we know that the wound is having biofilm, then first thing is we have to debride. You can use any method, like Dr. Srinivas sir is using maggots, and otherwise we can use sharp debridement can be used, enzymes can be used, or even hydrosurgery system can be used. We have to debride it. Once you debride, the biofilm is going to reform within 48 to 72 hours. This is the time where PHMB will come into action. It will delay the formation of biofilm and helps in wound healing. Once you have debrided and applied it, then you can apply the dressings, especially foam dressings or gel, which can stay for 48 to 72 hours and doesn't let that biofilm to reoccur. Not to forget, every wound in diabetic, when it is neuropathic, we need to do proper offloading and other supportive cares like dressings, and if there is any venous ulcer or something, we have to do compression. That standard care has to be done in all patients to get a proper results. If the wound doesn't heal within a week or so, we have to reassess and think whether we are missing something, and if it is there, then we have to follow accordingly and do it. Friends, this PHMB is very safe when we use it properly as topical. It is effective in diabetic foot ulcers, in post-debridement wounds. When there is very large wound and if there are chances that it get absorbed, so we have to plan accordingly and use it with cautions. Especially there is, if the patient is pregnant or children's, we have to use when there other options are not there. And it has to be avoided in cavities, especially CNS, ear canal or intraocular, because it is meant for topical use only. So, as I told, in the World Union of Wound Healing Societies consensus, it was discussed that this helps in early recovery and all. So, practical tips are that the contact time should be at least 2 to 5 minutes, and we have to reassess biofilm every 4 weeks or even earlier if we are not getting the optimized result. We have to always debridement. Debridement has to be done, and as surgeons, any person who is dealing with diabetic foot, he has to know that debridement is the foundation. If we do proper, we make proper foundation, then only we can make a building or something. And depending on the wound, whether exudate is less more, we have to change accordingly. So sharing some cases which have been provided by MilSafe team. This patient of venous ulcer, so after cleaning, this PHMB solution was applied along with compression dressing, and you can see nice epithelialization within 2 weeks. Another case you can see, within 4 months, the large ulcer after proper debridement and dressing application reduced to more than 80% has been within 4 months without any other surgery. In this case, you can see after proper debridement and PHMB solution application, the size has reduced within 2 weeks. Another case where you can see within 8 weeks, there is good amount of epithelialization with this. And this is the last case. This 74-year-old gentleman with non-healing diabetic foot ulcer. So after proper debridement and amputation of the toes, gangrenous toes, and with dressings, you can see within 6 weeks, we got good granulation. So the key takeaway is that it is a very broad spectrum antiseptic with outstanding efficacy and good tissue compatibility. And there has been good studies now that it is effective against most of the common bacteria, gram-positive, gram-negative, and even fungal organisms. So what is important is we have to, still we have to use it and we have to make a proper protocol, and every step is important. As I told, we have to assess all the wounds, irrigate, use other modalities also to get a best what is for the patient.
Thank you very much, Dr. Kakkar, for a wonderful presentation. I just have one quick question. You used a concept of 2 to 5 minute contact time. So you have to, when you use the product, you need to soak gauze in with the solution and leave it on the wound, or you'll leave it on the wound and you'll pack it off.
No, sir. We have to put the gauze soaked solution and put it for 2 to 5 minutes, then remove it, and then you can plan what type of dressing you want to put, gel, or you want to put a cavity, you can put that ribbon and all.
I think I'll thank all my co-speakers, and quickly to summarize, we did the podiatric perspective and the physician perspective of an MD FTA King's Hospital London. We did photographing documenting events by Dr. Bava with a very, very clear message of making sure you take a consent for photography and documentation rightly. And we did the app-based development of a wound app, preventive wound care app. We went through minimal, intermediate, and tertiary level of setting up a few tips for setting up a diabetic foot clinic. And we did PHMB by Dr. Kakkar. Any doubts from the audience? Otherwise, we'll close this. Name some apps which can...
So Auxilium is coming up with a product. I use eCare. That gives you wound measurement, and there are more apps available if anybody knows more apps, but because I'm kind of bound to eCare since a very long time, eCare is the one.
Okay, thank you, sir. Now I request Dr. Ajay Kumar to felicitate the speakers. Dr. Arvind Bava. Ashwin Bava. Sorry, sir.
Okay.
To Biki Kumar Shah. And to Dr. Vikas Kakkar. Thank you, sir. Now we move to session 6, Advanced Wound Modalities, Part 2. Moderator Saravana Kumar, sir. I request Mr. Satyanarayanan, Dr. Ashwin Bava, and Kaushik Nadarajan, Dr. Kaushik Nadarajan, to come to the dais.
Oh, okay. Welcome.
Baba will present first.
Now I invite Dr. Ashwin Bava to speak on multispectral autofluorescence in point of care diabetic foot management. Over to you, sir.
Any audio, sir? No audio. Just me. This is the presentation. Come on.
So good afternoon, everyone. Once again, more of my passion and wounds and images. So I'll be speaking on, oops. I have to swap displays somehow. So again, the only disclosure that I have for this talk is I'm a general surgeon. Why do we need early prediction of infections, and why do these cameras are there? Why are there? We need to know about early interventions, amputation prevention. We need to know if effective interventions are working. For example, Dr. Kakkar said PHMB. How do you kind of evaluate if PHMB is working or not? Time, patient's time, and our time in terms of using a product. Resources are very, very important, and even the cost that the patient has to pay is important. There's a larger elephant in the room that needs to be addressed. This is antibiotic resistance. Do actually we need to give antibiotics based on a wound or not? So here comes a game changer in the AMR space, which is the Illuminate camera. This is the previous version, where you could see infection in the wound and decide whether the infection is gram positive and gram negative, and decide what intervention do you need to do. So the basic principle is you throw UV light over a wound, and once UV light is thrown over a wound, the cell membranes are rich in these metabolic markers like flavins, NADH, and these are captured by this UV light, and gram positive and gram negative bacteria react differently to this UV light, and the algorithm has been taught to read gram positive as red and gram negative as cyan, green. So this is the newer version of the device. So what current methods do we use for infection detection? One is visual inspection and clinical signs. We usually take swab cultures, and then we send our usual blood tests like CRPs and the WBC counts. And can AI see what we can't? So this is about the third eye, seeing the invisible real-time autofluorescence bacterial imaging. So we all know the usual clinical signs, the erythema, edema, patient fever, warmth of the limb, and other things. Bacteria are usually present in asymptomatic patients as well. A clean-looking wound may still have a bioburden of more than 10 to the power 4. No camera in the clinic, you usually image, see a wound, decide about taking cultures. 85% of wound peripheries with clinically significant bacteria are usually missed by conventional methods. So I told you about how autofluorescence imaging works. So red is usually gram positive, cyan is usually pseudomonas, green is connective tissue. So standard clinical signs will give you an efficacy of about 15 to 52%. These autofluorescence devices raise the bar to about 74 to 100%. So we can stop guessing and target the hotspots. You can use fluorescence to map bacterial hotspots in the wound bed and periphery and take directed cultures. If you can see it, you can remove it. Of course, I'm just giving you ideas for studies. If you have the camera, you have a dirty looking wound, then you immediately do debridement and see how it looks. You would know the bioburden going off. Then, of course, antibiotic stewardship. I'm guilty of sending, negative pressure wound therapy, VAC swabs, VAC sponges for culture. And, I was giving these patients a lot of antibiotics when they were undergoing negative pressure wound therapy. So once I started imaging the wounds, I realized these wounds are pretty relatively clean every time. I think I have serial images for you for that also. So I have stopped giving antibiotics while the patient is on negative pressure wound therapy unless clinically indicated. If you have a positive scan, you give targeted treatment. You have a positive sign, green color, you can give gram negative if needed. So I call it the third eye. Just like something which is not usually visible to the naked eye is just like Shiva's third eye, which can make you, give better results. So this is rapid and label-free infection detection, AI-based gram negative, gram positive classification. Gives you a good report to show to your patient. In fact, we are developing a screen which looks like a scan for patients to, find out what is happening with the wound. A large screen, it's a TV-size screen to kind of be a foot scan. Non-invasive wound dimension and analytics, as I told you. Good HIPAA compliance, DPDP compliance in the future. Real-time app updates. The team is very good in terms of updating it constantly. You have a dashboard that shows everything. And I'm incredibly proud to say they've got US FDA approval. So something coming out of India, getting US FDA approval is incredibly a great achievement. Some case scenarios, amputation prevention. VIP patient, very VIP patient, judge's brother-in-law with such a foot, was told about amputation elsewhere. So what we do best is debridement and negative pressure wound therapy. So this is the result. I was able to save the toe. But in the background, I was using the device. So you could see a little gram-negative infection. Gram-negative infection as I was serially tracking the wound. Gram-negative, gram-negative, gram-negative. But there was a speck of... I missed a photograph, but while I was assessing this wound, suddenly in between, somewhere here, there was a speck of red, osteomyelitis, which I would have otherwise missed. I curated the wound from that area. So it was able to I would have missed it otherwise. I was able to curate it, and finally the result was like this. One could use it for post-debridement monitoring, simple wound, gram-negative infection. See, there is no infection and the wound is relatively clean. Targeted antibiotic use. I think this patient had Pseudomonas infection, elderly lady, CLD, and I would avoid, and CKD as well. So I would rather avoid antibiotics. So able to track this wound and avoid antibiotics. Again, a very choice of intervention in sick patients. Very clean-looking wound, high risk, no antibiotics, CKD, and in fact, I didn't even want to do a graft for this patient. So serial tracking of all these ulcers is very much possible. Again, a little speck of gram-positive infection, done well. Young patient with a mixed infection. So I took 2 cultures from these gram-positive and gram-negative sites. So this had Acinetobacter as well as Staph aureus. You could serially track these wounds, and eventually it healed. Difficult cases, recurrent amputation required. We were tracking all through, and you could see, the illuminance go off. So bad case, another uncle of mine, Punjabis are very, very diabetics. Very, syndrome X is very, very common. So uncontrolled diabetic, had to amputate him. So applied VAC, eventually did skin grafting for him, and required good amount of cleaning, was not very compliant, but then you could do targeted cleaning, superficial wound with gram-negative infection, proper cleaning of this wound, you could see the signature go off. One could do targeted debridement for these wounds. Targeted negative pressure wound therapy. So you can see the photo signature go off as you applied negative pressure wound therapy. So one could see the invisible. It could guide you about debridement. And one could know about healing, and patients get really engaged when you use a lot of optics in your practice. So from subjective assessment, one can move into image-guided intervention. And I tell you, one thing is improving clinical outcome. The second is research. So I've not added that part to my presentation. We won an award in Australia recently where we introduced the concept of NPWT 2.0. Negative pressure wound therapies, otherwise, the wound is contracting. But with all these optics involved, if you add the digital part to negative pressure wound therapy, which is your sizing and bioburden reduction, you have a new concept of NPWT 2.0. Luckily, I've been able to image, this is the data from the previous device. I think so I've imaged about 9,000 patients free of cost. just because I wanted to be very sure of the technology. 5,408 unique images in 703 patients. 577 patients had multiple images, more than 3 images captured. 76.6 days average follow-up of patients. So most of these no-growth patients, about 75%, had 3x faster healing. So I'm just telling you in context that we were able to, time's up. So about...
Go ahead.
Thank you, sir. So most of our patients were gram-negative, had gram-negative infections, no growth in about 1,147 patients. So what it means at the bedside is we know about the bacterial signal. We can predict the trajectory. If you have more bioburden coming in, you know that the patient is getting infected. We have CRP, we have fever, the clinical signs, but this gives you an important prospect. But information beyond wound size is what we are, able to capture. So more serial wounds captured, you can see 15% reduction in bioburden. Last 3 slides are, again, 62% reduction in bioburden. Thank you so much.
Thank you, Ashwin Baba. More techie you are. We try to learn from you.
Sir,
I have taken all the slides, these photos.
Sir, I'm happy to share all of this because the world is very rapidly changing. That's why I deliberately added that hernia.institute website. The entire website, coding, from cost estimator has been done by myself. If I can do it, anybody with an idea can do coding right now. Thank you.
Thank you very much. Now I call upon the second speaker, Mr. Satya Narayanan. He's going to speak on AI-driven early diabetic neuropathy, diabetic foot ulcer risk detection, and personalized rehabilitation.
A very good afternoon, everyone. I'm Satya Narayanan, the founder and chief executive officer of Be Early Tech Innovations. We are a medical technology and artificial intelligence-based company. Our vision has always been to enable clinicians and therapists to diagnose long-term gait and foot function disorders at the earliest of stages, enable longitudinal tracking of these conditions, and provide personalized interventions to improve the same for foot and gait disorders. We do this by integrating artificial intelligence with kinetic, kinematic, and spatiotemporal data. Because AI needs data and feeds on it, the importance of data that comes from foot and ankle is quite high. We are a team of engineers, doctors, and researchers that are here to create an impact for improving the patient outcomes for people living with mobility disorders. There is nothing better than a clinician's visual observations and a patient's own feedback. But as it is very difficult for us to objectively analyze the gait and foot function issues in a patient, it becomes a bit more difficult for us to track it. So the use of these foot function equipment, like a mat-based analyzer, walkways, and insole-based systems have been quite common across the globe. And most of the systems have always been imported from US or Europe. But there are quite a few limitations with these systems. One is the fact that the mat scanners can only analyze the static pressure, or even if it's dynamic, only one side of the foot can be analyzed, which is left or right. The walkways can measure up to a few steps, but cannot measure the turns. The in-shoe-based insole systems are always available, but the difficulty is that it's quite commonly used in sports biomechanics, but applying it on a patient with foot complications is quite difficult. To break out of these limitations and to observe the natural walking pattern of patients, we have built PaceB. PaceB is an AI-based biomechanical intelligence platform which comprises a wearable device and an AI platform. The wearable device comprises a few pressure sensors from toe to heel, which covers the complete area and region, and an accelerometer and a gyroscope that analyzes the ankle movement in 3 dimensions. The data will be captured and transferred to our software platform, which is integrated with AI. The experience of patients wearing this device is that they feel like wearing a comfortable footwear and walking, and they express their natural walking patterns, which is exactly what we need, and we obtain the best data that is possible for us to feed to the AI models. Our AI would ingest all this data and provide personalized inferences for doctors and therapists to understand the DPN and DFU risk assessment for neurological conditions, musculoskeletal, CNS, and PNS issues, involvement, likelihood. Based on the demographic factors, the AI also helps the doctor understand the abnormalities, the asymmetries, and deviations that have been caused. To close the loop, the important aspect of improving the patient's gait and foot or the ankle mobility here is to provide the best physiotherapy suggestions that's personalized to the patient's abnormalities. So that's something we provide too. When the first gait recording is done, we set the baseline, and for every subsequent analysis that is done, the requirement for a manual download or a digital analysis and a manual comparison of reports is not required. Our AI would automatically compare the patient's foot before and after treatment and would point out the areas of improvement and deteriorations for the treating clinician. Our early focus has been in handling neurological conditions like movement disorders and stroke. So we performed a study at NIMHANS in Bangalore for 120 subjects. This included 60 healthy controls, 30 Parkinson's disease, and 30 stroke patients. The outcome of the study was more focused on understanding how pertinent the data that comes from our product is benchmarked against an existing gold standard gait analysis equipment. The study came out well, and we have submitted the same to Disability and Rehabilitation Journal, and the peer review work is in progress. The vision has always been not to build something for a specific region, but to build a technology from India and make it accessible to patients living with gait and foot function disorders across the globe. With this vision, we launched PACE-B in the United States of America, facilitated by Oregon Health and Science University. This happened in last October. The feedback from both NIMHANS and Oregon Health and Science Universities have clearly validated the value proposition of the product and how it impacts patients with foot and gait disorders across the globe. This is a snapshot of the report that's generated in the clinician's end. On the left-hand side, you can actually see the foot pressure distribution across different regions of the foot. This is the foot pressure distribution of a patient that lives with obesity and which has caused him an increased arch pressure, and due to compensatory factors, the graded toe pressure is also increased. Our AI would automatically analyze the patient's foot pressure, highlight the pressure, contact time, and impulse across different parts of the foot, provide the analysis on the midfoot transition point, which is the phase of stance at which the pressure transitions from the hind foot to the forefoot, which is very important for us to analyze because you can see that the foot has landed flat on the ground, that the midfoot transition point cannot be found here in this graph. This was a patient with flat foot. Yeah. So you can actually see in the report summary the side of gait that has more abnormalities, how symmetrical is weight bearing, and the reasons why these abnormalities have been caused. The demographic-based root causes, DP and DFU risk stratification, and personalized physiotherapy suggestions are provided. This is the part where the parameters that have deteriorated and the parameters that have improved can be found with a clear overall and segment-by-segment summary. The AI highlights the positive changes in the patient's foot and ankle dynamics, the concerning changes, and the modified physiotherapy suggestion after the treatment has been given and after a follow-up analysis is performed. As you can see, the foot pressure of left side of gait before and after treatment has been presented over there on the right side, on the left side. We have shot a quick video of how PACE-B actually works, and this was done in NIMHANS. Is the audio not plugged in? This one, sir.
We often ignore these signs as a part of aging until it's too late. Over 400 million people worldwide live with gait disorders caused by neurological, musculoskeletal, and diabetic conditions. 50 million are in India alone. Yet early screening and continuous tracking remain a challenge. Traditional gait assessment relies heavily on visual observation and patient feedback, making it subjective, non-trackable, and time-consuming. In the early stages, different disorders often produce similar gait patterns, leading to misdiagnosis and delayed care. This is where PACE-B by Be Early Technovations changes the game. A foot-wearable, AI-powered gait analysis system delivering clinical-grade, real-time, objective data with personalised insights for doctors and patients. At Nimhans, PACE-B has been clinically validated across 120 subjects, including healthy individuals, stroke survivors, and Parkinson's patients, showing high correlation with gold standard gait analysis systems, while significantly improving usability and patient cooperation. From early screening to faster recovery, Be Early Technovations empowers clinicians with PACE-B to improve patient outcomes in gait disorders.
So the use cases of PACE-B extends from diabetic peripheral neuropathy and diabetic foot ulcer, Charcot foot, plantar fasciitis, and a lot of other foot deformities and ankle disorders. The applicability of PACE-B is not just in foot function disorders, but in a lot of movement disorders, neurological conditions, and orthopedic cases, which I have not highlighted here in this. So we are supported by the Department of Science and Technology and Shastra University's Technology Business Incubator Ableist, for the research and study that we have performed. And would love to thank Dr. RK, for the great opportunity that's given to us to present our product here in the conference. And he has been one of our core users right from the beginning. So we're at stall 3, and we would love to show you a live demonstration of how PACE-B works. Thanks very much. Thank you.
Thank you very much, Satya. Good lecture. Now I call upon the third speaker, Dr. Kaushik, podiatric surgeon, to talk on artificial dermal replacement therapy in hard-to-heal wounds.
Very grateful to all of you. At the outset, I would like to thank the organizers, Dr. RK sir, and the Maritime Company for giving me this opportunity to speak on the artificial dermal replacement therapy for hard-to-heal wounds. So what does the artificial dermal replacement therapy mean? It is basically a dermal filler, which is a biomaterial which acts as a scaffold in which the host cells are colonized and get replaced by the biological cells in form of to form a regenerated dermal tissue, which is called as a controlled degradation and remodeling. Why this is important? Because we know that the wound healing happens in 4 stages: the hemostasis, inflammation, proliferation, and regeneration. So the hemostasis is which happens immediately after injury, where the blood clot forms, which is basically made by RBCs and the platelets, which takes place between the time of injury to about a few hours. And next stage is where the inflammation stage starts. It's from few hours to goes to 3 days, when the inflammatory cells come in and attack the fibroblasts and the macrophages, which can lay in the tissues responsible for the fibrogenesis and the angiogenesis. During this phase, you have the next is the proliferation, which takes from 3 days to 3 weeks, during which time the collagen produced will be of type 3, which is more flexible, pliable, on which the tissues, the anti-inflammatory macrophages and keratinoids get set in and start forming the tissues. So by the influx of fibrogenesis and angiogenesis occurs. And finally, the remodeling, where you have the type 1 collagen, which is more stiffer and thereby helps in protecting the wound from any kind of a further injury, and the myofibroblast, which helps in wound contraction and thereby reducing the size of the wound. So if this stage is being prolonged or repeatedly halted by repeated injuries or infection, then the desired result of wound healing will not be attained, and you have a chronic wound in the form of either delayed healing or non-healing wound. So this is the place where the dermal filler, the biomatrix, has its function in form of it forms a scaffold that allowing the promotion of new tissue ingrowth in the form of fibroblasts and blood vessels. It also has gives a good wound healing with a good pliability. Thereby, tissues are more soft, and thereby the tissues can be more elastic. So, further shear forces can be resisted, and thereby wound breakage is avoided. And finally, control of scarring, because it gives a good granulation, thereby the keratinocytes can sit in, and a small wound it gets healed completely, or large wounds go for skin grafting, therefore the scarring can be avoided. So where do you place this biomatrix or the biology scaffold in the reconstruction ladder? We just place just above the level of the skin graft, or just before the level of where we have the complex flaps which are required for the wound cover to be done. So we have like many things in market, like many materials like Integra, Mataderm, Novazab, and Demosil in the markets. So we'll see a few things in the theoretical aspect. Integra is a dermal reversion therapy, which usually is a bilayer, which has a collagen, acetyl-collagen and glycosaminoglycan layer, which is adherent to the wound, and a silicone layer at the top. It requires two-step procedure, because after the application, we need to leave it for about 2 to 3 weeks for the fibroangiogenesis to occur, and then after the 3rd week, can remove the silicone layer and go for grafting. So the problem is it takes a longer time for the assessment and thereby a final wound closure. And therefore, the cross-linking here has a difficulty, because the cross-linking has impairment in the degradation of collagen, thereby the formation of a collagen type 1 will be much delayed. And second is the Mataderm, which is a bovine origin, which is like bovine dermis type 1, 3, and 5, with the advantage of elastin in this material, which helps in providing more elasticity when the wound started granulating. So the advantage of this kind of a Mataderm is it is available in many sizes, like 1 mm, 2 mm, 3 mm thickness. So you can use a single step procedure in case of grafting, particularly over the joints where the standard skin graft may have a joint stiffness because of its adherence to the wound. So this Mataderm can be applied over the granulous tissue and go for a single step skin grafting. Or in case when you have a big tissue defect, this can be stacked in multiple layers for the granulation to come and have an adequate filling of the tissue defect, and that we can go for a wound closure in the future setting. Next one is like a Novazab. It's a biosynthetic material made of resorbable polyurethane material. The problem with this material is that it is totally synthetic, which has a lot of spaces for the tissue to grow in, and as I told, it's a synthetic material. The inflammation triggered is very high, thereby the scarring is not acceptable, and it is also take a long time for the wound to heal. So a microscopic comparison of the 3 material with the human dermis shows that the property of the material in comparison to the human dermis, the similarity is more with the Mataderm, followed by Integra, as you can see that ultra microscope pictures, and least with that biosynthetic material, which is the Novazab. And finally, you have the dermosil material, which is a human acellular dermal matrix, allogenic type of material, where they decellularize the human dermis and by a matricial process, which removes the donor DNA. But the thing is that it's like the availability is less, and the possibility of allergic reaction or probably transmission of virus can happen because of its allogenic nature. So what do we have in the future of the dermal fillers? Now we have the other thing like microspindles, nanofibers, hydrogels with or growth factors impregnated, which can use to seal the wound, and thereby the influx of the angio and fibroangiosis will be much better. So this is the future perspective, which we'll see how it in future comes. So going to a few next will be like few clinical presentations with this dermal filler, predominantly my side with the Mataderm. How it helps in wound healing and how it can be very well utilized in the wound setting. So this is a case of a 70-year-old man who had a peripheral vascular disease, had an angioplasty done elsewhere, and probably the second, fourth were removed there, and after nearly about 1 to 1.5 months of time, the wound was not healing, and he was referred to us because they were planning to go for a complete midfoot amputation, high midfoot amputation, and the patient not willing, so came over here. And we had found that he had like one more kind of a block in the posttibial artery, which is calcified. So that when our intervention cardiologist was highly patient enough to remove the block with the drilling, and that way he re-established the flow of the posttibial artery. Then we went ahead with the removal of the first, third, and fifth toe, and the dried out fifth metatarsal also, which created a big defect here and defect in the plantar aspect of the foot. And this patient was an active political worker, so he won't have like a very stable foot for him to walk in the future. So to reduce the defect, we just stacked the defect with multiple layers, 2 to 3 layers of 2 mm Matiderm and covered with nitrobus therapy. And this is the amount of granulation we got in about 3 weeks, 2 weeks time, from the dates here. In 2 weeks time, and be able to go ahead with the grafting and get like near normal bulky tissue in the plantar aspect for him to walk more comfortably with a molded footwear. Now he's better walking, only about 1.5 years since the surgery has been done without much of a recurrence. Next is a frail patient who had a calcaneal fracture. For him, a screw fixation was done, and he got a decubitus ulcer with a scab in the post-op period, and he had like minimal ooze happening in the area. So to prevent any kind of new infection in that decubitus scab with a possible hardware inside, we were forced to remove the scab and debride the wound. And since the wound was clean externally, we had that hardware exposed. So we covered the hardware with a 1 millimeter of this DRT and went for a primary grafting. And this is the same patient, 2 years post follow-up. The graft is still in place, no further exaggeration of ulcer, and the hardware is totally covered and is comfortable walking without much of a difficulty. Next is the patient, an 80-year-old patient, thankfully with the preserved vascularity, had like a fifth row gangrene, very indolent in the external aspect. So when we opened it, we found the infection stacking up to the mid-plantar region and other toes. So we debrided extensively and removed all the infected material. And finally, what we got is a big defect with the tendons exposed, and even the metatarsal metatarsal head of the other three toes without a soft tissue coverage. So once he was like elderly and not willing to go for any kind of complex procedures, he wanted to go for a much more like conservative procedures. We went ahead with stacking all the tendons with the DRT, the dermal replacement therapy, Matiderm area. And in about 3 weeks time post the implantation, we found got a good granulation and is due for a grafting. That way this complex process is avoided, and patient is, because of age and all the factors, this can be done in a more easier way, and the patient can have a good tissue bulk in the plantar aspect, which are covered over the tendons, so that the future chance of ulcerations and can minimize, and the mobilization can be almost normal with a customized footwear. This is a case where we have like a necrotation patient is extending from the foot to the leg, which is completely debrided, and here you can see that due to the nature of the infection, the debridement, here got all is like medial ankle ligaments and the periosteum of the tibia got exposed. So in a normal setting, a granulation is difficult to achieve. If the granulation occurs, it's over the ligaments will be difficult, and in the meantime, the periosteum of the tibia can also go for dryness. So to prevent those kind of complications, we went ahead with DRT therapy and placed over the periosteum of the tibia and over the ankle region, covering the ligaments also. So helping in adequate granulation, and because of this material, it can maintain the elasticity, so the flexibility of the ankle can be preserved, and that way walking can be normal. This one up 3 weeks post DRT with vacuum therapy had a good granulation. So we went ahead with a complete grafting of the wound, and this is the wound after 1.5 months since the initial debridement, where you can see the wound got completely healed with a good plantigrade stability of the foot, which can be little compromised in direct grafting by the stiffness of ankle may prevent the movement. This is one of the last one where you can find that partly what I call as a half-hearted debrider wound in Elsewhere Hospital, and since the wound was not healing to the expectation, they advised an amputation. So the patient came to us, and we found that the infection wasn't completely clear, so we went ahead with the complete debridement of the plantar, the tendinous and the lateral aspect of the foot wound, we can see even the lateral part of the ligaments are exposed. So we debrided, a complete debridement causes the exposure of the calcaneal periosteum and the lateral ligaments of the ankle. So to aid in wound healing, and he was like thin and frail, not possible for a complex reconstruction. To cover the tibialis tendocles region and the calcaneal periosteum, we did a multiple piece of macadam because it was not affordable for a complete large size macadam, like A4 size macadam material. We went ahead with other size and made multiple small implants of the material over the tendocles region and over the calcaneal periosteum also. And we went ahead with back therapy. Post 3 weeks post therapy, we found they had a good granulation, which very well amicable for grafting. A small tendocles in the raw area, which can be even shaved off and have a grafting directly done over a small piece of macadam, which will help in wound healing in a more better way. So this advantage of using a dermal filler means, like in case of it's a viable tool, and in case of elderly patients, frail patients, who had a peripheral vascular disease, where you can't go for any kind of a complex flap procedures, this can be used. And you can have a better wound healing with more kind of a tissue pliability and elasticity. So the mobilization can be in a more near normal way with as usually the customized footwear to prevent any kind of future ulcerations.
Thank you, Kaushik.
Thank you.
We are lucky to have more patients who are affordable for this kind of treatments.
Hopefully the material should be much more cheaper.
Thank you very much.
Thank you, sir. Now I request Dr. Saravana Kumar to felicitate the speakers. Dr. Kaushik, Mr. Satyanarayan. Thank you. Now we move on to the next session. When things go wrong, managing complications. I request the moderators, Dr. Rajesh Keshavan, Dr. Venkata Gopalakrishnan, to come to the dais. The speakers of this session are Dr. Madhu Periyasamy, Dr. Srinivas, Dr. Rajasabhabadi, Dr. Nellayappar, Dr. Rajesh Kannaya. Rajasabhabadi, sir.
Good evening, all of you. We are going into the next session. When things go wrong, how do you manage the diabetic foot complications? Because again, all of us, most of us surgeons and even physicians, 90% of the time the things go right, but again, still a small part, we still have to face problems. So how to look for the problems, how to manage problems in case we get into it. So the first talk is by Dr. Madhu Periyasamy. So he's not able to join us in person, so he's going to come on Zoom. Are we ready? Arvind? Arvind, do you want me to start the next lecture or? This topic is going to be a difficult topic even for the people who are going to lecture on this. So I'm trying to look at it at three different perspectives. One, Professor Rajasabhavati usually looks from the top-down approach. So he has a phenomenal way of looking at things, making difficult things simple. Madhu has a more practical way of dealing with these things. And Srinivas manages everything. So that is how things are going to go in. I think Dr. Madhu, there are some technical difficulties. I will now request Dr. Srinivas to give his lecture. He is going to talk on the mistakes in diabetic foot surgery.
Thank you for the invitation for the third Chennai conference, and this is my last lecture in this conference. I'd like to thank Dr. Rajesh and the entire RK family for giving us wonderful scientific feast and great hospitality over the last 1.5 days to continue tomorrow as well. Can I have the slide on, please? So this talk is basically a hodgepodge of all that we have been listening to in the workshops yesterday, today from morning till the noon. So this talk is basically designed, it's a very, very basic talk, 10 minutes given, 10 mistakes, and how to get away with it. And I stand humbled to between a great guru and a great Sishya to do this talk. So mistakes in diabetic foot surgery. To achieve limb salvage, I think we need to look at good, strong MD, multidisciplinary foot teams, good surgical techniques, and coupling adequate technologies to achieve the limb salvage. Probably why a lot of times diabetic foot surgery fail is, as different surgical specialists, i.e. podiatric surgeons, vascular surgeons, plastic surgeons, orthopedic surgeons, we look at that diabetic foot in different angles. And probably unless we club up together as one team, we wouldn't achieve adequate limb salvage. So diabetic foot surgeries fail because of multiple reasons: patient factors, surgeon factors, system factors, and knowledge gaps. And unless you give the 6 basic tenets needed for every diabetic foot patient, achieving a wound healing and keeping the wound healed is difficult, i.e. the 6 tenets, which is mechanical control or offloading, vascular control, making enough blood supply is there, taking care of the wound, taking care of the infection in the wound or microbiological control, metabolic control, and educational control, which is very, very, very important because the patient is insensate most of the time. They are at a very high risk after the first ulcer, heals also, they're at a very high risk for a recurrent ulcer. So we need to look at these all 6 basic tenets. So mistake 1, poor knowledge of surgical anatomy. I think for the young surgeon, particularly the ones who deal with most of the foot emergencies or foot attacks, infected feet, we need to have an adequate understanding of the plantar compartmental anatomy, facial planes of the foot, neurovascular structures and their positions, tendon anatomy, and as my professor Ajay Kumar keeps saying, tendon is the enemy of the diabetic foot surgeon. Again, missed compartmental anatomy can cause persistent infection or a subacute presentation again. Importance of complete exploration is needed. A simple ulcer that looks like that, as it spreads across, you give months of dressing together, nobody takes care of the offloading, nobody bothers about, because these patients many a time have hard plantar skin, have callosities, very difficult to recognize a underlying infection because overt clinical symptoms of infection may not be there. The one common thing that all of us miss generally is, there are transverse lymphatics which run along the transverse metatarsal ligaments, and if you have a toe, say a gangrene of second toe, and you miss out draining that lymphatics and the fat, subacute fat around that, you may leave behind nidus which can spread to the adjacent toes. Dorsal, central, medial, lateral plantar compartment, and the central plantar compartment is superficial and deep to the plantar fascia. Many a time, looking at just a gangrenous toe and leaving the plantar abscess undrained or the entire plantar space being not being deroofed can lead to adjacent, what Professor Bal teaches us as the iceberg phenomena. Courtesy of Professor Raj Sabapati, patient, again, this is exactly what I said, you miss your anatomy. 2 toes amputated, debrided, the tendon was not, the FHL was not traced. Patient comes back a couple of months later, a couple of weeks later with the central plantar because the FHL was carrying the infection upwards. So excision, tracking the tendon till its healthy margin, excising the infected tendon is very, very important. You need to know that dorsal infections spread across that way, plantar infections particularly spread along the flexor tendons of the flexor plantar tendons under the flexor retinacular, up ascending into the ankle and the leg. Lateral compartment infections are carried through the peroneals. Mistake number 2, many a time, the minute we see infection, we tend to under-evaluate the vascularity. Unless you evaluate the vascularity, you have, and the basic vascular evaluation is nothing but clinical palpation of the pulses, measuring toe pressures and ankle brachial pressures. You can go ahead when the patient has low pressures. So in an ischemic foot, a second toe gangrene of toe, part of the toe fell off, missed plantar abscess. Again, vascularity not assessed. Somebody did a transmetatarsal amputation to arrest the infection without knowing the vascularity. This patient actually, when the angiogram was done, no infrapopliteal vessels were there. It should have been a primary below-knee amputation instead of a transmetatarsal amputation. A typical presentation, a septic patient to the emergency room in the middle of the night. You drain, give a small drain to get rid of the putrid smell and etc. You do a secondary amputation today. And on day 3, you'll find that adjacent toes are gangrenous. The reason there, we didn't bother doing a vascular evaluation. So then get an angiogram, stabilize your patient, hydrate your patient, get a vascular consult or get an vascular workup done, get the tibiofemoral bypass, and then give a final answer, which is biomechanically viable. A lady who went around pillar to post from hospital to hospital, clinician to clinician, without finding an answer for healing of this heel wound. Here, the pulses were not palpable, and she had a calcaneal osteo, as you can see there. A vascular consult was done, angiogram done, required bypass done, partial calcanectomy done, antibiotic bead placed, and the wound would heal. Partial calcanectomy, antibiotic beads, and complete wound closure. You can see the beads and complete wound closure. It's very, very important that you establish a vascular algorithm. The only place where you wouldn't consider revascularization first is an actively septic, fetid foot which comes in the middle of the night. There you would want to just drain the abscess, give a limited source control, hydrate the patient, get your kidney status back to normal, then do the angiogram and the needful. Inadequate surgical technique, like we said, and inadequate incision planning can lead to problems. So you need to look at tension-free closure if you're looking at closure of stumps, respect angiosome concept, preserve all the viable tissue. Ignoring biomechanics. A lot of times diabetes causes changes in the gastric soleus or the tendo-Achilles complex. Pressure redistribution or offloading needs to be considered. It's very, very important to preserve the first ray as much as you can in the diabetic foot, and you need to consider bony deformity as well. Professor Narayan Murthy courtesy, again a nice bilobe flap rotation advancement was done, wound completely healed, but the inciting pressure was not addressed. And this, once a patient starts walking, the patient comes back with a recurrence. Courtesy Rajesh Keshavan, a midfoot Charcot patient who had a skin graft done, a midfoot exostosis very clearly seen on the X-ray. Had you done a midfoot, once you do a exostectomy, you wouldn't actually need a graft also to close that patient. Biomechanical failure is the most common cause of recurrent ulcers. So inadequate debridement we talked of in the first one. So Professor Bal says all that you need in an acute diabetic foot is a good pair of sensible hands and eyes and a mind to know what you're doing. So this patient presented with a third toe gangrene, like I said, you have to entirely deroof that central plantar space in addition to the toe amputation, track the tendon of the third toe, flexor tendon of third toe till its healthy margin is arrived. Many a time, like in this case, as you could see, it progresses under the flexor retinaculum. You need to lay open the entire flexor tunnel to get rid of the infection and get the wound to heal. This video again courtesy Professor Ajay Kumar. A lot of these talks are all, that's what I said, we've been hearing about this from morning all, and you can see the gangrenous toe being excised, the flexor tendon now being tracked. You can see that the infection has spread beyond the flexor retinacula. You can see Professor Ajay opening up the flexor retinacula and laying open and excising the flexor tendon of the third toe. Failure to address the tendon spread, or again failing your anatomy and failure to inadequate debridement can lead to timing, alignment, and superconstruct principles are crucial to diabetic Charcot foot management. A patient who had a surgery for a Charcot deformity which was temporarily fixed, like you would treat a fracture, and the Charcot process goes on till the patient presents with the next ulcer to us. At this point of time, the patient presented to us. And what the patient ideally needs would have been a modern fixation of internal, long segment, internal rigid fixation in a superconstruct like a beam. So extended fixation, treat Charcot with a long segment fixation. The entire medial and the lateral column need to be addressed. Many a time the subtalar also in case of midfoot Charcot. Strong constructs like beams, long-term offloading. We generally offload them in a plantar slab for about 10 days or 14 days till the post-op edema comes and the sutures, skin and the sutures settle down. And then you put them on total contact cast till at least 70% bony healing, which takes roughly around 12 weeks. Failure to know about and use or couple advanced technologies like negative pressure, skin substitutes, the Ricosma, regenerative laser, erbium YAG laser, biologics, digital monitoring of the patient like we heard Ashwin Baba in the previous lecture. How do you decide when to advance your therapy? You give adequate wound care. A good wound care or a standard of care you can see on the left-hand side, which is a thorough assessment, debriding non-viable tissue, creating a warm, moist environment to the wound, appropriate enough for it to take it to epithelize fast, heal fast, offload them adequately, and the topical wound care. If in 4 weeks' time, we did this here at least 3-4 times in the morning, if in 4 weeks' time your wound does not shrink to 40 to 50% of its original size, you know you're missing something. Reassess your patient if you're missing out of any of those 6 tenets that we talked of: infection, pressure, vascularity, diabetic control. All the 6 tenets should be addressed. If your wound does not progress to less than half the size in 4 weeks, you need to advance your therapies into the right-hand column, which you see. So good surgery plus wound technology, or coupling them, basically gives better limb salvage outcomes. Missing hidden pathologies. If you have an unshaken wound which lies there, in spite of giving good standard of care, you are stuck. You should think about unusual pathologies like that. What was thought as a post-traumatic subungual hematoma looked like that, stayed like that, did not change at all, turned out to be studded with eosinophil-laden cells on the histopathology, turned out to be a melanotic melanoma. This patient was treated as a venous stasis and eczematoid dermatitis, turned out on biopsy to be lividovasculitis. So biopsy your cultures and culture your biopsy is a one-liner for that. And neoplasms often don't present with the classical rolled out edges, etc., till it's late in the disease progression. When to biopsy these? Any atypical wound or non-healing wound that does not progress to healing within standard expected time of 3 to 6 weeks, you should. Poor antibiotics stewardship, not able to escalate or de-escalate antibiotics, not able to give culture-guided therapy, and avoid prolonged empirical treatment. Very important thing to realize that bacteria will be present in all wounds. It is where do you use systemic antibiotics, where do you give local topical antibiotics, where do you use silver-based dressings. So here, from the point of critical colonization, that is this line, to the right on you give systemic antibiotics. From the point of critical colonization to the left on you give topical antibiotics. And for the contamination, just use wound cleansing and no topical antibiotic. Not able to institute biofilm-based wound care, as we heard Vikas, etc., speak on a few products. Not able to switch to AI-based systems or point of care systems, which can give you measurements and wound progress in terms of reduction in wound volume, in terms of fluorescence detecting bacteria at the bedside, outpatient, not able to use local antibiotic delivery systems like Cerament or Stimulant to give high dosage so that you can reduce systemic requirement for antibiotic and you can reduce the incidence of antimicrobial resistance. So this patient is a Charcot midfoot ulcer patient, severe osteomyelitis, septic arthritis with subtalar joint was found, subtalar joint prepared, stimulant beads placed, temporary fixation as a stage 1 recon there. After a couple of weeks, after 6 to 8 weeks, once the infection and the CRPs and the ESR, the inflammatory markers come down, stage 2 recon of the midfoot and complete fixation to achieve wound healing. Failure to keep up with the advances in surgical techniques like MIS surgeries, regenerative medicine, AI-assisted devices. 4D bioprinting came and probably it's not there now. Basically, 4D bioprinting is AI-based device, makes a volumetric bioplug which becomes in the exact volume of the wound, placed in the wound, no secondary dressings or no secondary treatment needed. The world is looking at how to prevent the ulcer at the first stage, smarter technologies to pick up the warmth and the pressure changes almost 37 to 40 days prior to the skin break. Smart mats, smart shoes, smart socks. So the modern diabetic foot surgeon should be a good surgeon equipped with the adequate training, and should be an infection expert, should be a biomechanist, and should be a wound healer, all in one. And we need to look at keeping those wounds healed for a long period of time. Thank you very much for a patient listening. And I would like to thank, last slide please. I'd like to thank RK to have traveled with me for a long journey. I don't know if all of you saw that. The last slide please. There you go. Long journey from 2019, probably, maybe prior to 2019 only. Thank you very much, RK, for making me part of the RK family.
Thank you. Next lecture, Management of Complication by Dr. Madhu Periyasamy.
I hope I'm audible.
You are audible, Madhu. You can proceed.
Yeah, so thank you, sir. Good afternoon, everybody. And I'm extremely sorry I was not able to come in person. We had a small family emergency, but God has been kind and things are getting better now. So I'm here with you on video. So the topic today is managing complications in the diabetic foot. I'm sure Rajesh sir should have had something in mind when he gave me this topic. So because we've always been speaking about good outcomes and how to do good surgery and things like that. So maybe he thought, boy, it's time you showed us how to manage the complications that you have. Not everything always goes well. Even if you can do the best of surgeries, you always know that the patient may not be cooperative enough for you to handle the complications well. So the initial slide would be about, I'll just try to define a complication. A complication is an unwanted event, secondary to a disease or treatment, and not an inherent part of the original plan. Whereas a sequelae is a part of the original disease. So we must be able to clearly differentiate between a complication and a sequelae, because that is where often patients get confused and start thinking that every long-term sequelae is a complication and you're left defending yourself. So I think we must take care to explain to patients about the expected sequelae and the unexpected complications. So complications
Madhu,
are
just,
not only...
Madhu, just a minute. I think they have some difficulty getting your video on, your presentation on. Just hold on for a minute. We can see you, not your presentation. So we can hear you also very well. Just a second. They are trying to address that.
Shall I try to share again, sir?
I think you come out and reshare the screen. Yeah, you can reshare the screen. Yeah.
Yeah, I'm just doing that, sir. Is that visible, sir?
Only you are visible, man.
Okay, I'll just do one thing. Is that visible, sir?
Yeah, your slides are visible. You are also visible. Yeah.
Yeah. Okay.
You can proceed with the presentation, Madhu. Huh?
Yes. So comorbidity is a pre-existing problem. And I'll just skip a slide, I think. Yeah, so as I said, complications can occur not only in the intraoperative period, it can also come in the preoperative period. And also after you operate on the surgeon, after the surgeon operates, for the patient on the immediate post-operative ward or in the wards. So and often we see a patient with multiple comorbidities. And nearly 80 to 90%, I'm sure all of our patients might have one of the other of the problems that you are seeing on the screen. And the answer to this is to optimize the patient preoperatively. That is the best answer to a patient with multiple comorbidities who may have ischemic heart disease, renal failure, and other problems. So it's always better. How do we address this problem? Particularly a soloist, it's better not to try to juggle too many roles at once. Try not to become the diabetologist yourself. So always try to involve other specialists so that you have a good list of medicines that the patient is taking. They have adequate knowledge of all of the medicines that are taking. Each specialist will often look at the patient separately, and you may get the best outcome that is possible in that current patient. So one of the most important drugs that we often meet is the antiplatelets. Nearly every other patient who walks into the diabetic foot clinic is on both statins and antiplatelet drugs. And of these antiplatelets, aspirin is okay. But when you get a patient with clopidogrel or ticagrelor, we often prefer to stop these antiplatelets for at least 4 to 5 days. But then you must always balance the risk of thrombosis versus the risk of bleeding. So if the patient has undergone a recent angioplasty with or without stenting, then it's always better to continue the patient on antiplatelet drugs. And if you're planning to stop it, if you think the risk of bleeding is excessive, then maybe you can shift them to heparin or low molecular weight heparin, stop it during the intraoperative period, and restart it immediately. Some patients who have no platelet function, you can also think of a platelet transfusion. So the other patients are those with ischemic heart disease. Here we must always anticipate that any reduction in heart may be a new onset MI, it can be a silent MI, either preoperative, just preoperatively or intraoperatively also. The patient is going to have a reduction in the cardiac output. And once a reduction in the cardiac output happens, particularly in patients with a pre-existing peripheral arterial disease, you're going to see a worsening of that disease because the systolic pressure is going to drop and the perfusion of the extremity is going to drastically fall down. So we call this the cardiac foot, and we are also working to bring out a paper on this subject, which we have noticed. So patients with peripheral arterial disease perfectly walking fine, suddenly they suffer a cardiac illness and then they come back with a gangrene. So particularly if you can see this patient, he underwent a toe amputation for peripheral arterial disease, was doing good. He had an ischemic event, and you can see immediately he started to develop gangrene of the foot, which ended up in a below-knee amputation. And then come patients with renal failure. So what should we be careful about in renal failure? The most important thing to be careful about is the fluid overdose in the intravascular compartment. So the patient might not be taking fluid out enough, and they might go into a pulmonary edema. And the other thing to be very careful about is an increase in the serum potassium levels. If you don't address this well, the patient might go for an intra-op cardiac arrest. So these are things that we should be very, very careful about in renal failure patients, both fluid overload and an increase in potassium levels. Creatinine, urea, these are not going to affect it immediately, but these are the things that you must look at preoperatively, very importantly. And if you notice any patient who has been on long-term dialysis, you'll often notice that there is a severe arteriosclerosis with medial calcification of the vessels. And these patients usually are not very good candidates for vascular intervention or any other procedures that involve microsurgical options. And patients with decompensated liver disease, the most important thing to look at is the clotting parameters and also the serum protein levels, particularly the serum albumin level. If the serum albumin level is very low, these patients are going to have impaired wound healing, and their immunity is also going to be very low. And you must, we mustn't be attempting very extensive and complicated procedures in such patients. It's always better to just wait, get them prepped better, and then take them up for surgery. And you can see in such patients, the risk of bleeding is always high because the vitamin K, the levels are low, and all of the vitamin K dependent factors are very low. So once we've seen the preoperative complications, we're going to see very specific intraoperative complications. I'm not going to be very general here. I'm going to be very specific. And both the complications are related to the arterial problem. One is going to be an atherosclerotic vessel, and the other is going to be an arteriosclerotic vessel. We've always advocated the use of tourniquets for any surgery, debridement, elective surgery and things. But here, if you look at the amount of bleeding, and if you look at the tourniquet, you can see the tourniquet is on. But still, if you watch that the speed of bleeding was coming, it was fresh red bleeding, and it was just pouring out. But soon as the tourniquet is released, you notice that the bleeding has actually come down. So this is a paradox. So what is happening here? So in patients with severely arteriosclerotic vessels, the arteries will not close to the usual tourniquet pressure, but whereas the veins will get occluded. In such patients, an incision will be the only outlet of that venous congestion, and the patient will start bleeding torrentially. In fact, if you don't recognize a venous tourniquet, the patient can even bleed to death. So if you're using a venous tourniquet, please be very careful. Be aware of the problem of a venous tourniquet in a patient with an arteriosclerotic limb. Next, if you go on to atherosclerosis, this is very, very important for at least plastic surgeons who are thinking of doing a lot of microsurgery for the diabetic foot. If you see atherosclerosis, makes it very hard for us to find a correct spot for doing an anastomosis, and often complicates the anastomosis because there may be intimal separation or an atheromatous breakdown which can travel into the flap and cause a thrombosis. So here you see, we were not able to occlude the vessel with just a plain microvascular clamps, and we had to use bulldog clamps. And once we had done the flap, even then, we found that the gracilis vessels were also so atherosclerotic. In the end, the perfusion was not enough, and we gradually ended up losing half of the flap. So this was a perfusion pressure problem due to a severe atherosclerosis. So what have we done? We have adapted a Karen Evans technique of putting in an interposition vein graft, whereby you can see an atherosclerotic vessel here and an atherosclerotic vessel down there, interposed by a soft, small vein graft. And we have also taken up this technique to the next level to actually assess the flow of blood. It's called the Scout vein graft technique. It's been published in JPRAS. And this has really helped us do a lot of anastomosis without leaks. So now going on to post-operative complications, they can be divided into early post-operative complications and late post-operative complications. The general complications are, as usual, bleeding, particularly in cases where an angioplasty is done, and high doses of heparin are given immediate post-operatively. The most important thing to do is good compression. You know that it's going to bleed, give a good compression, wait. But after some time, if you notice there is a hematoma, if there is no problem, wait and watch. But if you see that the overlying skin is starting to necrose, then you can just take them in to the theater to do a minimal evacuation to prevent further loss of the overlying skin. And bleeding can also occur in suture wounds, delayed bleeding, particularly in vessels where there is a partial vessel injury. So you must always remember, a complete vessel injury is less dangerous than a partial vessel injury. A partial vessel injury, if it goes into spasm, actually opens up the opening. So because of that, the patient may not have an immediate bleed, they will have a herald bleed, particularly if in patients with microsurgery where 1 or 2 sutures have come off, or in a patient like this where there's a partial arterial injury. These patients will develop a week or 2 later a small herald bleed, then a lot of clots. And if you take them up for an ultrasound or an angio, you'll find there is a pseudoaneurysm. The only thing to do is go in, clip the vessel, and completely excise the vessel. And another important specific complication that I wanted to speak about, particularly to a lot of general surgeons here, was graft failure. So the most important condition for graft success is close, immobile contact with a good vascular bed. So every word in that sentence is important. Okay? So unless you have that, you're going to lose the graft. And you know you're going to lose the graft within the first 5 days of your surgery. The first 2 dressings, if the graft is not sticking, it's not going to stick anymore. So here we have a case. We have a case of a chronic vascular ulcer, a venous ulcer. We had earlier done an anterolateral thigh flap. There was again a recurrence of the the venous ulcer because the patient stopped using the compression garments. We debrided it, put a graft, but if you notice, the problem has come back with a vengeance. And then putting a graft again is not going to solve the problem. So using the same solution, you can't expect a different outcome. So here what we did was, we went in, took another vessel on the opposite side, and into this gap of this flap, we put in another gracilis flap, and this whole thing settled well. And now you can see actually the graft is sticking. And now the patient is following up on good compression garments. Speaking about grafts, the wound which you grafted was made by God. It's his problem. But the place where you took a graft is created by the surgeon. It's your problem. So you better make sure that that heals very well. It's not that everybody doesn't get a complication. Even we get complications like these. But what are the precautions that we take to avoid this complication? We always change our gloves once we handle the wound and we are going on to take the graft, the entire team will change the glove. We will not use the instrument that have already been used in the wound. Second, we will again repaint or surface the whole graft donor site with skin prep, even though it is prepared and draped. And such precautions will help minimize graft site complications, but even then, you cannot entirely obliterate them. But please do your best to avoid these complications. Here we excised, and if you see this complication, address it immediately. Don't manage expectantly. We excised it and again put in a small graft, and it went on to heal well. Flap complications. The most important flap complication that I want to speak about is when you put a free flap on an infected wound, please expect the flap to get infected. It's called an infective myositis. Once you put the flap, the patient is going to go for a fever. The flap is going to get infected. The flap will start to look dull. The patient's counts will start to raise. He will have an increase in CRP and procal. But that is why it's important to do a preoperative culture and keep your antibiotic profile ready. Once that happens, you can also see sometimes the flap gets so congested you think that you're going to lose the flap. But it's important to maintain your head here and not just go in and just take off the flap. And with time, the flap settles and the eschar comes off. And this is one of the reasons why we never graft a muscle flap primarily, because nearly all of them always end up getting infected. But however, if you see we've taken a long vein graft here and the patient develops a cardiac incident, the entire flap can also go. It's not that we don't have flap losses, but with good practice, we have managed to minimize our flap losses to just 3.5%, which is about world standard. So another important postoperative complication, which is quite late postoperative complication, is a recurrence of ulcers. You can see here simple plastic surgery. The ulcers come back with a problem. Simple plastic surgery for ulcer here comes back with a vengeance here, but it takes quite some time. And the answer to this is surgical offloading. I'm sure all of you must be aware. And those who are not aware, please do go through this paper. It was published in 2016. And we also realized it's nearly a decade since we published this paper. And we are coming out with our book. Most probably by the end of this year, it will have a lot of more details, and I'm sure all of you will enjoy it. But there is one very late complication which we must all be prepared for. It is litigation. And the only preparation that we can have against it is safe surgical practice, safe surgical practice, and safe surgical practice. Because eternal vigilance is the price of liberty and here safety. And the other options are malpractice insurance, and the most important thing is empathy, which prevents more lawsuit than any perfect surgery can. Thank you. Thank you for your time.
Thanks a lot, Madhu. That was a wonderful presentation. And thanks for joining in spite of the emergencies that you're facing there. Hope everything settles very soon. Thank you, Madhu. Next, I would like to call upon Professor Raja Savapati, sir, to talk on common pitfalls in diabetic foot management.
Thank you, Rajesh, for organizing this meeting. And if you really see from Srinivas' talk and Madhu's talk and my talk, you will always find that since the topics are the same, most of the things will re-emphasize. And it's also good to re-emphasize because these are common things which happened, and then everybody talks about the same thing that means all of us have suffered the same thing. See, for me, the title that has been given is Pitfalls in Diabetic Foot Management. If you really think, what do you mean by a pitfall? That means it's a danger or a difficulty which either is hidden or there is not obvious. I think that's the pitfall. I think what you know, what you expect, that's not a pitfall. I think what you get, suddenly you get caught, it's a pitfall. So whenever you encounter a problem for which you are not really prepared, that means the outcome could be disastrous. So I decided to take it in two things. One is pitfalls in techniques and pitfalls, non-technical pitfalls. So pitfalls in techniques are easily very correctable. I think our decisions are easily correctable. So I think I'll concentrate more on these in these 15 minutes. I thought I'll tell about 10 pitfalls, what we have found in our, which have been the most common. The pitfall number one is missing the bus. See, here you find the patient has come to us. If a patient could come to present to a surgeon, both sides he had a great toe ulcer. But someone tells, can I wait for about a month? Okay, then you also say, yes, you can wait for a month. It has been there for a year and all that. But then in the month that you wait, and it gets the other one, like the complication could arise. So the one thing that what we should tell them is, as a doctor, I cannot ask you to wait. But then if you find that is there, that means you have to. So that means you are on the positive side. That means we could never tell them because if we are not God, then we can never predict as to when a complication could happen. I think you will see the same 2 feet, both feet at the great ulcer, and then suddenly they have been present for a long time, and suddenly one gets like this. I think that's the missing the bus, as you call that. No, so that's the pitfall number 1. The second pitfall is that I already been emphasized. This I first found it out in 1991. So when we started our practice, and there's a diabetic foot, this thing. So you find a lot of patients refer to you. They say that they had a shortening closure, and then after 2 weeks' time, then you find an abscess in the midfoot. Then every time I found that there was the tendon, that is flexor tendon, that has been divided at that level, has gone back. So what really happens is the tendon, which has got a lot of infective material, which is infected, when you pull it out and cut it, that means it still is not a good tendon. So when it carries the infection down to the midfoot, it is now in an anaerobic environment. I think it's a perfect state for which, for you to get infection. So then we started this system of, so when you have the beginning of the surgery, and then if you're going to amputate, you make an incision in the proximal part, and then divide the flexor tendons, and then pull the flexor tendons from distal side, proximally, you pull it to the distal side. So that means, this bad tendons and got no opportunity to go along the sheath. I think that's the thing. So you need to cut it proximally and withdraw the cut tendon distally to prevent retraction of the infected bit. I think this is the pitfall number 2. So pitfall number 3 is underestimating the need for radical debridement. I think this is a very, very important finding. If you find us where we get cases referred, I would say that about 30% of the cases come because of this. A common cause is a common cause for a compromised outcome. And then what you need to think when you start debriding, this we tell it for trauma also. If somebody asks you, what do you mean by debridement, we say that it is removal of the dead tissue, removal of the contaminants, all that we'll say. But then as a surgeon, when you go to debride a wound, what you need to think is, you need to think that at the end of debridement, what is left is everything is viable. I think that's a different way of thinking, but it may look as if we are talking the same thing, but they are not the same. There's a subtle difference from telling, I'll remove all contaminants and I'll remove all stuff, to telling that at the end of debridement, what I leave, everything will be viable. That means that's get a little bit of an extra step. I think this is what differentiates good surgery and almost a little compromised surgery. And the confidence in reconstruction gives a lot of courage during debridement. The 2 important things when you debride, one is use the tourniquet. I think you must use the tourniquet because all our diabetic patients are all compromised individuals. They cannot stand blood loss too much. I think that's very important. They cannot stand blood loss too much. They have got a heart disease and all that. Compromised individuals cannot stand blood loss. And whenever you start debriding, you need to extend the incision. And then when you extend the incision in a diabetic patient, it's always longitudinal. I think it's not transverse. I think you always know longitudinal incision. So here you find small callosities that are there. And then that might get infected, when it gets to necrotizing fasciitis. I think what you really need to do, I think from that small area, I think you need to reach to a level like this. I think up to only when you reach to a level like this, then you will find, then after that you could graft and get an extraordinary good result. That is quite possible. But then being afraid to make the wound bigger, I think that's a problem. See, here a patient comes with a small ulcer over the tendoachilles. I think you see a sloughed tendoachilles, you see. And on debridement, the whole of the tendoachilles has sloughed out. And it has gone almost to the popliteal fossa. So always extend the incision while debriding. This is point number 2. I get one more example. See, here you find that's the base of the 2 toes. You got slough. But really what you need to do is that you need to really debride it to this level, you need to debride. There are 2 ways of dealing with this. One, you could wait to keep dressing, put other things and all that. But then if you are in a place where you are able to, if you have got pulses that are palpable, what we have done is we have taken a free gracilis muscle flap and then put it on. So a free flap has been done to salvage the foot after a good debridement. The bed is good, the vessels are good, that means good. This is possible in our country because most of the diabetic foot that happens in India are all on a neuropathic foot. I think whereas you take a Caucasian people, they have got a high percentage of vascular problem, whereas in India we have got a high percentage of neuropathic foot. So usually the vessels are fine, but the sensation is wrong, and the altered biomechanics cause this. Point number 4 is trying to debride and reconstruct when pulses are not palpable is a mistake. The first thing we do is when you see an ulcer, we don't even look at the ulcer. First thing is what is that you keep a put on, whether you see a pulse or not. Is it a vascular foot or not a vascular foot? So no reconstructive surgery will be possible. I think no recent wound care products will be useful. I think even the best of the wound care products will not be useful. They all need a vascular surgery consult. I think now you need to get blood into the foot. I think only then it should be possible. See, here you find this patient who has got a great toe has been amputated. So, but then pulses are not palpable. You find a lot of stenosis. You revascularize foot, you do the angioplasty has been done, you revascularize foot. When the pulses become palpable, immediately you can even do this. I think you can do a post-angioplasty, you can do a gracilis flap cover, and then you save the foot. I think this is the point number 4. I think this is the most important thing you have to get. Unless you have got blood supply, nothing will work. So you need to get a good blood supply. Point number 5 is seeking the assistance of VAC in inappropriate times. That's very important. So VAC will not be useful, and VAC in fact is dangerous if you put it on an infected bed. I think you put it on an infected bed, particularly so in trauma too. That is, you put a patient who has got an infected wound or slough in the base, and then you put a VAC, immediately they go for septicemia. You will find if any patient you put a VAC and in 24 hours you get 48 hours you get fever, that means the first thing you have to take is to throw the VAC away. So you cannot do it. Infection in the bed, that means that it requires debridement and not VAC. VAC will not debride. The second thing is, we should not put VAC in ischemic foot. I think ischemia also, VAC will not be useful. I think that's point number 5. So when you do the point number 6, what I want to say, when you are doing minor surgeries, you need to be more careful. I think this we always say, even when in trauma we say, I don't mind, if we get a patient who has got the hand comes in 3 or 4 pieces, it's fine, we can do it right. But then if somebody has got a small fingertip injury, you have to do it very, very carefully. Or they come with a 1 centimeter wound in the forehead, you have to be very careful. But they will not wait and they will not agree for a compromised result. So you need to be well trained. That means, what do you mean by well trained? That means, you should be able to treat the complications of the procedure that you do. I think that's what is called a well trained. If you are doing a small thing like a flexor tenotomy or a Keller's operation, the complications are more acceptable to patients or more unacceptable to patients after a minor procedure. I think because they think, mostly they think they don't need surgery. Then you tell them that you need surgery, you explain to them that you need surgery, and then if you have a problem, that they will not accept. Those people we find, I think smaller procedures we find that they need talking, they need a lot of talking before surgery, they need a lot of talking immediately after surgery, and then a lot of talking explanation as to how they should be after surgery. Then the next point is not saying no to continued dressings or reconstruction is a pitfall. I think at some stage, you must know that means this won't work. I think, you should not be continuing on. In the process, if you don't do, what happens is that you may endanger the lives of the patient or wipe out the families financially. I think this again is very important. So you must know when to say no more. For example, here, you find there's a patient who has gotten severely infected. It's a Charcot foot who has got severely infected. See, what we have found is, if a bone gets infected, you can always cure them. I think you can debride it well, you can cure them well, or you can remove that, and then you can fill the cavity, you can get away. But we have found if all the intermetatarsal joints, joints get infected, that means it's not salvageable. I think that's the addition that the experience we have found. So here we have found that infection, when the joint cavities get involved and are bathed in pus, it becomes extremely difficult to salvage. That means they all need amputation. But whereas here you find, if you see the X-ray, the calcaneum has really got infected. I think the calcaneum is really got infected. So you can just remove the calcaneum. We removed it, and then after that we have made the gap. We have filled up the gap with the free flap. And after that we have done the anterior side. We have done the ankle fusion on the anteriorly. That means that this guy can walk. But whereas that if infection has been only in that bone, it has not extended to the next level. I think it has not involved the joint spaces. So if you find that the joints are infected, that means these people will not walk. So next I come up to the last things, I find the complications versus disasters. This is a very common thing. On the last 30, I keep on telling every batch of people, I keep on telling. See, when there is a mistake in your technique, that means you get a complication. That's always just solvable. I think in our institution where we find, when I mean say that we got a disaster, that means it's non-surgical. I think if you have a disaster, that is, it's a non-surgical. That is, you missed a major important point. See, what are the non-surgical mistakes that you could have? I think this you need to mark it because, but then if you're becoming a very busy unit, that means if you're doing 1 or 2 cases, it's okay. But then if you are unit which are making the unit which do 1,500 cases a month, then what happens is you need to have a very rigorous process you need to have. I really can't emphasize it more because most of these patients will have many toes will be involved. You will say that you do a flexor tenotomy for the second toe, then you may do it on the opposite side or the third toe you can make it. I think this way. You need to mark it. And I have to tell the younger generation that is, you are only as good as your last dance. Okay, so you might have done about 10,000 good operations, but then one operation, you do a bad operation like this, that means it may wash out your entire reputation, it might wash out. So not driving discipline in the whole unit could become a pitfall in a diabetic foot unit management. So this is a very, very important point today. The point number 9 is knowledge gap. Not knowing what one needs to know about diabetes as a disease and its management. See, we are all surgeons. We think, we'll only operate. I think that's not enough. I think you need to know something about the diabetes you must know. Some of the drugs that I usually take, you must know. You must know the half-lives of that you should know. How often they do, you know. This becomes very, very important because sometimes, your schedules in the operating list may get delayed. That means these guys may become hypoglycemic. I think that's very important. I think these are the small, it may look to be an ordinary thing, but then a person who has got a cardiac disease, I think if he goes little amount of hypoglycemia, so small compromises lead to big disasters. So I think that again, you must know. So there is a knowledge gap that you need to have. And not taking care of what you think as minor things can lead to major disasters. Like what I said is hypoglycemia due to delay in taking up for patients for surgery. And most of these patients, as Madhu said, they got a lot of comorbidities. And so they may be taking drugs, but once they come to the hospital, they will think that all the drugs you will give. So sometimes they may not tell it properly or you may miss it. Transcribing them at the discharge is also very important. Sometimes you may really miss out the very important drugs. And then when you come back and ask them, you say, they didn't ask us to take. So this again is important. So missing drugs when they get admitted to the hospital is a problem. Missing drugs when they get discharged from the hospital, that again could be a problem. So these are the things that they don't result in complications. They result in disasters. So this is also you should take. And finally, most important is not having support system of sister specialties. I think that again could be a problem. When the diabetic unit picks up, you're not going to get small problems. You are going to get big problems. So what you need is you need expert anesthetists who are well versed with regional anesthesia. I think regional anesthesia is really taken off in a big way. So that's very important. An intensivist who could cover you up both before and after operation is very important. I think diabetic foot is one field where interdisciplinary care is very important. And lastly, as Madhu also said, we keep on telling it in our unit, eternal vigilance is the price of safety. Since you are not sure how things will go, it's important to see, and this I tell to everybody, and then even if you are a very senior person, you need to follow this. Just because you're older, I think the patients don't expect anything different from you. So you need to speak to the patient before the operation, you need to speak to the attenders after the operation, and you must see them before you go home. I think this you make it as a routine. I think no matter what, you need to do this. Then what would happen is, even if they get into a problem, they will say, no, doctor saw us, the doctor saw us in the night, we are all right. Okay, if you just miss it, again repeat it, you must see the patient before operation. That is, before induction, you have to see them. And after the surgery, you need to go back to the post-op ward and see and talk to the attenders. And you must see them before you go home. I think you just have to make it, this is all right for every disease. But for a diabetic, it's absolutely is very important. If this system is diligently followed, you can be sure of a very lot of peaceful nights. Thank you so much.
Thank you, sir. Next lecture by Professor Delayapar. split skin graft versus flap versus dermal substitute.
Good evening to all. Thank you, Rajesh, for having given me a chance to speak here. Not only a simple chance, but being encouraged to talk with the very greatest persons of our country, Professor Rajesh Sabapathy sir, who hails from the Mecca of plastic surgery of our country, Ganga Hospital, and my teacher, R.V. Venkatakrishnan sir, and all my friends. So my topic, whether SSG versus flaps versus skin substitute, the same thing was dealt for the past 2 days from yesterday morning itself, and it still keep going with all the plastic surgeons and all surgeons. So diabetic foot is prone for changes due to various reasons. At times, even in spite of best level of care, there might be a non-healing chronic ulcer and infective wound that requires treatment. So before coming for the surgeon or plastic surgeon or podiatric surgeon or orthopedist, anybody else comes there, the patient would have completed all the available conservative management treatment. That is starting from the normal glycemic control with antibiotics and culture sensitivities and so much of things. And of course, all these patients are always associated with other system failure like cardiovascular system, renal failure. So when the patient comes to me, it's difficult to convince the patient to go for a surgery and other things. And as well as we can understand why things are going wrong. It is because associated with the peripheral neuropathy, ischemia, and deformities, they are always associated. In addition to that, infection. Infection also causes these things. The neuropathy, you know how it affects the foot and how the ulcer started forming due to loss of sensation and other things. You can see the cascades that occurs in the neuropathy. Then ischemia, that is peripheral vascular diseases, and everybody has told about that. And deformity of the structural. Telling before going and touching the patient's foot, we must be very thorough with the normal anatomy of the foot and ankle, as well as what is for the particular patients whom we are going to treat. So we are taking all the radiological investigations and other Doppler and all other investigations and find out what is there, and accordingly you have to plan our surgery. Dr. Rajesh told about a problem, the calcaneum, and everybody stones with somewhere in the joint spaces or with a tendon. Everything must thoroughly go with that and go ahead that. Infection, again. So what we see is only before doing the wound management, the patient comes over there will be some blisters or there may be some pus points or some maybe ulcer. This is only a tip of an iceberg. That is only the deeper things will go there. Beyond the subcutaneous level, along the dental tunnels, along the subfacial plan, the patient may come with something over with a great toe, but the infection would have started even from the above angle stage. So if you just look at the smaller portion and debride it, then it is not going to give a complete heal. Even if you do the grafting and other things, the post-operative period itself, some other pus points may burst out in the other cough region or somewhere else. Do a thorough debridement, thorough investigations, and go ahead with a complete treatment. So wound debridement, of course, many methods are available, enzymatic, autolytic, biological. But always, in our department, we used to say, always attack microorganisms with knife. That is the best thing. Always start with a debridement. That is thorough debridement. When you're doing the debridement, think about what you do for the cancer clearance. That's why local excision. So you do not show any sympathy for the dead tissues there. Thoroughly debride it. Give margin at least 1 or 3 or 4 millimeters. Say at Rajesh Sabapathy, I told after a debridement, there should not be a single unviable tissue should be there. All should be thoroughly clear bleeding, crystal clear. You must occur and you have to continue over that. So optimizing the healing, so many things. Either whatever you plan for a SSG or a flap or for the skin substitute, you first optimize the healing. That is, so many ways are there. All the basic things we are taught. Even the advanced thing we were taught in the past 2 days, always hearing about the very latest treatment to everything we are hearing about that. The most important nowadays, that is negative pressure wound therapy. You must be here also, before putting the patient on NPWT, be sure patient wound is totally debrided well. That is, you yourself go and see the patient and get thoroughly satisfied with the wound condition, then go for the negative pressure wound therapy. Do not do in a undebrided or a patient with an infected, it may go for sepsis, septicemias. So many things will end up with the patients, so be thorough with that. And of course, many places it is available, hyperbaric oxygen therapy. They can also, you can consider the patients and make the wounds recover. And then you go for the reconstructive ladder. When you think about the reconstructive ladder, always think from the base. That is healing by the, that is, first it may primarily heal. Second, you go with some help for the wound to heal. You can go for the secondary intention, then go for the skin graft, then for the local flaps, then for the distant flap, then for the micro flap and microvascular anastomosis. Even if all those things are not available, then you can go ahead with the skin substitute, and so many things are there. So it's a simple skin grafting. That is a part of a dermis, and part of the dermis and epidermis is taken and it is applied over the area, and the wound will become healed. This is a very simple procedure. That's a bread and butter for any plastic surgeon or any podiatric surgeon, very easily come over that. But we must understand which patients ask for the SHG. So it can be given only over the area where there is no bone or tendon or vessel exposed, unexposed area only you can give. For that only you are making the granulous tissue to appear by means of all the wound techniques like NPWT and of course taking the wound culture swab and nutrition of the wound. So many things are of the patients. Then split skin grafting is applied. The prerequisite skin grafting is optimized wound bed. Wound bed should be capable of supporting the skin graft. Wound bed should be devoid of infections, especially beta hemolytic streptococcus, coagulous production staphylococcus, and pseudomonas. The morning they were told even if you take a skin swab for a normal person, all these will be there. Then how can you expect these not present in the diabetic wound? So we depend upon the load. We not only just presence, we depend upon the colony count or load of the wound. So accordingly you treat that. This is one simple example. We have given that this patient with a diabetic foot wound, with a SR formation and other things, we have thoroughly debrided and put the patient again and again for a VAC therapy, as well as this patient was treated in KMC where their hyperbaric oxygen therapy was also available. Patient was also given over that. Now the patient's wound bed has become very clear. Then a large skin graft is given. It's taken well. It's a very recent, like 15th or 16th day only. After that, the graft would have taken very nicely. But what are the advantages? Even though it's a very large graft, we would be able to do that. And of course, the operating time will be very less because the wound is already good. So even patient with a poor compromised ejection fraction, or with a patient with some renal problem, whatever other complication present, we can take the patient and we can easily do the surgery. This patient also given by a flap, but this is a very large flap which requires a very longer time of surgery, and donor site will become very difficult. If at all we are going for a flap, we can think for only a cross-leg flap or a free ALT flap with a very large duration. And of course, other comorbidities we may start doing in the post-operative period. So simple we do and come out. But there are certain disadvantages with SHG. What is that? What is the most important thing? When they are easily prone for the next ulceration because of the poor quality of these things. And of course, here nothing, you have to, for that to avoid, you have to give a graft care. The grafted skin is devoid of sweat and sebaceous gland, so it is unable to secrete moisture or oil. So if the graft is not moisturized regularly due to dryness, cracks or fissures will appear which may be infected later. So graft should be massaged, lubricated with moisturizers like coconut oil, liquid paraffin, that is very commonly used, and so much other things are moisturizers available in the market now. Skin graft is not suitable for stress and maybe breakdown on constant friction due to care is needed. So in case the ulcer here, what we see, what's present only over the dorsum of the boot and the posterior aspect of the leg. In case if it is present over the weight-bearing region, that is in the plantar aspect, then skin graft would not be given. Then you must go for the flaps. So indication for the flap, what is flap? Tissue with its own blood supply is called a flap. The flap may be a local flap, that is defects formed one edge of the flap, an intrinsic flap raised from the same region of the foot, distant flap raised from adjacent region, the free flap harvested from another site with blood vessels are then transferred to the defect and transposed to the donor blood vessels. So much of local flaps we must have studied and we must have seen, starting from the simple rotation flap to the advancement flap and V-way advancement flap, and so many are there. I have given one simple example. This flap, it's a deeper ulceration. The entire wound was debrided, and we planned a V-way advancement on both sides of the defect. Both sides of the defect, V-way advancement flap was done and mobilized and sutured, and the wound healed well. And of course, we must follow it up, not to recurrent, because it is also very close to the weight-bearing region. So for some time, you can give a good orthosis to prevent pressure over that area, and you must educate the patient in such a way to protect. This is a regional flap. That is, few options are available. That is either a medial plantar artery or a flexor digitorum brevis muscle flap or a EDP flap, or etc., etc. Or the medial plantar artery flap, technically difficult, sensile flap with glabrous skin for the tissue replacement. Here I have given an example of a FDP muscle flap. The ulcer is almost in the calcaneal region, the weight-bearing region. So distally we have a straight transverse incision. We identify the FDP muscle, and the muscle was harvested and reverted back from the incision. That area was grafted and the wound healed well. This is a medial plantar artery flap. Medial plantar artery flap either can be harvested as a islanded flap or even as a pedicled flap also. One important aspect of the medial plantar aspect is the donor site is a very glabrous skin. Moreover, it is in the medial concavity portion of the foot. So even that area, the donor site, we can give a graft. That will be healing nicely, as there is less pressure over that area. That medial plantar artery flap can be easily harvested. The last picture is with a pedicled one. The other one is an islanded one. So this is an example of the reverse sural flap that's in the angle region. For that also, as it is exposed and very close to the tentaculus region and with a medial malleolus bone, we cannot give any graft over there. So we take the reverse sural artery flap and the donor side, we have done the grafting and the wound will be healed well nicely. So like medial, this is a lateral supramalleolar flap. This is also taken over the small defect that arises from the tentaculus area. Tentaculus is the most important. We cannot sacrifice any cause. Very easily infectable area also. So after thorough wound debridement and with all those glycemic control measure and other thing else, this lateral supramalleolar flap was applied over that. And of course, these are all pedicled flap, either from the adjacent area or from the nearby muscles. Otherwise, free flap can be taken. That is a flap harvested from the distal region and has come over that. In commonly plastic surgeon, we mainly do over the anterolateral thigh flap. But here, the foot where you have to go for with a weight-bearing area. So if you put that anterolateral thigh flap, it will be wobbling. You cannot have much grip over that. And moreover, with the skin and dermis will be present, very easily go for recurrence. So not to avoid that, we plan for a muscle flap. Either the graceless can be given, or here in this picture, we are given the vastus lateralis flap. The marking is almost like anterolateral thigh flap. By leaving the skin, we take the vastus lateralis muscle and smooth with a nearby muscle for the defect here. And over the muscle, the graft was given. That will settles very nicely. So when we can think about skin substitute, so far the pictures I was shown and all is a very big areas, almost needed 2 or 3 surgeries for debridement and making the wound healing well, then taken for a graft or flaps, something like that. Whereas if it is a smaller one, like 1 square centimeter, 2 square centimeter, just exposing over the, especially over the dorsum of the foot, exposing the extensor tendons or some other tendons, these areas, we can think about the skin substitute. What are skin substitute? They are the bioengineered materials. They are artificial dermis, gets vascularized from wound bed, but can sustain on bare bone or tendons if periphery is held. These are small areas. After substitute is integrated, the wound needs to be skin grafted. It can be also, now other recent materials are there. The skin grafting can be done in the primary surgery itself, or you can do as a secondary one. Commercial preparations go by names like Indacra, Matridum, Polynova, BTM, etc., etc. Here I have given one example. This patient is a diabetic patient, but had an injury. Further, they have given the tibial fracture was also there. They put the plate and other things. After that, the area became necrosed, that area. They came to us in the plastic surgery. We totally excised all the necrosed bone. On that area we cannot do any other flaps because considering the general condition, we cannot think about even the cross leg flap. So what we thought, we applied the Indacra over that area, and we allowed for 2 weeks, 3 weeks, and became vascularized. Then we did for the grafting for that patient. The graft taken well, patient went well. So how do you think the choice? The most appropriate option for the wound cover, how do you choose that? The early coverage of the defect is very, very essential, because for any wound, any skin raw area, the best dressing is skin. That is what Lord Lister told. So still now, whatever the specialist, whatever the bifurcation, whatever the trifurcation comes, we always think about that. So factors to consider: availability, resources, logical feasibility, surgeon, and all the characters of the ulcer, like location, size, etc. And of course, most important thing, cost, everything. And accordingly, we think these are all other some of the examples where we are given that. Why this patient? Actually, you can think about a raw area over there, but the calcaneal surface, there was a part of plantar skin was present. So that way, that area, patient can easily walk over that. So we just give graft over the rest of the area. The patient, general condition also not good, but within 30 days of putting 1 or 2 wax, patient became well. We grafted this. These are also some other few examples where we can think about the alternate source. So is this the end of the care? Is for a podiatric surgeon or a plastic surgeon or a general surgeon, orthopedician, whosoever it may be, when the patient has come with a skin raw area, we are given the cover, we can able to make the patient to walk either simply or with other processes, helpful offloading techniques and other things. Is it the end of the care? No, it is never an end of the care. It has to continuously follow up with all those things. Especially, we have to think about any deformity or any orthopedic something, any pressure point that is to be taken out, recurrence, patient to be followed them. In a review also, we always consider with a modern management like so much of other computerized testers, pressure points, testing, all these things available. So we have to assess the biomechanics and all these things. So the conclusion is the disease is progressive, diabetic disease, especially when you get the complication of diabetic foot. The morning we were all telling from the great stalwarts, that's a 5-year survival rate after the foot. It's almost 60% only. They were always telling. So far we were talking about the 5 years survival only for the malignant conditions. Now we are thinking about the these diabetic foot ulcers also. So we always consider the follow-up importance. You can educate the patients and the patient. Sir, Rajesh sir always telling, keep telling, educating the patients to attend daily, either before surgery, or during surgery, after surgery, and follow-up every time. So that is the only way we can get the confidence of the patient and their attendant, and we can have a complete cure for them. Thank you very much. Thanks for patiently listening.
Thanks a lot for a wonderful presentation, sir. Because again, paucity of time, we'll go to the next lecture now. So Dr. Rajesh Kannaya, he's going to talk on endovascular procedures versus bypass. Which is better? When is better?
Good evening, respected dignitaries on stage and off stage. And the importance of vascularity was appropriately pointed out by Professor Rajak Sababadi sir. With this brief introduction, I'm going to talk about endovascular versus bypass, which is better and when it is better. So for ages, we have been accustomed for open surgery, ranging from endarterectomy and bypasses, and which are more durable and acceptable. But the problem with open surgery is it's a prolonged surgery, and all the patients may not tolerate a open surgery. So then came the endovascular era, in which we are more comfortable with the balloons, stents, and the newer technologies like laser as well as intravascular lithotripsy all come into play. And it significantly reduced the patient morbidity as well as the mortality. So we thought the endovascular era is a revolution came, and this could say an answer to all these things. So the arterial tree, you can see the from the infrarenal aorta to the inframalleolar artery, all the segments can affected by diabetic peripheral vascular disease. So we need a classification system to address the issues. So the basic classification which come into force is a transatlantic intersociety consensus classification, that is a task classification based on which we can quantify the disease. So task A is basically a small lesion, so a small stenosis or a small occlusion in the common iliac artery, and task D is extensive disease in the both iliacs, or either the external iliacs are involved. So for a task small lesions, we can go for an endovascular. For a complex lesion, we can go for a surgery. For lesions with task B and D, C, we can go for either surgery or a endovascular based on the patient comorbidities. So going under the aortoiliac disease, it's almost 10 to 15% of the diabetic foot ulcers we come across aortoiliac occlusion. We have options of iliac stenting and open aortic bypasses. So the aortoiliac bypasses, open aorta bifemoral bypass, is a gold standard if the patient is fit enough, especially in task C and D lesions, because the patency for a process is almost 97% even after 2 years. Compared to the iliac stenting and other things, its patency is about only 70 to 80%. So always the bypass, the results will be better, the patency will be better, the limb salvage will be better. But we can't afford bypass for all the patients because of the severe comorbidities. This is one of the aorta bifemoral case which are done. Basically, it's a task A and B. Endovascular first approach is reasonable. For task D, surgery is preferred. For task C, B and C, task C, it should be a shared decision because depending upon the patient comorbidities. So, like the task classification, next thing what is evolved is the glass classification. Based upon that, we use for the femoropopliteal and infrapopliteal as well as inframalleolar disease. So the SFA disease, if it is a small stenosis or an occlusion, that comes under class 1. And if it is an extensive disease, it goes for a class 4. And here, it is an infrapopliteal disease. You can go for ranges from class 1 to class 4. If the tibioperoneal trunk is occluded, it is class 4 because it will be difficult to cannulate these lesions. And for the inframalleolar also, we have got classification like P0, P1. If the arch is, plantar arch is intact, that is P0. The plantar arch is incomplete, that is P1. If the plantar arch is not seen, that is P2. So if you see a patient with P2, we can better refer the patient to one of your enemies. Because even after a successful revascularization, the wound won't granulate because there is no meaningful vessel in the foot. We call it as a desert foot. So this is the time we should ask for reference to this patient. So based on the anatomical classification, we can go for a GLASS, that is a global limb anatomical staging system, what we follow now. So putting all the femoropopliteal, infrapopliteal, and inframalleolar disease, we can club into GLASS category. So GLASS category 1, GLASS, which also quantifies the patency as well as the limb salvageability, assesses the limb salvageability. So it is better than TOS classification. So nowadays we follow GLASS classification. So for GLASS 1, we follow endovascular. For GLASS 3, it is bypass. So the severe calcification increases the target artery pathway by GLASS segment 1. So for GLASS 2, we can go for shared decision, like whether you go for a bypass or an endovascular. The superficial femoral artery is one of the most complex territories one can deal upon because it is a very challenging, because the artery can undergo multiple torsions, compression and all. So even if you go for a endovascular intervention, with plain balloon angioplasty alone, the patency rate will be only about, the failure rate is about 70%. So very high failure rates after 1 year. So the results may be promising initially and you will get a good pulse and all, but after 1 year it goes down. Even with newer gadgets like stents, drug-eluting stents, drug-eluting balloon and all, the patency rates will be very less because of the high restenosis as well as stent fracture and stent migration can happen. So be cautious when dealing with superficial femoral artery. Bypass is always a gold standard. The long-term patency is definitely good. But most of our diabetic patients, when we offer a bypass, they will definitely ask, doctor, even this small wound is not going to heal, is taking much time to heal. How this surgical wound will heal? So you have to convince the patient and get ready for them for bypass, especially if they are fit enough. So that should be the concept. The bypass is always an acceptable choice, especially in the femoropopliteal segment. And short lesions in the SFA, you can go for an endovascular first approach. If it is a long and complex lesion, go for a bypass if in a fit patient. So the conduit matters. If the great saphenous vein is very good, the limb patency as well as the limb salvage will be very good. Okay. This is one of my cases when I come across almost 6 months back. This patient gentleman came with an ulcer in the right great toe and and he went to some other center. They did a great toe amputation and his ejection fraction was only 35%, and they have done chemical lumbar sympathectomy for probably some reason, for probably to relieve the rest pain. Chemical lumbar sympathectomy will not work in a diabetic foot and diabetic patient at all. So with spreading gangrene, he came. So you can see the CT angiogram. There is no, you can't notice any occlusion here in the CT angiogram, which looks fairly normal. But the vessels in the plain CT shows a densely calcified vessel. So I did, before offering any surgical procedures, based on CT angiogram, always go through the cut section, and if doesn't answer anything, then you go for a digital subtraction angiogram. It clearly shows a near total occlusion in the mid superficial femoral artery, and popliteal artery is reformed. And for this patient, if the poor ejection fraction and a borderline CKD, I did femoral endarterectomy. You can see the hard plaque, which is nearly occluding the common femoral artery, and with a sheath in the superficial femoral artery, I did intravascular lithotopsy and able to achieve a good channel. And ultimately, the wound started granulating and the rest pain relieved. So, depends on this patient, the anatomy or the glass decides the patient stratification, but the patient comorbids and other things decide the treatment strategy. Yeah, popliteal artery disease, you can notice there is an occlusion in the popliteal, mid-popliteal, that is a P2 segment. From the adductor hiatus up to the patella, we can say it is a P1. For P1 lesion, the endovascular results will be very good. For P2 and P3 lesions, the endovascular approach, the results are suboptimal. So, what recent evidence say, the best CLI trial, the data that changed everything, the cohort 1 bypass was superior in reduction in major adverse limb event as well as death was endovascular. For cohort 2, there is no much difference. So, for the lack of time, I will just rush. For BASIL 2 trial, has found that endovascular strategy, that is basically BASIL 2 trial is for the infrapopliteal segment. Here, the endovascular treatment is a first choice because the bypass cases went for major, death is a major adverse event in this group. So this is a patency across territories. You can see the bilateral bypass scores better even after 5 years, and all others like endovascular things, the patency rates are less. This is one of my follow-up patient. She had underwent left femorodistal bypass, left common femoral artery to proximal popliteal artery bypass almost 13 years ago. Now she came with the right critical limb ischemia, and now you can see the aortoiliac segment has completely occluded, and even after occlusion of this proximal segment, the bypass graft is patent. That is the beauty of a bypass surgery. And this time the patient is not fit enough, but they wanted a bypass. So this cardiac ejection fraction was only 30%. I did do an axillobifemoral bypass. That is an extranarvical bypass for this patient. So current guidelines at a glance, for an aortoiliac task A and B, it is an endovascular first approach. For aortoiliac task C and D, you have to go for a bypass. For femoropopliteal, the endovascular therapy should be the first choice. For a complex lesion, you have to go for a bypass. Yeah. So, if the anatomy, in a nutshell, the task C and D and glass 3 needs a bypass. If the condit is good, you can go for a bypass. If the patient is fit enough, you can go for a bypass. So, this is a takeaway. For SFA and popliteal, endovascular first. And for tibial also, endovascular first, especially in complex lesions, especially in simple lesion. So there is, this famous flame in which you have to choose between the endovascular and bypass. Sometimes you have to go for a hybrid approach, combining the endovascular as well as open surgery to get an optimal result. References. Thank you. Thank you, Dr. Rajesh Kesman, my good friend and my unit mate, for giving me this opportunity. Thank you all.
About the pitfalls, I want to, as an eye-opener, I want to share with you all. One patient was wheeled into a corporate hospital with acute pulmonary edema, straight away admitted in ICU, ventilation was done, ventilatory support was given. The in-house surgeon was called. Seeing that there was a swelling, bedside X-ray was taken for the foot and heel, and there was an abscess. Bedside, with the help of anesthetist, he drained the pus, and he weaned off from the ventilator. Second day, he was in the ward. Patient did not want to continue the treatment there. Then he went to his family surgeon. This first surgeon has lost the contact. Second surgeon, he did a wound ebrima. He was doing daily dressing. The wound was not showing any improvement. The patient did not show the X-ray to both the surgeons. So on the 12th or 14th day, he brought the X-ray to the surgeon, second surgeon, family surgeon. He saw there was a foreign body. He was in ventilatory support, no family history could be taken by the family member, or the patient cannot talk. Then third surgery was done, the glass piece was removed, the wound slowly healed after good dressing for a few days. Who's to be blamed? The first surgeon, second surgeon. There's litigation about to start. Then we spoke to the family and compromised. Both happened to be my students.
Anyway, thanks a lot, sir. It was a wonderful, eye-opening session. Thanks all the speakers for this session, sir. Thank you.
Thank you, sir. Now I request Dr. Rajesh Kesavan to felicitate the speakers. Dr. Rajasabhabadi, sir. Dr. Nellayapar. Dr. Rajesh Kanaya. And to our moderator, Dr. Venkata Gopalakrishnan. Now we move on to the next session. I request Dr. Saravana Kumar to moderate the session. Please come to the dais, sir. The first speaker of the session will be Dr. Archana. She is joining in Zoom link.
Recording in progress.
Arvind.
Diabetic Foot and Wound Care Conference
Dr. Archana, are you ready?
Hello, everyone.
She is going to speak on toenail procedures for the foot
I'm
specialist.
extremely grateful to the Advanced Diabetic Foot and Wound Care Conference Organizing Committee, especially Dr. Rajesh Kesavan, for inviting me. Hello, everyone. I'm extremely grateful to the Advanced Diabetic Foot and Wound Care Conference Organizing Committee, especially Dr. Rajesh Kesavan, for inviting me to deliver this lecture on toenail procedures for the foot specialists. I have no financial disclosures to make and no conflict of interest, and I bring greetings from Nail Society of India. The learning objectives of this lecture are going to be to understand indications requiring procedural intervention, review procedures and their outcome, to recognize, manage complications, and how to ensure follow-up. The common toenail procedures that we often do are ingrown toenail or onychocryptosis, retronychia, pincer nail, traumatic nail dystrophy, subungual hematoma, onychogryphosis, acute paronychia, debridement of the dystrophic nail, and other tumor excision. I will be discussing only a few, 1 to 2 paucity of time. Before you go for any procedural intervention, it is very mandatory to know the nail unit anatomy and do complete pre-procedure evaluation such as history, examination, evaluate for comorbidities, especially diabetes mellitus, whether it is controlled or not controlled. Consent has to be taken, photographic and imaging, which is required in many disorders. You have to know about the anesthesia, since it's a painful procedure, which agent are you using, which technique are you using, and what are the safety considerations. A tourniquet is essential for most of the procedures to ensure bloodless field. You have to know your instruments, how to ensure asepsis, and what are the post-procedure instructions and follow-up. We know that nail unit anatomy has lateral nail fold, nail plate, lunula, proximal nail fold. Lunula is the visible part of the matrix. Now, it is very important to know where the matrix is. The proximal matrix is 3 to 4 mm proximal to the proximal nail fold, and this is a sacrosanct area, because if you mess up with this area, there is going to be a nail plate dystrophy. I have already told you the pre-op instructions about the patient should be counseled about the healing time, and these are the instruments we use. These are the nail plate splitter, nail plate elevator, hook to retract the proximal nail fold if required, if you find forceps, jeweler forceps, curved scissors. And I use 2% xylocaine. It gives a fairly good anesthesia for 45 minutes to up to 2 hours. And I often use adrenaline, but if you are very off or you're scared of using, then it's up to you. Local anesthesia is given by the proximal digital block. Mind you, it's not a ring block. It's a tuminescent anesthesia, and it is given at 2 points at the base of the big toe. So by using 26 gauge needle, so we inject 1.5 to 2 ml on either side. It has to be very slow, and we block the lateral digital nerves on either side. And this is by the pressure of the amount of xylocon that is injected. It's definitely a painful procedure to give anesthesia. So what are the tips for reducing pain? Talk to the patient. I call it talk anesthesia or vocal local, and this works in all age group. You can bring the LA bottle out of the fridge and keep it at room temperature. Use thin needle. There is no utility of applying amla cream, because this will ensure only that the prick is painless. But the diffusion, or when you inject local anesthesia 1.5 to 2 ml, the pain is not avoidable by use of amla cream. Post procedure, it is very important to know that the patient has to go back home in an appropriate footwear which will not hurt him. So V-shaped slipper is the ideal one. I often use antibiotics apart from, of course, caring for the sepsis during the procedures. For ingrown toenail and other things, I use broad spectrum antibiotics, analgesia, leg elevation to prevent swelling, pain, and help in hemostasis. The dressing is often changed after any procedure after 48 hours. Coming to the first ingrown toenail, which is a very common but very painful condition that significantly alters patients' quality of life, and it is usually seen more in men in second to third decade, involves big toenail, and it is usually unilateral but is often bilateral also. It occurs because of the wearing ill-fitting shoes with the narrow toe box, improper trimming of the nail. There are certain drugs which can lead to hypergranulation tissue, and often diabetics are more prone to get ingrown toenail because of the polyneuropathy and the impaired sight subsequent to retinopathy, which hinders the nail clipping adequately. So you can see that you should trim the nail only once they are out of the the pulp of the big toe, and not otherwise. So what is the sequence of event when you cut or trim the nail plate obliquely or in a semicircular fashion? It cuts through the lateral nail fold, inciting the foreign body reaction. This leads to cascade of inflammation, and there is lot of granulation tissue during the reparative process. The ingrown toenail has different grades of severity. Grade 1 when there is only slight erythema or swelling. Grade 2 when there is suppuration, and grade 3 is when there is lot of granulation tissue and hypertrophy. The principle of management is that we do address the primary problem by surgical method or conservative method and to prevent recurrence. So we have to do tell patients about the general measures. Medical management is reserved only for grade 1, and for grade 2 and 3 we go for partial nail avulsion with chemical matrixectomy. So my go-to medical or conservative method is strapping, which is very useful in grade 1, and if patient is regular for say about 3 months, its surgery can be avoided. Partial nail avulsion with selective lateral material destruction, which can be done with 88% phenol or 10% sodium hydroxide or 100% TCA, and all have similar efficacy, but 88% phenol scores because it is antiseptic, it is anesthetic, and I have the experience. We can also destroy lateral nail matrix with the carbon dioxide laser and radio frequency, which is less downtime. So this is a video of 2-minute video of how you, so once you have injected, you have to place the tourniquet. I use gauze piece tourniquet for the toenail. And see, I started distally and I went proximally. This causes exsanguination of the blood vessel, you know, emptying out of the blood vessel. And once you reach the base, you have to unroll the gauze from distal to proximal end and that tie at the base of the toe. So this will serve as a tourniquet because bloodless field is very important. Then you take the nail plate elevator, and on the side where the nail plate has to be lifted, it has to be done in a very, very controlled manner. Otherwise, if you do it very strongly, you tend to tear the nail plate from the nail bed up to 50% of it. And once you have separated it, you take the nail plate clipper and say clip around 2 to 3 millimeter of nail plate along with the lateral horn of the matrix. And once we have done it, it is very important to ensure with the forceps, fine forceps, that there is no remnant of the lateral horn of the nail matrix. After that, you have to phenolize it, and for that I have ready-made, I keep the cotton tipped applicator ready. You dip it in the phenol, you drain the excess phenol alongside the wall of the container and vigorously rub it for 20 seconds, 3 times, and you can see that I am tilting the side of the toenail medially, because so that the phenol does not diffuse to the other side and cause destruction of the nail matrix. So it is a very important tip to reduce the destruction of the matrix on the other side. This is the second time, and now the last time for 20 seconds. If there is hypertrophic granulation tissue, even that is also taken care, and it is very important to remove the excess of the phenol on the side of the bottle. So once it is done, you can see there is no blood at all. It's absolutely bloodless field, and once you have done it, you have to, your phenolization is complete, and you have to unpack the tourniquet, remove the tourniquet, keep the toe in anti-gravity position so there is hemostasis, and immediately you give a heavy, bulky, non-adherent dressing. So I use this thing, gauze piece, and lots of antibiotic that I place, and you give a bulky dressing so that there is no even if there is oozing, that is soaked, right? So this is the how you do the dressing part. I have shown you the post procedural foot care instruction. In grade 1, sometime if you need surgery, or grade 1 or grade 2. I also use radio frequency ablation of the lateral nail matrix. We know that it is there by the surface anatomy. It's a blind procedure. Even phenolization is a blind procedure. The only advantage is that the downtime is very less. So in 3 to 5 days, there is no oozing as compared to phenolization where the oozing can persist for up to 2 weeks. So this was the patient with grade 1 ingrown toenail, but it was very symptomatic. This was grade day 2 after the partial nail avulsion and RF ablation of the lateral horn of the matrix. This is day 7 and this is day 14. So there is definite reduction in the width of the nail plate by all these procedures. This was a patient where the orthopedic surgeon avulsed the nail plate for ingrown toenail twice, and there was a distal embedding, you can see. So I again used Dynaplast taping, and in 6 months time, it's a slow but it's a very rewarding process. Coming to retronychia, because it's an uncommon type of ingrown toenail, and where the nail starts growing proximally. And trauma is the most important predisposing factor. It presents as the triad of inflammation of the proximal nail fold, discoloration, or slow or absent nail plate growth. So there are multiple piled up nail plates which can be seen. As you can see, there is xanthonychia, yellow discoloration, piled up nail plates, and there is inflammation or tender proximal nail fold. The diagnosis is established on ultrasonography, where you can see multiple nail plates are there, and you have to remove the nail plates because they are loosely adherent. And once you remove all the nail plates, and you destroy the lateral horn of the nail matrix, and then the nail plate that moves forward. Coming to pincer nail, it often involves big toenails, maybe unilateral or bilateral, and are characterized by excessive curvature of the nail plate, impinging of both nail folds. And this is more pronounced distally. There are 3 types. Omega type, which is similar to the Greek letter omega. This is plicated type, and this is trumpet type because it pinches the nail bed distally. So there are 2 things happening. Number 1, there is broad nail plate, and number 2, there is narrow nail bed, and that leads to the formation of the pincer nail. So when we are addressing the treatment, we have to address both these parts. So the narrow nail plate, the nail plate is very wide, so we have to narrow the nail plate, and this is done by bilateral partial nail avulsion with chemical matrixectomy, as we do in the ingrown toenail. And the second thing is that we have to widen the nail bed, and which is done by avulsion of the distal 1/3 of the nail plate, and then you make a T-shaped inverted T-shaped incision, so there is widening of the nail bed. And this was a patient where I had to go for total nail avulsion because there was too much of fibrosis. Coming to onychogryphosis, this is characterized by hyperkeratosis and increased and distorted yellow-brown nail, which grows very much in length, and it resembles the ram's horn. It occurs in older adults, may cause pain. It has difficulty in putting on shoes, difficulty in ambulation, there's cosmetic concern, and of course psychological consequences. The trauma is the main inciting factor, but infections and compromised vasculature, as in diabetes mellitus, this can also predispose to pincer nail. And I have seen most of the cases of onychogryphosis in diabetics. The treatment is debridement, and to prevent further occurrence of the onychogryphosis, counseling for regular nail trimming and softening of the nail plate by using 10 to 20% of urea-based moisturizer can be done. So see, for this patient, I scraped the nail gently for so long, keeping the nail in saline soaks for quite a long time, for an hour or so. And then once it is done, you have to apply urea cream to make the nail plate soften and to prevent recurrence. Another important emergency is acute paronychia or acute traumatic subungual hematoma. You can see there is collection of pus in hematoma because of secondary to trauma. Will be collection of blood, and this is extremely painful condition. So what I do after giving proximal digital block, which is very important, I make 2 holes as you can see here with 2 mm punch and take out. And once the pus starts coming out, there is immediate relief in pain. So it is true for both hematoma, but it has to be a very, should not have been organized. So within very few minutes or say up to 2 hours of the injury, it can be done. If there is subacute hematoma, if there is acute traumatic subungual hematoma, it is very important to take X-ray beforehand to rule out any fracture, because if it is there, the pain is going to stay for much longer time. Another important foot condition is chronic traumatic subungual hematoma, and this presents as reddish black discoloration. And in this patient, it is very important to differentiate this discoloration whether it is blood or melanin, because if it is melanin, then we have to take a biopsy, and this can easily be done on dermatoscopy, where you see the blood is there and it is in different stages of resolution. Then debridement of the diseased nail is indicated in onychomycosis, because partial removal of the or the onychalized nail plate is very important. It decreases the fungal load. We are debulking the fungal load, and when we combine it with oral and topical antifungal treatment, the cure is much faster. So debridement of the diseased nail or onychalized nail plate is essential and important part of the foot care. And this you can see, this is dermatophytoma, and this was debrided, and this is the result with topical and systemic antifungal treatment. So the important learning points are that one should know about the nail unit anatomy very well. Try to retain as much as nail plate as possible for better surgical outcome. Ensure bloodless field while performing nail procedures. Use gauze or latex glove finger for the tourniquet. Don't forget to remove tourniquet after the surgery as early as possible. And all toenail condition may not require surgical intervention, right? So you have to identify the indications properly, evaluate, assess radiologically, investigations have to be done, and patient has to be counseled properly. Thank you very much for your kind attention. I again am grateful for the opportunity.
Thank you very much, Archana ma'am. It's really a wonderful lecture, because we normally come across such cases in our practice. It's really a wonderful lecture. Thank you very much, ma'am. Now I call upon Dr. K.R. Divya Vijayaraghavan to talk on skin disorders in diabetes.
A very good evening to everyone. Thank you so much for this greater opportunity. We have gone so deep into all these scientific sessions, so deep into the tissues and blood vessels and everything. Now let's lean back and let's come to the superficial part, the skin. Now, when we think of diabetes mellitus, we always think about the blood sugar control, neuropathy, nephropathy, retinopathy, all these. But sometimes the skin gets there first. In fact, the skin acts as a visible glucose monitor, quietly revealing clues long before complications become obvious. So today we will explore the cutaneous clues or cutaneous manifestations in diabetes mellitus, ranging from common findings to important diagnostic clues, and to discuss how recognizing these signs can help us identify the disease severity the metabolic control, and occasionally even undiagnosed diabetes. Because sometimes the skin doesn't just reflect disease, it announces it. Diabetes doesn't just affect sugar levels, it leaves fingerprints on the skin. Now, why is it so important to know about these cutaneous manifestations? 30 to 70% of patients with diabetes mellitus will present with a cutaneous complication at some point of time during their lifetime. These dermatological manifestations vary in severity from a simple infection that can be curable, benign, deforming, and even life-threatening situations. Some lesions may precede diabetes diagnosis way ahead. So these skin changes may provide insight into patients' glycemic control and may be the first sign of the metabolic derangement in undiagnosed patients. So recognizing and managing these conditions is very important in maximizing the quality of life and in avoiding serious adverse effects in patients with diabetes. So think of skin as the dashboard warning light of diabetes. Now, the cutaneous manifestations in diabetes can be broadly classified as skin manifestations strongly associated with diabetes, non-specific dermatological signs and symptoms, dermatological disease associated with diabetes, common skin infections in diabetes, and cutaneous changes associated with diabetic medications. The etiopathogenesis with these cutaneous complications or chronic hyperglycemia, because of which there is accumulation of advanced glycation end products, collagen cross-linking and reduced elasticity, microangiopathy leading on to thickened basement membranes, reduced tissue perfusion, neuropathy causing reduced sweating, xerosis, and later can also lead on to ulceration, immune dysfunction causing neutrophil dysfunction and increased infections, and insulin resistance causing growth factor stimulation and epidermal proliferation. Now coming on to the most important part, these diseases, the skin manifestations that are strongly associated with diabetes mellitus include acanthosis nigricans. This could be a first marker of insulin resistance well ahead of the diagnosis of the disease per se. Diabetic dermopathy, which is more common and sometimes pathognomonic of diabetes mellitus, necrobiosis lipodica, bullous diabeticorum, scleroderma diabeticorum, diabetic foot syndrome. We will see all these in detail, and some non-specific dermatological signs and symptoms include ichthyosiform changes, acquired perforating dermatosis, eruptive xanthomas, acrocordons, the simple skin tags, pruritus, Huntley's papules, keratosis pilaris, palmar erythema, periangual telangiectasia, yellow skin and nails, onychocryptosis. These are non-specific signs, but these can provide a variable clue regarding the glycemic control and the disease progression. Dermatological disease associated with diabetes mellitus could include psoriasis, lichen planus, vitiligo, hidradenitis suppurativa, generalized granuloma annulare, and even melanoma. Recurrent skin infections are very, very common. It can precede the diagnosis because of the poor glycemic control. It can also give us a clue about the insulin resistance. So repeated infections like folliculitis, recurrent furunculosis, appearances of carbuncle, cellulitis, all these can give us a clue towards the diagnosis of diabetes mellitus, or it can, in the course of the disease, it can give us a clue about the metabolic control of the disease. Another very important infection is fungal infection, where the patient may present with simple candidiasis like intertrigo of the toenails, or repeated vulvovaginal candidiasis in females and balanitis in male, where you have to treat, when we treat the disease, and because of the recurrences and sometimes very poor responses will make us think about an underlying and undiagnosed diabetes mellitus. Another specific fungal infection is superficial dermatophytosis. Superficial dermatophytosis these days are presenting as a very problematic condition and very severe condition, because previously, like a decade ago, when we see a case of superficial dermatophytosis, we used to find it as a very easy case of managing in our OPDs, because a 2-week course of a systemic or a topical antifungal can provide a beautiful clinical outcome. But because of the poor management of dermatophytosis, over-the-counter medications and undiagnosed underlying immunosuppression and uncontrolled diabetes has made a very simple case of a tinea corporis to present like this. When you see this case, the first thought, because of the intense, extensive involvement, scaling and severe itching, and almost this girl had almost 80% of the body surface area involvement. So we thought of just an erythroderma and an underlying psoriasis. But then after repeated inquiry, she was found to have type 1 diabetes mellitus, and then she had taken over-the-counter medication of applying topical steroid for so long that it has become a very complicated dermatophytosis. It was a very difficult condition, and this specific condition, superficial dermatophytosis, has become such a burden for us in our OPDs, and it is so prevalent that I would say there is a silent epidemic of fungal infections, fungal skin infections overall in our region. So when you in your OPD see any skin lesion, giving you a thought if it could be an eczema or a psoriasis or a fungal infection, you can stop whatever they are applying and don't jump to prescribe a topical steroid. Just go ahead with giving a topical fungal, antifungal. In case if it doesn't work, then think about the other prescriptions like giving a combination of topical steroids. If it works out well, you got the diagnosis of superficial dermatophytosis. There are certain insulin resistance markers like acanthosis nigricans, as I said earlier. It could be the first sign of an underlying undiagnosed diabetes. And a very simple skin tag. We call it a soft fibromas. It can present as a single or multiple grouped papules over intertriginous areas like commonly involved are neck, inframammary region, groins, inner thighs, sometimes even around the eyes. Of course, it can involve even the trunk too. But a single skin tag or a gradually progressing group of skin tag, just go ahead with investigating the patient. If everything is normal, go ahead. You can advise them for a management with a dermatologist. But if there is a cropping up of skin tag within a short span of time, like 3 to 6 months time, think about an underlying diabetes. Management is very simple, cryotherapy can be done, or simply radiofrequency or electrofulguration can be done. The amount of skin tags may correspond with an individual's risk of diabetes mellitus or insulin resistance. Now, coming to the most common presentation, acanthosis nigricans, it usually presents way ahead, like they can present in their second or third decade with this kind of hyperpigmented patches. They are usually asymptomatic, patient present with just for cosmetic reasons. We have to think about the future diabetes mellitus or insulin resistance underlying this skin condition. It presents with multiple poorly demarcated gray, dark, velvety appearance. We can actually see the velvety skin. In the histopathology, there is hyperkeratosis, epidermal papillomatosis with acanthosis. So the hyperpigmentation is definitely not due to melanin overproduction or melanocyte overactivity. It is because of the hyperkeratotic skin underlying. So that has to be treated with topical retinoids, salicylic acid with the combination of glycolic acid, keratolytics, peels like chemical peels with trichloroacetic acid, glycolic peels, and in some cases laser therapy also, and definitely not with steroid. If the patient presents with acanthosis nigricans in established diagnosis of diabetes mellitus, think about a poor glycemic underlying control, because on top of all these, if the glycemic control is not good, the response may not be very easy. Also, a complicated case or if it is not properly managed case or a personal hygiene is very poor, acanthosis nigricans can invite secondary bacterial infection leading on to carbuncles or even fetor and further spread of secondary bacterial infections. Diabetic dermopathy, also called as shin spots or pigmented pretibial patches, is the most common dermatological manifestation of diabetes. It is pathognomonic of diabetes. So it presents with smaller, well circumscribed round papules like this, and it gradually progresses to become a papule that heals with an atrophic brown macule that is atrophic in the center and leaves a typical hyperpigmented patch around the macule. So there will be multiple stages of presentation, like at one point of time there is different lesions at different stages of evolution. So this is one very typical patch of diabetic dermopathy. Commonly involved area, pretibial area, that's why it is called shin spots. Lateral malleoli, sometimes it can progress to involve thighs, forearm and even trunks in later cases. Usually asymptomatic. Here, the diagnosis is clinical because we should not just jump to do a skin biopsy and find out the reason here, because first thing is, if the glycemic control is poor, the wound healing will also be delayed. Second, histopathology will not give us a exact clinical pattern in the histopathological side, giving us the diagnosis of diabetic dermopathy. So usually diagnosis is clinical also, with very little treatment, like topical steroids, emollients and little bit of antibiotic if at all needed. It will give us a very greater clinical outcome, but the patient has to be followed rigorously for further complications. Diabetic foot syndrome, it encompasses the neuropathic and vasculopathic complications that develop in the feet of patients with diabetes mellitus. It is a significant cause of morbidity, mortality, hospitalization and reduction in the quality of life of patients with diabetes. Initially, it can simply present with dry skin or callosities or rough patches where the skin is peeling. All those will be initial presentation. Careful monitoring, investigations can give us a clue to a diabetic foot syndrome, because later it can develop into chronic ulcers, secondary infections in the later stages. The ulcers are because of neuropathy, ischemia or mixed. Neuropathic ulcers are more common, and areas prone to trauma are being involved. The skin of these patients are also more prone to get secondary bacterial and fungal infections. Secondary bacterial infection can lead on to serious complications. And another associated finding here is erythromelalgia, where the patient will present with redness, warmth, burning pain in the lower extremities. So apart from glycemic control, appropriate wound care is very, very important, along with proper footwear. So with these management, hydrogels, hyperbaric oxygen therapy, topical growth factors and biofabricated skin grafts play a key role in the management of DFS. Scleroderma-like changes. This is usually painless, indurated, waxy, thick skin, which slowly progresses to involve the other areas. To start with, it affects the acral areas, like to start with, it involves the fingers, dorsum of the fingers, proximal IP and metacarpophalangeal joints. Later, it can involve further go proximally also. Severe diseases may extend centrally to involve the arms and trunk also. As it progresses, it can lead on to limited joint mobility as a complication, where you typically see that thick, indurated, waxy skin, and the mobility of the distal joints are restricted so much. We can ask them to do a prayer sign, and this is what we see. In such stage of presentation, there is very limited therapeutic options, but physical therapy and glycemic control can help a little bit in improving the quality of life. Scleroderma diabeticorum, it's a little bit different entity where this also presents with gradually worsening thickened indurated skin, but the area of involvement here is upper back, shoulders, back of neck. Here, distal extremities are typically spared. In extreme cases, they can be complicated with restrictive respiratory problems also. Here, phototherapy becomes the primary line of management. Apart from this, second line, we can think about giving a methotrexate, cyclosporin, and intravenous immunoglobulins too. Necrobiosis lipoidica is yet another strongly associated cutaneous manifestation where there is firm, well-demarcated erythematous papules that can progress to become plaques with yellow atrophic centers. It can present as a very small papule also involving a very large area, can present as a chronic ulcer. Typically, pretibial area of lower extremities are involved. Corticosteroids in the form of ointments, orally, intralesionally also can be considered. Appropriate wound care is very, very important in necrobiosis lipoidica. Bullous diabeticorum, here there is sudden appearance of spontaneous painless blisters. Hands, feet and legs are commonly involved. It may resolve without any treatment also, but here we have to be very careful in not deroofing the blisters. We have to prescribe topical antibiotics. In case needed, we can give systemic antibiotics, but don't open the blister or induce an ulcer here. Other changes include ichthyosiform skin changes where larger areas of dryness and scaling appear. Typically anterior shins, hands and feet are involved. Emollients, sometimes with keratolytics, are the key management strategies here. Xerosis, very similar, abnormally dry skin can present with scaling and fissures. Emollients are the primary line of management here. Acquired perforating dermatosis, it's a chronic skin disorder with loss of dermal connective tissue. Here there is typically hyperkeratotic umbilicated keratin centralized plugs are there. The patient can tell us that I can plug out one small keratin plug or a black colored plug like thing I'm able to plug out from each center of the lesion. So extensor surfaces of the arms and legs are involved, extremely pruritic, and the new lesions appear in lines of trauma. It typically also leaves hyperpigmentation as it heals. Topical steroids with emollients, keratolytics and antihistamines are mainstay of management here. Pruritus, simply they will present with severe itching, skin will be normal, sometimes may be dry also. Only sign what we can see is excoriation marks here. We have to think about poor glycemic control. Topical calamine, sometimes emollients and very low potent steroids can be prescribed here along with antihistamines. Also consider topical capsaicin and topical ketamine here along with antihistamines. Now, cutaneous changes associated with diabetic medications include insulin-induced lipohypertrophy and lipoatrophy also. So, localized adipocyte hypertrophy and can present as soft dermal nodules. It usually improves over the course. Lipoatrophy can also be present, like localized areas of atrophic patches will be there. It presents as round concave areas of adipose tissue. Usually it is very, very, very rare. And allergic reaction to insulin can be seen. This is also a very rare condition. We have also seen certain cases of erythema multiforme, urticaria, angioedema, photosensitivity, drug-induced pruritus, fixed drug eruption, sweet syndrome with oral medications of diabetes. So, examining a lower limb is very, very important for every diabetologist. Look for shin spots, xerosis, fissures, calluses, nail dystrophy, a simple fungal infection, a small papule or a nodule that can lead on to ulcers. So, inspection of the feet is very critical. So, 1 minute of looking may save years of wound care. Of course, as many of the seniors and other speakers have told, management of diabetes is interdisciplinary management. Here, dermatologists play a vital role by diagnosing can help in diagnosing the disease early, can identify insulin resistance with certain markers. So examining and preventing of later complications by examining the skin improves the quality of life of patients. So the key points: skin findings can predict systemic disease severity, low limb manifestations are clinically significant, so early diagnosis prevents morbidity, sometimes even mortality. Dermatologists play a vital role in diabetic care. Patient education and lifestyle changes are the key points in improving the health and quality of life with diabetes mellitus. Thank you all. Thank you so much for the patient listening for the last session of the day. Thank you so much.
Thank you very much, ma'am. It's really, for the practitioners, it will be very, very useful. Thank you very much. Now, kindly stay for the musical extravaganza by 7 o'clock. Please stay with us.
Sir,
Yeah, I have few questions. Ma'am, Archana ma'am, are you available to clear our doubts?
Yeah.
Ma'am, is it
Yes,
audible?
I'm here. Yes, I'm here.
Yeah, I have one question. One delegate has asked the frequency you have told 20 seconds, 3 times finalization. What is the gap we should give for every 20 seconds?
No gap is required. You just drop in one, the applicator and pick up the another one. That is the gap.
Okay, thank you. And another question, this is from my, I am asking as a podiatric surgeon, I come across this recurrent ingrowing toenail. Sometimes for recurrent ingrowing toenail with infection, I do excise the one part of the nail plate along with the nail fold, lateral nail fold, and I do excise more of that nail fold. And what do you think, in such a way I prevent recurrences as more scarring in that area, and thereby the nail plate surpasses the soft tissue around? What's your thought on that?
Actually, there are 2 ways you can see the etiopathogenesis. Either there are overhanging nail folds, or there is broad nail plate or nail matrix, which is giving rising to a broader nail plate, and that is, insinuating in the surrounding lateral nail folds. So you have to judge, and if there is overhanging hypergranulation tissue, that is usually taken care of when you are doing phenolization, because phenolization is not happening only at the lateral end of the matrix, right? Lateral horn of the matrix.
Yeah.
Because we are going through the lateral nail fold, or we are going through the passage that we have created after removal of the 2 to 3 mm of the nail plate.
Yes.
So that will also take care of. Generally, I have, in my experience, unless and until there are, there are certain congenital abnormalities on the toenails with overhanging nail folds, the excision of nail fold is not required.
Thank you very much, ma'am. You have more experience than us. Thank you very much.
Welcome. And thank you for having me.
So,
You are welcome, ma'am.
thank you, Doctor. Now I request Dr. Saravana Kumar to felicitate Dr. Divya. Dear delegates, please join the music, a unique fusion of music and medicine by Vivek Nair, followed by dinner. Thank you all for your participation.
9 rupees won't even buy you a samosa. But what if I tell you 9 rupees can automate 95% of your work? What if I tell you 9 rupees can make you irreplaceable in the job market? And what if I tell you 9 rupees can give you that salary hike that you always...
Check. Good evening all. பிடிச்சிருக்கா எல்லாருக்குமே பிடிச்சிருக்கா? ஒரு நல்ல கைத்தட்டல் கொடுங்க. ஓகே, நெக்ஸ்ட் சாங் வந்து ஒரு ஹிந்தி சாங். எல்லாருக்குமே பிடிக்குமா? ஓகே, ஜாயின் பண்ண முடியுமா? உங்களுக்கு ஜாயின் பண்ண முடியுமா? பாட தெரிஞ்சவரா இருக்கா? ஏதாவது பாட்டு தெரிஞ்சவர் இருக்கா? உங்களுக்கும் ஜாயின் பண்ணலாம் என் கூட. நெக்ஸ்ட் ஒரு ஹிந்தி சாங் போகலாம். சாருக்கு தெரியுமா? வாங்க சார், கம் ப்ளீஸ். ஹிந்தி பாட்டு பாட மாட்டார். ஓகே, ஒரு செஷனில் நமக்கு ஜாயின் பண்ணலாம். இப்போ ஒரு ஹிந்தி பாட்டு பாடலாம். உங்களுக்கு பிடிச்சிருந்தா நல்ல கைத்தல் கொண்டு நல்லா சப்போர்ட் பண்ணாங்க. நமக்கு எல்லாருக்குமே சேர்ந்து இந்த ஒரு ஷோ ஒரு சக்ஸஸாக போகலாம். ஓகே, தேங்க்யூ சார், தேங்க்யூ ஸோ மச். Thank you so much. Thank you. இங்கே வந்து பாடலாமே. Come, please come. Check. மேம் நல்லாவே பாடிட்டாங்க, சூப்பர்.
नीले नीले अंबर पर चांद जब छाए तो तरसाते तो हमको तरसाए। ऐसा कोई साथी हो, ऐसा कोई प्रेमी हो, प्यास दिल की बुझा जाए। नीले नीले अंबर पर चांद जब छाए और बरसाए हमको तरसाए। ऐसा कोई साथी हो, ऐसा कोई प्रेमी हो, प्यास दिल की बुझा जाए। नीले नीले अंबर।
Thank you so much. Thank you, sir. Sir, check. 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 Hello, check. Hello, check. கொஞ்சம் லெவல் கூடி போனுங்க மோட்டர்ல. ஹலோ. एकदम
ये दोस्ती हम नहीं तोड़ेंगे दम मगर तेरा साथ ना छोड़ेंगे। दोस्ती हम नहीं तोड़ेंगे दम मगर तेरा साथ ना छोड़ेंगे। ये दोस्ती हम नहीं तोड़ेंगे दम मगर तेरा साथ ना छोड़ेंगे। मेरी जीत तेरी हार मेरी यार सुन मेरे यार। तेरा गम मेरी जान तेरी जान ऐसा अपना प्यार। जान पे भी खेलेंगे तेरे लिए ले लेंगे। जान पे भी खेलेंगे तेरे लिए ले लेंगे। सबसे दुश्मनी हम नहीं तोड़ेंगे दम मगर तेरा साथ ना छोड़ेंगे। हम नहीं तोड़ेंगे दम मगर सबका साथ ना
நயனர் சாருக்கு ஒரு சத்தமான கைத்தல் கொடுங்க சார். சூப்பர். That's what awesome. Thank you. இங்கே லவ்வர்ஸ் இருக்கீங்களா? எல்லாருமே லவ்வர்ஸ் தாங்க. சார் லவ் பண்ணதா?
புது வெள்ளை மழை இந்த பொழிகின்றது, இந்த கொள்ளை நிலாவுகள் நனைகின்றது, இந்த சொல்லாத இனம் கூட குளிர்கின்றது, இந்த சொல்லாத இனம் கூட குளிர்கின்றது. அழகின்ற வேளையில் உயிர் பூ அடுக்கெந்து மலரும் நீ பெடுகின்ற ஓடினார் உயிர்ப்பு சருகாக உலரும் இது கைகள் தீண்டாத பெண்மையை உன் கண்கள் பாதோடு மலரும்.
Thank you, sir. Thank you so much. டான்ஸ் ஆடலாமா? வாங்க அங்கே இந்த ஃப்ரண்ட்ல வாங்க. எல்லாருமே வாங்க. பாடுவாங்களா? இந்த சாங் ஸ்டார்ட் பண்ணும்போது தெரிஞ்ச சாங் தான் வந்து ஜாயின் பண்ண. ஓகே ஓகே.
செவப்பு இல்லை, கணுக்கால் கூட கருப்பு இல்லை. நீ தீண்டும் இடம் தித்திக்குமே, இனி பாக்கி உடம்பு செய்ய வேண்டும் பாக்கியமே. குறுக்கு சிறுத்தவளே, என்ன குங்குமத்தில் கரைச்சவளே, நெஞ்சில் மஞ்சள் தேய்ச்சி குளிக்கையில் என்ன கொஞ்சம் பூசு தாயே. ஒரு சுத்தமணியா என்ன கொஞ்சம் மாத்து தாயே. ஒரு தடவை இழுத்து அணைச்சபடி உயிர் மூச்ச நிறுத்து கண்மணியே. மழையடிக்கும் சிறு பேச்சு, வெயிலடிக்கும் ஒரு பாதை, உடம்பு மண்ணில் புதையிற வரையில் உடன் வரக்கூடும். நோட இருக்கையில் நீ மண்ணோட போவதையே, அடவும் ஜீவனில் நான் இல்லையா, கொல்ல வந்த மரணம் கூட குழம்புமையா. பொருட்டு சிறுத்தவளே, என்ன குங்குமத்தில் கரைச்சவளே, நெஞ்சில் மஞ்சள் தேய்ச்சி குளிக்கை என்ன கொஞ்சம் பூசாயே. உங்களோட சுத்தமணியா என்ன கொஞ்சம் Thank you.
Oh, super. Thanks so much. எக்ஸ்கியூஸ் மீ, எப்படி போயிட்டு இருக்கு? ஓகே தானே? ஒரு நல்ல கைத்தட்டல் கொடுங்க.
Check. போனா ஜூலை காற்றே கண் பார்த்தா காதல் காற்றே பூ பூத்தா தேன் வருமே பெண் பார்த்தா நீ வருமே என்னாச்சு தோணலியே ஏதாச்சு தெரியலையே நட்பாச்சு லவ் இல்லையே லவ் ஆச்சு நட்பில்லையே வெற்றி என்பதும் கையில் இல்லை நாளை என்பதும் பையில் இல்லை இன்று மட்டுமே நெஞ்சில் மிச்சம் உண்டு தோளா முத்த கூத்துகள் யாருக்காக மொத்த பூமியும் கூத்துக்காகத்தான் அன்பே வெற்றி என்பதும் கையில் இல்லை நாளை என்பதும் பையில் இல்லை இன்று மட்டுமே நெஞ்சில் மிச்சம் உண்டு தோளா மொத்த கூத்துகள் யாருக்காக மொத்த பூமியும் கூத்துக்காகத்தான் அன்பே போனா ஜூலை காற்றே கண் பார்த்தா காதல் காற்றே பூத்தா தேன் வருமே பெண் பார்த்தா தீ வருமே ஓ ஓ ஓ ஓ ஓ ஓ ஓ yeah oh my God. அறைக்குள்ளே மழை வருமா வெளியே வா குதூகலமா இந்த பூமி பந்து எங்கள் கூடை பந்து அந்த வானம் வந்து கூடை செய்த நின்று கரை இருக்கும் நிலவை சாதனை செய் சிறை இருக்கும் மனங்களை பலவை செய் இந்த மலர்களும் கண்ணீர் சிந்தி கண்டதில்லை போனா ஜூலை காற்றே கண் பார்த்தா காதல் காற்றே பூத்தா தேன் வருமே பெண் பார்த்தா தீ வருமே நாட்டு தோணலையே ஏதாச்சு தெரியலையே நட்பாச்சு லவ் இல்லையே பாச்சு நட்பில்லையே என்பது கையில் இல்லை நாளை என்பது இருப்போமா வெளிப்படையாய் சிரிப்போமா மலக்குடையாய் சிற்பி வீரர்களும் சிலை செய்துமே பெண்ணின் விழிகளும் நம்மை செதுக்குமே ரொம்ப காதலை இந்த பூமி கண்டிருக்கும் பல மாற்றங்கள் வந்து வந்து போயிருக்கும் இந்த உலகத்தில் எவருமே இது போனா ஜூலை காற்றே பார்த்தா காதல் காற்றே பூத்தா தேன் வருமே பின் பார்த்தா தீ வருமே என்னாச்சு தோணலியே ஏதாச்சு தெரியலையே நட்பா